And we're grateful this time also to have the best faculty. And of course, this is a virtual meet and a physical meet. The physical meet members are restricted because of COVID, but it is screened all over. We have the best faculty. The faculty will be introduced by the concerned moderators of the particular sessions. And I must say here that this trauma course has been the brainchild of Dr. Chandrasekhar, the president of the KOA, and Dr. Satish, the chief organizer. So with these few words, I request Dr. Satish and Dr. Madan Ballal to carry on with the further proceedings. Thank you.
Our first talk is today on spectrum of meniscal tears in arthritic knees, strategies and management by Dr. Elmar. I'd like to introduce
from Germany.
Sir, I'll give a brief introduction about you.
Yes.
So then you can start off. So Dr. Elmar, he completed his PhD in musculoskeletal sciences at the Medical University Innsbruck, Austria. And he did a research fellowship focusing on anterolateral complex of the knee and the influence of posterior tibial slope and meniscus tears on knee kinematics at the University of Pittsburgh, USA, with Professor Freddie Fu and Professor Volko Musa. His main scientific interests are on rotatory knee instability, knee anatomy, knee biomechanics, and knee kinematics, with special emphasis on lower limb alignment represented in several related publications. Dr. Elmar is currently working at the Department of Trauma, Hand and Reconstructive Surgery at the University of Hospital of Münster, Germany. Before moving to Münster, he did his training sports medicine at the Department of Orthopaedic Sports Medicine at the Technical University, Munich, Germany, under Professor Imhoff. Now I request Dr. Elmar to continue with this presentation.
Yeah, good morning. Sorry for interrupting you. So we start with the first talk on meniscal tears in more or less arthritic knees. So thank you for inviting me. It's a big honor for me to be part of your trauma meeting. So why do we even need to talk about meniscus repair? So this is an image of a fairly young former football player. And you see on the left-hand side, his meniscus torn. He had a little bit of cartilage degeneration already here, grade 2. But 6 years after a complete meniscectomy, you can see what happened to his knee. So there is no cartilage left. He has osteoarthritis, and we want to prevent this actually. And that's why we have to talk about it. We all know, or you know, that the menisci are important structures to transmit load through the knee joint, so especially close to extension, and in that case they act like a shock absorber. And most interestingly, the compressive load that are acting on the knee joint are transformed into circumferential tensile hoop stress, which provides also stability to the joint despite nutrition and proprioception. And as we all know, the knee is not really congruent, and what the menisci do, they kind of fill this incongruency, as you can see here, and they extend the tibiofemoral contact area by therefore decreasing the transmitted load. So what happens if we have to remove one of the menisci? So this is a graph showing on the very right-hand side what happens if we actually remove the meniscus. So if we have, for example, meniscal root tear, which we commonly see in osteoarthritic knees, it equals a complete meniscectomy. So and the load increases exponentially, and then osteoarthritis will progress rapidly. So we have to avoid these. And many years ago, everyone was saying, okay, if you have a medial meniscus root tear in arthritic knees, don't repair it, just leave it alone. But we know it's a bad idea, actually, but we come back to that later. So, and what are the risk factors when facing a meniscus tear with regards to progression to osteoarthritis? And actually, if we have signs of meniscus extrusion on MRI or even ultrasound, or if we have complete radial tears or complex tears, the likelihood of early onset osteoarthritis is pretty high. So the question now is, what are the perfect indications for meniscus repair? As we know, the tissue quality sometimes is not as good as we wanted to have it. So we need to find the right patient for our treatment. And ideally, we have all young soccer players, but as we know, there's a lot of diversity. And we have some skinny people, we have people with a higher BMI, we have tall people, we have short people, we have women, we have male. So we have to face all these facts. And the question is now how to do it clinically. And we have to look at all these factors. So there are many factors we have to look at when repairing a meniscus. And the most important thing is, when looking at literature or even in clinic, don't compare apples with oranges. You can do it as shown in this study, but it's not a good idea. So let's start with age. Usually everyone is saying age is a contraindication for a meniscus repair, as we know that the tissue quality is basically deteriorating, the content of water within the meniscus is going down, and even the vascularity is limited in elderly people. So the meniscus repair won't heal. That's what everyone is saying. But let's see what happens if we do actually repair in people with moderate osteoarthritis in their 40s, 50s, and 60s. And actually, there's a systematic reviews who looked at partial meniscectomy, and of course, there was no significant difference. But what happens if we repair it actually? And this is what you can see: 87% success rate if you do a meniscus repair in patients between 40 and 60 years of age. So this is a number. 87% success rate is good. And so whenever we are facing patients with meniscus tears, we shouldn't really look only at the age, but look at their demands. Are they active? How are they biologically? Are they biologically younger or older? So if they are younger, we should, if possible, aim for a meniscus repair. And in fact, this study here, it's easy to summarize. So if you look at different age groups between 25 and 40 and so on, there's no significant influence on patient-reported outcomes. So the age, at least until the age of 50, has no significant influence. So what about the BMI and the lifestyle of and habits of the patients? So there are conflicting results with regards to the BMI. However, the higher the BMI, the higher the transmitted load through the joint. And so we should avoid any excess loading to a meniscus repair. So we don't recommend doing any meniscus repair in patients with a BMI above 30. And as we all know, smoking habits reduce the capability to a tissue to heal. So even look at this. So don't try to do a meniscus repair in patients in their 40s that are smoking. It won't work. So what about their location? We know that the blood supply is decreasing from the periphery, so the capsule, to the inner part of the joint. But is it really important? And I would say no, not really. So of course, the success rate of a meniscus repair is higher the closer that there is to the capsule. However, we also have in this middle age group, so in their 40s, we have a fairly high success rate, even if we perform a repair in the red-white zone. So I wouldn't only consider doing a repair in the red zone. And so It's more, as said before, look at the age of the patient, look at their biology, look on their smoking habits. It's more important than actually their location. So this is now most important because we know in degenerative knees, and there are some tear types that are commonly seen. For example, tears that we face actually clinically. We know that when you are having a radial tear, it equals a complete meniscectomy. So it will change the kinematics, it will change the contact forces, even if the tears are small. But if the tears are basically going through the meniscus, you have to repair it to avoid any early onset osteoarthritis. So how do we treat these patients? This is one example. We can do a side-by-side repair if it's possible, but frequently, for example, on radial tears that are close to the posterior meniscal root, so it's not possible to perform a good root repair. So in these cases, we do a transtibial pullout repair whenever possible. Of course, even if the tear extends into the compartment. So if the tear is short, we move our bone socket, our bone tunnel a little bit more medially, and that helps us to at least prevent or preserve as much tissue as possible. So whenever we face a meniscal root tear on the medial side, even in a moderate osteoarthritis, we go for a transtibial pull-out repair. We don't do it in end-stage osteoarthritis, of course. So what about the horizontal cleavage tears that we see on almost every patient in their 40s or 50s? We know that these tears don't really affect our kinematics and our contact pressures. However, if we have very huge tears extending from anterior to posterior that we rarely see, we know that also the contact pressure could be affected, but I don't think it's clinically relevant. But what about chronic tears or degenerative tears? We know that the earlier we do a repair, the better it is for the outcome of the patients. However, time is not a exclusion criterion for a repair. So even if it's chronic tears that are at least 2 or 3 months old, we try to repair it. However, we need to enhance the biology. So what you can do, for example, a microfracturing in the intercondylar notch to kind of mobilize some stem cells or precursor cells. You can go in with a small rasp and try to rasp on your synovium, and just to mobilize some cells and to induce some bleeding, actually. Most important thing is stability and alignment, in my opinion, especially in patients with moderate osteoarthritis. So we know that the menisci help to stabilize the knees. So for AP translation, the medial meniscus is important. For rotatory instability, the lateral meniscus is important. So whenever you're facing an unstable knee with a meniscus tear, it's useless to do a repair on the meniscus if you don't fix your ligaments. It won't heal. It's simple. So, but what to do with patients that have a mild varus, for example, 5 or 6 degrees? If you are facing patients with early osteoarthritis or moderate osteoarthritis with meniscus-related symptoms, I recommend you to perform a long leg standing radiograph to look at the axis, because the patients won't do well if you just do some sort of meniscus repair or debridement whatsoever, if you're not really correcting their malalignment. So we always look at the coronal alignment. If the patient have excess varus or valgus alignment, we highly recommend to realign first the leg before the meniscus is repaired or debrided. So when we now look on our patients between 50 and 90 years of age, about 45% or even more have evidence for a meniscus injury if they are if they go to have an MRI. However, only 1/3 of them really have symptoms. So the question is, do we really treat meniscus tears in this age group with moderate osteoarthritis? And that's what evidence is saying is no. So there is no indication to perform just a meniscus debridement in degenerative meniscus tears in subjects with early and moderate osteoarthritis. However, when reading the articles carefully, there are some points that should be considered. So, first of all, what were their indications for treatment? And their indications usually are based on MRI. The authors of these articles, they didn't look on symptoms like locking, effusion, pain, and so on. They just looked at the MRI and defined, okay, physical therapy or operative treatment, and they found no significant difference. But when following the patients longer, about half of the patients got subsequent meniscus surgery after they opted for a initial conservative treatment. So follow your patients and you will see that many of these that are symptomatic need actually a meniscus injury. However, we need to have kind of a guideline. And this is the ESCA consensus meeting that we published a couple of years ago. And in fact, whenever you're facing patients with early and moderate osteoarthritis in their 40s and 50s, and if they are present with meniscus related symptoms, just leave the meniscus alone. Treat them conservatively, proper physical therapy, motion training. You can, the most important thing is to keep the patients active. If your conservative treatment fails after 3 to 4 months, you can opt for a surgical treatment like debridement and so on. However, whenever facing patients with meniscus injuries or meniscus symptoms, look on symptoms like locking and effusion. If the patient continued to suffer from locking periods, I would opt for early surgery. If they don't have any locking, I wouldn't opt for any surgery at all. So what's the ideal indication? The best patient has no meniscus tear, which is not realistic, as we know that half of us have already meniscus tears. So in the early phases or traumatic cases, we need to save the meniscus and we need to fix what is torn, regardless the age, regardless the degeneration status of the knee, at least if it's not an end stage osteoarthritis. In degenerative knees, in osteoarthritis knees, look at mechanical symptoms. Pain is not a strong indicator, but also look at the lower limb. The most important thing is looking at the lower limb to realign the patients if they have symptoms. The patient would benefit the most from the realignment surgery rather than meniscus surgery. So thank you very much.
That was an excellent presentation, Dr. Elmar. Now the talk is open for discussion. Any questions from the floor?
Hello. Dr. Elmar, there is one question from the delegate. Do we ever repair a white zone? And in general, what is your non-weight bearing protocol?
Yeah, so it depends. In the white zone, I don't do any repair. It doesn't make any sense. In the red-white zone, we always do repair. It doesn't matter. If we have a radial tear, so not a root repair, but a radial tear that we repaired, we recommend to do non-weight bearing for 6 weeks. If you repair a vertical tear, you can do partial weight bearing for 6 weeks. On the medial meniscus, you can do passive range of motion exercises between 0 and 90 degrees of flexion by avoiding deep flexion for at least 3 months post-operatively, regardless the age of the patients. On the lateral meniscus, we are more conservative with range of motion exercises. So we recommend doing a range of motion only between 0 and 60 degrees for the first 6 postoperative weeks.
One more question, Dr. Elmar. In a root repair, whenever you repair the root, the extrusion of the meniscus, does it come back to place, or is there any technique to get back the meniscus onto the condyle?
Yes, that's actually a good question, and we are looking at it. So we always think to go back and to take the meniscus back, and actually in the degenerative menisci, many times it doesn't work. It just works if you follow the patient shortly. So if you look at them after 1 year, the meniscus is many times extruded. It's not as much out of the joint as preoperatively, but it will never get back to the physiologic position. What you can do in young patients with root repair, with extensive extrusion, we sometimes do a mini open repair of the meniscotibial ligament on the medial side, the coronary ligament, by placing 2 or 3 sutures in there. It helps to take the meniscus in place. But it's also associated with more pain in the early postoperative period.
One more question, Dr. Elmar. During HTO, do you do arthroscopy as stage 1?
Yes, always. So before starting with the HTO, we always do a arthroscopy. We clean the joint. We treat some small meniscus tears. We do some debridement, and for especially we look at our indication. We look again on how the cartilage status is in the lateral compartment, for example, because that drives us to then to decide whether to overcorrect the patient or not. For example, we never aim automatically to the Fujisawa point, because in our hands it's too much. Going to 62.5%, even if the patient has some following arthroplasty. So we usually correct to 55 to 60% if the patient have really really bad cartilage on the medial side and good cartilage on the lateral side. But usually we don't go further than 55%.
Thank you, Dr. Elmar. Let's move on to the next talk.
Yeah.
This talk is on anterolateral rotatory knee instability by Dr. Elmar.
So, thank you. So, anterolateral rotatory instability. We have heard a lot about this during the last couple of years, and so I hope to shed some light in this area. So what is anterolateral rotatory instability? In the normal knee, we have the center of rotation on the medial spine, and the knee rotates like this. If we tear our ACL, our center of rotation moves further medially, and the lateral compartment gets a larger lever arm and rotates and translates more. But we know when facing anterolateral rotatory instability tested by the pivot shift, that not every pivot shift is the same. As you can see here, we have a grade 1 pivot shift versus a grade 3 pivot shift. And so these are different patients with different instability patterns, and we need to treat them differently. There's no not one single option to treat these patients. And this has been shown already many years ago, 20 years ago, but nobody recognized it, shown by Andrew Amis. And he showed in his 10 cases that the instability pattern after an ACL injury varies largely amongst the different specimen or subjects. However, we also know if the patient has a positive pivot shift after ACL reconstruction, it correlates with our patient-reported outcomes. And to prevent from osteoarthritis, we aim to at least recreate physiologic knee laxity. And even if we are good with our ACL, at least 10 to 15% of our patients suffer from a persistent pivot shift or symptomatic instability. And therefore, in 2013, Stephen Claes presented this study in all media about the new ligament, the ALL, and everyone was happy because everyone had now an explanation to treat patients with anterolateral rotatory instability. However, if you look at all the following articles on the anatomy, you can see that the ALL, the so-called ALL, is differently amongst the different publications. So whenever something is that variable in size, in shape, in their location, it cannot be a real consistent anatomic structure. And in fact, we sat together in 2019 in Watford, London, with an international consensus group. It was about 15 surgeons led by Al Gatket and Charlie Brown. And we defined that the ALL is a structure within the capsule. So it's a capsular structure. It's not a distinct ligament, but it's a capsular structure. And instead of talking about the anterolateral ligament, we should start talking about the anterolateral complex, because there's much more than just one ligament. We have the iliotibial band with its superficial and deep fibers, and we have the ALL and the capsule. And in fact, we looked at this in our study published in OJSM and KSSTA. And you have a first layer, the really dense iliotibial band. Everyone knows that if you reflect the iliotibial band, you have some distinct Kaplan fibers here shown as KF, and the deep iliotibial band. And this has been described already in 1958 by Kaplan, in fact. So this is not new at all. We just neglected anatomy for 70 years, basically. If we go one layer deeper to the capsule, there's just a capsule. There's no distinct ligament. However, on the right image here with the black triangle, you see a structure. And this is the capsular osseous layer of the iliotibial band. And this could have been described as ALL. But again, everything was known. It's not new at all. And this is an important fact. We also defined that the ALL, or capsular osseous layer, or how you want to call it, has attachment to the lateral meniscus. And if you look here, this is basically the coronary ligament. And I think it's important to keep these attachments intact, especially when you're facing, for example, patients with a complex lateral meniscus injury. The question is now, why are our ACLs not perfect? Why do some patients continue to have a persistent anterolateral rotatory instability? And if you look at these in vivo kinematics data, this is the physiologic knee. So this is the green line is the physiologic kinematics in a healthy knee. If you do a transtibial ACL reconstruction, commonly seen, or even a malplaced ACL, you see that the knees are rotated more internally. So the kinematics are not physiologic, they are pathologic. If you do a anatomic or close to anatomic ACL, you get very close to normal. Not always, not in every case, but you are very likely to hit the right spot. Whereas a non-anatomic ACL reconstruction is the biggest factor affecting anterolateral rotatory knee instability. So going back to the anterolateral ligament, and this was the first robotic study published in HSM 215 by Parsons. And they said, well, look at this. This is the contribution of the anterolateral ligament to prevent from a pivot shift. And they said, well, the contribution went up to 40–50%, which is enormous. So it was the explanation for the pivot shift. And in fact, in their clinical relevance in the abstract, they said that the ALL must be associated with a pivot shift. And if patients have a pivot shift, look or watch out for a ALL injury. But again, looking at our anatomy, there's no such clear thing as the ALL. And understanding the pivot shift, we know that the pivot shift does not persist or is not present at 60 degrees of knee flexion, but it happens during the first 30 to 40 degrees of knee flexion. And if you look here at, for example, 30 degrees of flexion, you have about 30% of contribution of the anterolateral ligament. So there must be other structures influencing the pivot shift. And then the next question is, when looking at all these high-ranked papers in very renowned surgeons, you need to look not only at the graph saying, okay, there are many many asterisks indicating statistical significance. But look here on the graphs. This is degrees, one degree difference. So if you look here at for example, 0 degree, there's 1.5 degrees difference in rotation on a cadaveric knee, not even on a healthy knee. Here, the largest difference here at 30 degrees of flexion, it's not even 3 degrees, so not even 4 degrees. So the question is this instability really clinically important, or is it just statistically significant? So just look at the graphs. And the next question is, and this is a study from HSS in New York, and it's an important study. They looked, when is the ALL important? Because they found that the ALL itself has just a minor role, 10 to 15%. And in fact, they looked, when does the ALL become taut? And they found you need to translate your tibia anteriorly by 15 to 20 millimeter to have the ALL functioning properly. And look at the image of Stephen Claes again. Here, the ALL is taut. Why? Because the tibia is subluxated anteriorly. So no knee is present like this in your clinical practice, I hope. So the question is, in a physiologic knee, is there a role for the anterolateral ligament? And in fact, it's not, because all these studies, they remove the iliotibial band before testing the ALL. And if you keep the iliotibial band here, you have, or all studies found that the iliotibial band is the most important stabilizer against anterolateral rotatory knee instability, whereas the ALL has a contribution of 10 to 15%. And this is what we observe clinically as well. So the question is, what are other factors influencing our instability pattern? Look at the posterolateral meniscus root. We know when the meniscus root is torn, the patients are present with a high-grade pivot shift. So before treating these patients with that anterolateral reconstruction, look at the meniscus root, look at the meniscus hypermobility. The next thing is, to me, the most important thing, because you can't work against the bone. So you can't try to prevent excess laxity that is caused by a bone malformation by a soft tissue reconstruction. It won't work in the long run. It may work in the short run, but it won't work in the long run. So whenever you are facing patients with a high posterior tibial slope, especially in the lateral compartment, these patients have a higher risk for a high-grade pivot shift. And if you see these patients, you should consider doing a slope-reducing osteotomy rather than a anterolateral reconstruction. Look at hyperlaxity and chronicity of ACL tears, as these influence our instability pattern. And the question now is, if you have this, what should we do? And if you look at this study by the Laprat group, they were saying that ALL reconstruction is perfect. You need to do ALL reconstruction in order to have physiologic kinematics, but 0 is their normal knee. And if you look at the yellow bars, this is the ALL reconstruction. You see that the knees are getting stiffer. Your kinematics are below 0, so the knees are getting stiffer. And the question is this clinically relevant again? And we found the same in our study. Whenever you are doing a ALL reconstruction or adenodesis in a knee that is not excessively lax, you overconstrain knee kinematics. And this could cause excess tibiofemoral contact pressure, which could lead to early onset osteoarthritis as well. So in fact, this is a patient seen in our outpatient clinic. On the right-hand side, he got Macintosh reconstruction back in the 80s. On the left knee, he got a isolated ACL reconstruction. And you can see his right knee is super stable. There's no pivot shift, there is no translation. But now look at his x-rays. So the right knee, status post Macintosh, lateral osteoarthritis, even a little bit medial osteoarthritis. And this is status post ACL reconstruction. There's just normal progression of OA, but no excessive OA. So try to not make the knee too stiff. And this has been shown also by the French guys, saying that if you do an anterolateral tenodesis in ACL reconstruction, about 60% are facing a lateral OA. But what is our current best clinical evidence? And this is a randomized study from Al-Gatgut on more than 600 subjects, and they found in the 2 years follow-up that if you do an isolated ACL reconstruction in young active patients, they will fail in 11% of the cases, compared to only 4% if you do an anterolateral tenodesis according to Lemaire. So the number needed to treat to prevent one ACL re-tear is 14. So you have to do 14 tenodesis to prevent one re-tear. And this is, of course, important. This is clinically important because every ACL tear that we can prevent is a good ACL. So what are our indications? And we have just little evidence. Potential indications, and we do it very aggressively now in revision ACL cases. We do it sometimes in patients with an explosive pivot shift, which is rarely seen, in patients with generalized hyperlaxity, and especially in young patients that are planning to return to high-risk pivoting sports. So there are different techniques that you can do. I will explain our technique a little bit later on, with a short video. The most important thing is when you are doing a tenodesis, don't pull your graft too tight. Don't pull the graft too tight because it will simply make the knee too stiff. I don't like the hamstring tendons for a anterolateral reconstruction because the tendons are too stiff. I like them to use a strip of the iliotibial band. It's not as stiff as the tendons. And so in summary, we know that all ACL injuries result in a anterolateral rotatory knee instability, and even a perfect ACL, which is the most important thing to prevent anterolateral rotatory knee instability, even a perfect reconstruction may result in a residual anterolateral rotatory instability. The ALL is not the only solution. It is a solution, but not the only solution. And we should rather talk about the anterolateral complex rather than anterolateral ligament, because we know there's the iliotibial band with its superficial and deep fibers, and that is the most important structure to restrain anterolateral rotatory knee instability. Look at other risk factors like posterior lateral meniscal root tears, look at the posterior tibial slope, and then decide whether or not performing a anterolateral reconstruction, because it's very potent in reducing the re-rupture rate. And this is now the technique we are doing. So we palpate the epicondyle, then we do an incision about 4 to 5 centimeters, then dissect down the soft tissue to the iliotibial band, which is seen very shortly. It's always this layer here with the bubbles. Then you palpate the Gerdes tubercle and make an incision in the posterior third of the iliotibial band. Go with your scissor proximally, but pay attention to not injure your lateral collateral ligament. And then we start preparing the area around the epicondyle and the lateral collateral ligament. So you can palpate the lateral collateral ligament with a shaver. We use the arthroscopic shaver to go down to remove this layer here. And when it starts bleeding, you're right on the right spot, actually. Then you identify your lateral collateral ligament, pass through a shuttle fiber like this. Be careful to not shuttle the fiber through your popliteus tendon. Then make another incision about 1 centimeter posterior and complete your dissection of the strip of the iliotibial band like this. So then you have a nice strip of the posterior third of the iliotibial band, which is distally attached, and then you just suture it up and pull it through or underneath the lateral collateral ligament as shown here. Boom. And then try to find the right spot. A little bit now we go anterior to the lateral epicondyle and posterior. This is now posterior and proximal. Now we go anterior and a little bit distal to have a better lever arm, and place a socket of about 6 to 7 millimeters according to the thickness of the graft, and fix it in about 20 to 30 degrees of flexion with neutral tibial rotation. Don't pull it too tight, and you will see it's easily. Then we try to close the iliotibial band as much as possible. Don't try to go all the way down to Gerdy's tubercle because it won't work, and the patient will be fine at the end. So thank you very much.
Wonderful presentation, Dr. Elmar. The talk is open for discussion. Any questions? One question, sir. So all revision cases, do you do LET, ALL, reconstruction?
Almost, yes. It depends if the patient. So in all revision cases, we look at the posterior tibial slope. If the posterior tibial slope is high, we opt more for a slope reducing osteotomy. We are getting more aggressive with these. But in all traumatic or many traumatic revision cases, usually we do a LAT. But it's also because many of these have a chronic re-tear. So in all these chronic re-injuries are excessively lax. But you need to rule out other instabilities as well, because, for example, some of these patients have posterolateral rotatory knee instability. We never looked at these in ACL injury, but look at the patients. Many, or about 1/5 of the patients, they have posterolateral rotatory instability. Look at anteromedial rotatory knee instability. Not described at all in literature. Look at this. You will see that many of these patients with a chronic ACL tear or re-rupture have a complex rotational instability pattern. It's not only an anterolateral, unfortunately.
As you said, most of the failures of ACL is due to because you don't address the posterior lateral corner. When you have a posterior lateral corner instability, in a revision case, do you combine with LET or just do a posterior lateral corner reconstruction? Well,
we start with the posterolateral corner reconstruction and look intraoperatively if they are still unstable anterolaterally. It's very uncommon, very uncommon.
Thank you.
But I've done it. I've done it in 2 cases before, but I'm not sure if it was the right decision, to be honest.
First, I have a question. Now, you said you select the, instead of the hamstrings, you select the, in time, after 4 or 5 years, what happens to your graft? Does it really slacken down?
No.
The iliotibial band, does it slacken down, or what is the longest follow-up you have?
Well, there are very long follow-ups, as the French guys did this for decades. We started doing it regularly about 5 years ago. Yeah, it's 5 years now, 4 to 5 years. And we never saw a slackening of the iliotibial band because you have a big injury on it's extra-articular, so you have a different biological environment. And you have the bleeding there around the epicondyle always, and it scars down. It scars down. So I don't think it's getting loose. And actually, I never saw, and this is kind of interesting, we saw a few, not many, a few revision cases even after LAT. And we explored the anterolateral side, but there was no bleeding, nothing. So it's kind of interesting.
Oh, thank you.
But you have to be careful to not make the reconstruction too tight. And I don't recommend to pull it down at 60 or 90 degrees of flexion. I would fix it at 20 to 30 degrees, like your ACL.
But you said nearly about 40 degrees of flexion. Is
no,
it the
20 to 30.
20 to 30 degrees? I thought it was, because that will slacken. Okay.
And I think the most important function of the LAT is to protect your graft, your ACL graft, during the remodeling phase.
Okay, thank you.
Sir, anyway, you can make out clinically whether it is an isolated ACL failure or whether it is associated with an anterolateral complex. Can you make a clinical diagnosis before taking up for reconstruction?
Yes. So we do, of course, the pivot shift. The pivot shift, the issue with the pivot shift is that it's highly variable and the patients are guarding. But you can do when you're doing the Lachman test, don't do it and do the Lachman test in neutral tibial rotation and do the Lachman test in internal tibial rotation. And you will see that patients with a higher grade anterolateral rotatory instability have more anterior tibial translation at 20 degrees of flexion with the tibia rotated internally.
And you are told that by doing an LET, when you do a excessive tightness on the LET, then it causes compression force on the lateral compartment. Same patient, when you do a lateral meniscal repair, do you do a LET or you in a primary case?
Usually not. So it's about only 10% of the primary cases where we actually do a tenodesis. Very rarely. And if they have a high grade or complex lateral meniscus tear, we repair the meniscus. We don't add a LAT. No.
Any questions? Thank you, Dr. Elmar. It was an excellent presentation.
Thank you.
Thank you.
Bye.
Thanks. Bye.
So next talk, I invite the moderators, Dr. Shantaram Shetty and Dr. Raju Naik onto the stage.
Is there an inauguration? Some, as for you, this thing that they schedule inauguration? No.
Okay. Just there's some change, sir. Just a second.
There's a small change in the schedule. We'll be having the next talk by Dr. Thomas Randau on pre-operative preparations in knee arthroplasty. And we will have the inauguration as well as Dr. Krettek's talk a little later in the program. So if Dr. Randau is ready, can we? Dr. Krettek is seen on the screen.
Yeah, he's there. Why not you finish?
You're okay to start, Professor Krettek?
Give me 30 seconds.
Okay, that's fine, no problem. Then Dr. Rajiv Naik will.
Can you see my screen?
No, not yet.
Okay. What's about now?
No.
Okay.
We request Dr. Raju Naik to be the moderator and Professor Shantaram Shetty to moderate the session.
Sir, a brief introduction to the audience about Professor Krettek. He is the professor of trauma and orthopedics at the Hanover Medical School, Germany. He is the AO Trustee International, chairman of the Computer Assisted Surgery Expert Group of the AO, special clinical interest and research focus, computer, navigation and robotics, late reconstruction of articular trauma. This is a brief introduction for Professor Krettek. And sir, we welcome you to present your talk.
Thank you very much. Good morning, everybody. Can you see my screen? Is it working now?
Yes, we can see your screen, sir.
Okay. Greetings from cold, rainy Germany. And in the next 20 minutes, we will share with you our ideas about post-traumatic articular destruction and the use of intra-articular osteotomy and 3D printing devices, which came to knowledge recently and give us new opportunities to avoid, in some cases, early prosthesis and knee replacement in specifically in the younger patient population. We are a busy trauma place in northern Germany, and there is no conflict of interest for a couple of paid editorial tasks. What are the intra-articular problems? We all know about it. It's cartilage and bone defects. It's intra-articular deformities. And we are looking since a long time for alternatives for arthroplasty, especially in young patients. And I would like to sensitize you for new joint preserving options, which are intra-articular osteotomies. And we have a special focus on osteochondral bending and shaping to make as the articular surface more anatomically. The use of proximal tibiofibular joint in some instances in tibia plateau fractures where we have articular defects, this can be helpful. We will share with you some of our ideas about the correction with the use of 3D printed template devices, so we can have some sort of 3D print template assisted navigation during the surgery. And we will also have a short brief look on the use of osteochondral allografts in this patient population. There is no, as I mentioned, no conflict of interest for a couple of paid editorial tasks as listed here. So cartilage damage, defects, joint destruction, these are the problems. And especially in the young patient populations, when we do joint replacements, we have more implant loosening than in the higher aged population. We have shorter implant survival. We have usually multiple revisions in a lifetime, which get more and more complex the more we do them. Sorry, try to forward. There's very few literature on intra-articular osteotomy. Here, a paper from René Marti showing the combined intra-articular and varus osteotomy wedge for certain types of depression fractures, but this is not applicable for a number of situations. And problem is many deformities are just more complex than the situation we are, which is described by René Marti. And I would like to share what imaging as sources we are using. Of course, standard 2D and 3D analysis, X-ray, long-standing film, very important, CT. And in the CT scan, it's so important not to throw away the contralateral side into the radiographer spin. We use very often the contralateral side as a model, as a shape. And you need to speak with the radiologist that you get these data sets from the contralateral side, because this is very helpful and can provide you with the exact geometry if it's uninjured. MRI, of course, and I even more love the CT angiography over the MRI, because this gives you not only the cartilage and the ligaments, but also the connection with the bone and the spontaneously filled up cartilage defects with tissue. So here is a good example where we see with the help of the CT arthrography, we see the cartilage defects very nicely in context with the bony deformity. Instruments and implants we are using, these are the typical things, very important, the laminar spreader, brush, etc., small implants for temporary fixation, and so on. And I would start with as a case of a 50-year-old lady from the Netherlands. She had a missed lateral tibia plateau impression fracture with a large defect. Look at her, that's her lateral plateau, and she has this big hole, and she comes with a significant amount of pain, visual analog scale of 7, instability. She is dependent on crutches, and she presents 9 months after trauma. And when we did a CT analysis, we see that this, what we see here as the lateral impression depression, we see that she has a huge impression zone in the lateral view on the CT scan in the lateral compartment. And we all know usually the lateral compartment is convex, but her lateral plateau is concave. And when we do a simulation, when we transpose here as the contralateral side, we see the huge amounts, the big difference between the injured side, we see now, and the contralateral side, which shows the filled up defect like here. Same is true for the lateral view. Here is the injured side with a sharp impression in the anterior part. We see here in the middle of the condyle deep impression. So significant problem which causes pain and instability during examination. So this is something which is a toy and a technique to cut mango, but this inspired me to think about how we could solve her problem. This is making a stiff material flexible, and that's the task also in this patient. We have a stiff osteochondral bone situation which is concave, and we want to make it convex, and maybe the mango technique can inspire us how we can solve the problem with multiple cuts, making a stiff structure flexible. So question is an articular surface malleable, and we developed this osteochondral bending and shaping with special cutting technique. We use the reciprocating saw, and we make multiple coherent segments, like here on this drawing on the right side. We cut from underneath, very tight to the articular surface, and then we can slowly bring it up, make it from concave to convex, and we can correct the situation. Let's have a look how it goes. Here's the intraoperative, here's the situation before the surgery, here's the principle, and here's the post-operative situation. We could make from a concave a convex articular surface again here in the frontal plane. And also when we see the MRI, we see here's a big defect, the concave situation with in the MRI. And later, post-operatively, we have again a convex situation, and we see the meniscus very nicely. And we see also here the film as the structure of the lateral meniscus again. So here in larger detail, the pre-operative situation with the concave bone. Then we did some multiple cuts as displayed on this little drawing. And in the center, we have a nice convex situation again. Here's a patient significantly reduced pain score with significantly improved visual analogs situation, knee society score and Lysholm score improved significantly compared to before the surgery. And also here again, the MRI showing the nice reconstruction, the nice survival, of the cartilage 1.5 year after OCT bending. And we see her now in a total 3 years after the surgery, patient doing very, very well. So if this works, maybe we can also apply it to a more trauma situation. And there we have frequently the need for osteochondral structures when they are broken, when they are destroyed, when they are crushed. And I would like to share with you a case with Uwe. Uwe is a 52-year-old anesthetist from a neighborhood hospital. And he had this complex fracture with a large anterior defect of his lateral plateau. So he was brought to surgery. And in the next morning, we saw an X-ray like here. Post-operative, we can assume incongruency, and we still assume some sort of a defect. It's difficult to judge. But when we did the CT scan, we clearly see in the anterior 50%, we have incongruency and defect. So 52-year-old anesthetist, what should we do? Should we leave it alone? Should we go for revision? And when we go for revision, what should we do? What can we do if we have such a messy destruction in the articular surface, as the surgeon told us in the morning conference? So we voted, I decided for surgery. And question was, how can we fill the defect? How should we approach it? Had an anterolateral approach. And always my idea is use the proximal tibiofibular joint as an option. And I will show you how this is. Because in a tibia plateau fracture, we have very close by a donor site for osteochondral grafts. The problem is that sometimes you have a convex donor site on the fibula side, but we all know the tibia plateau on the lateral side is convex. So we need to shape it accordingly so that it nicely fits into what we need. So we identified the articular defect, the articular depression. We did some planning using the contralateral CT scan. And so what we found, the green line is the contralateral joint line, and the projected onto the ipsilateral knee. And we see the depression and the defect not only start in the middle of the knee, they start here in the posterior quarter as the articular surface starts depressing, and this all needs elevated. And on the right side of the slide, you see the situation when we open the knee again, this time not with an anterolateral approach, this time with a posterolateral approach. So for your orientation, here is posterior, here is proximal, here is distal, and here is anterior. So what we see, it's a right knee, and we see here the meniscus is trapped. We see here the posterior part of the mostly more or less healthy articular surface, but in the anterior part, we just see a crushed situation with this trapped meniscus. And as we mentioned before, we used a slice of the proximal tibia in order to get some sort of a graft for the big defect. So we used the oscillating saw to harvest it. Here you see the peroneal nerve, which is protected. And here the destructed articular surface. And we use now the oscillating saw to make multiple cuts in these little 3 centimeter diameter proximal tibiofibular joint. And look, here is a graft we harvested. And when we go forward, we can see that this all of a sudden gets some sort of flexible, and we can adjust it to our needs. Here we inserted it. This is the graft. This is the remaining osteochondral situation, and we shaped some sort of a convex replacement and fixed it temporarily with K-wires, later on with the replaced screws. So we didn't change very much on the hardware. We just brought the knee to an congruent situation. We have molded the osteochondral fibular graft, and then here's the pre-operative situation on the left side with the deep impression and the defect. Here's the post-operative AP and the post-operative lateral. Here's the X-ray after 1.5 year follow-up. We see a nice congruency, and the most important thing in trauma is not the X-rays. The most important thing is the function and the pain, and the patient 4 year post-operatively significantly improved. He has now a Lissome scores of 96 out of 100, a Tegner score of 5, EQ 5D of full 15. And look at him, how stable he is, how good he is able to run. So he's a very, very anesthetist, again, helping us with his narcosis. So another case I would like to share with you, and this time we experience how 3D print devices can help us in the management of our fractures and post-traumatic deformities. Mohammed is 24-year-old. He has a B-type femoral fracture, which was mal-reduced and healed in a mal-reduced situation after he had some sort of a gunshot attack in Libya. So he healed in a varus deformity and remained with a significant pain between 6 and 8, and he presents 2 years after trauma. So everything is healed, everything is fixed, and he had this lateral condyle fracture, which was addressed with these implants. We see here remaining bullets, and the medial condyle is mal-reduced and has, in addition, also intra-articular steps. So this, from our view, is a case for intra-articular osteotomy, but we need to very carefully need knowledge what is the exact plane where the osteotomy should be done. And here the benefits of a 3D analysis come into play. We do the analysis with the help of 3D CT scans of both sides from the hip to the knee, so we can superimpose. We can superimpose the injured side, which is green, and we superimpose the healthy side, which is mirrored and is gray. And when we do so, we see the gray side is almost 10 millimeters longer, 9 millimeters longer. It's more flexed. And in addition to this, also rotated. So there is a bump and there is a gap between the healthy side and the injured side. And so you see the difference between gray and green. This is the difference between healthy and injured side. So we use a very simple, free available standard software, which is called Blender, and we use 3D slicer in order to do the planning step. We see as a gray side and as a green side. The gray side is the healthy side, and we now try on the computer a certain amount of cuts. And once we are happy with the cuts, we can construct devices which can help us to identify the bone position, which can help us to do the appropriate cut and help us to reduce the cut fragment into the right position. So this is all done on the computer desk, and we can play with different variation. We can show where would the knee would fit best in order to reach the position of and the shape and the configuration of the contralateral side. And this is now the construction of a tool which is fixed into the old passes of the screws, and they help us that we can manipulate these bones. So this procedure contains 6 steps. First is to fix the distal master block in the existing screw hole. The existing screw holes help us that we can completely identify the position on the distal main fragment and our references. The second step is we have constructed a connection block to the proximal main fragment, and this connection block has snap-in connections. And this connection block connects to the proximal master block. So distal master here, connection block, proximal master, which is fixed to the proximal main fragment. Step number 4, we need a cutting block. We fix, and which means we snap the cutting block to the proximal master, and this plane, the dark gray plane, gives us the cutting plane with the oscillating saw. So we are very controlled in the 3D sprays, can do the cut without doing too much soft tissue dissection. Here's a cutting block, and once the distal main fragment is loose, we do the reduction, and we move the loosened distal main fragment into the right position. So it looks like this angulated is also angulated. We have these snap-in connectors, and once they are snapped in proximally and snapped in distally, they move and open the osteotomy gap and rotate and shift the distal main fragment into the right position, since it is loose. So here is the intraoperative situation. We see the large osteochondral defect. We see the former fracture line, which is not filled completely with natural cartilage. Again, it's filled with connective tissue. We see here this ugly bump, which causes probably a large amount of the patient's pain. And we see that the femoral medial condyle is also rotated adjacent to the patient's main axis. So step 1, you see the negative surface of the medial condyle in the distal master block. And this connector fits exactly into the screw hole. And once it is pressed against the bone, look how nicely this fits for shape, very much like in the preoperative planning, 3D planning. Second step, we use the old screw hole to fix it, and then we apply the osteotomy block, which is connected to the proximal master, as we have highlighted before. And we see now, aha, here is our cutting plane, and we can very safely and very controlled do our cut. Here's the oscillating saw. We have the clearly defined plane for the oscillating saw. And here is the situation after loosening the medial condyle with the help of the bone clamp. And the step number 6 is the reduction step. We snap on the reduction block into the connector slots, and by attaching the reduction block to the proximal master block and to the distal master block, the reduction block by itself reduces and holds the mobile medial condyle as we see it here. So we do intraoperative alignment check with an alignment rod. That's part of our standard procedure. And we see parts of the alignment rods. We see parts of the 3D devices in the knee. And here, after once we are happy with the overall axis, we fix it with a simple T-plate, locking plate. And an additional cancella screw, but still we have something to do. We see here that this local bump still needs a correction. This would be the shape of the natural bow of the condyle, but this is elevated and doesn't fit the curve. So what can we do? We do again osteochondral bending and shaping. And I show you how we did it in this case. We did a correction of the local bump with a closed wedge with thin blades. And we did a closed wedge resection here with the oscillating blade saw still in place. We cut out this wedge. Now we have an open wedge situation after removing the wedge. And then I press with the finger and close the gap. Now we have again a very nice curve which fits the previous situation much better, and we have removed the bump, and we fix it with simple 180 K wire and fix it to the bone. So we have left some defects which we fill with bone graft on both places. Look on the right picture how nice the curvature is achieved again, and the remaining defect is filled with cartilage, ACT graft, chondral graft, which we have cultured after a knee arthroscopy 4 weeks ago. And this is protected with a membrane, resorbable membrane, and small sutures, a small defect in the middle of the condyle, but also the intercondylar articular chondral defect. So post-operative imaging, let's have a look. Long-standing film, we shows that we have nicely controlled the varus deformity with a perfect centering of the mechanical axis. And also in terms of the osteochondral bending, we have a nice curvature. Again, the bump is finished. Look at this X-ray. Here's the medial condyle. We have a very nice transition of the uncorrected and corrected area. Here's a frontal plane situation. We have an open wedge correction, and this had this screw as a placeholder in order to avoid drifting back the fragment. We just put in a single screw as a mechanical resistance, some sort of a polar screw, if you like, in order to avoid to slip back the mobilized distal main medial condyle fragment. Here's the postoperative film, pretty unspectacular. And here's a situation in the postoperative CT scan. Green is the preoperative osteotomy planning. Gray is the postoperative situation. And we have a nice fit between green and postoperative in all directions. We have seen that the green and gray have a good overlay. Here on the green, preoperative, of course, we have the bump, which is part of the 3D data set, but this is gone postoperatively on the gray data set. Here's a patient. Again, this was before bad walking on a staircase, incongruency. Here his arthro-CT before the operation, and look at him, 1 year follow-up, Lysholm score 80 out of 100 again, knee society score improved to 178, and VAS, no pain again. So significant improvement with a Lysholm score of 100, knee society 178, and excellent visual analog scale result. And when you see him walking on the staircase again, very different to the situation 1 year ago. So very complex situations, but sometimes we have defects which we just cannot fill with local material, as we have seen in the 3 cases before. So I would like to share, what can we do then? I would like to share with you Irmgard. Irmgard is a 59-year-old female patient. She presents 6 months after a bad horse riding accident. Again, with a significant deformity and a pain score of VAS of 8. We have significant valgus instability. She is dependent on crutches. Her valgus deformity is increasing over the time, and she has a very poor Lysholm score of 26 out of 100. And a recent arthroscopy and partial implant removal had no effect at all in order to improvement. And everyone she is traveling to recommends her a total knee replacement, but she doesn't like to have a total knee. So someone sends her to Hanover in my clinic, and I analyzed her and found these problems, and did a CT scan. And when we did a CT scan, we saw this huge defect. And in her lateral condyle, we also see that this is not yet healed. We have a non-union, we have a defect, and the defect is very, very big, and it's very symptomatic, and the patient has pain, instability, and doesn't get away from crutches. So what can we do? What can we do except arthroplasty here in this case? Okay. We did some planning, and as an additional background, we are doing fresh large living osteochondral allograft transplantations, and in our technique is a bit different to allograft transplantation technique we saw in the past. We call it Floxart, fresh thin osteochondral allografts. Do well, and we see that have good long-term survival, as we see here in a couple of studies listed here. And question is, can we use it here for this patient with a big lateral plateau. But we would need a big allograft, not a thin allograft, which is proven to have good long-term result. We would need a thick one. So we split the task. We filled the gap in a first step of a two-step reconstruction procedure. In a first step, we built up the defect with a large autograft from the posterior iliac graft and gave it a 6 months ingrowth time. As we see here, we have this large 4 by 3 by 4 centimeter cartilage defect. It's destructed, the meniscus is destructed, as we see here, and we fill it with autograft from the posterior iliac crest. It does not look natural. We overcorrected, we overstuffed it a bit, and then after 6 months, we saw in the CT scan this is healed in nicely. We did some 3D planning in order to shape and modify our allograft transplant, which we see here is just a small medallion of the lateral condyle. Here's this red line, small medallion is the allograft device. And here the intraoperative situation with the allograft meniscus, with the allograft bone part. This is the original bone, also done with an extended posterolateral approach with a fibular osteotomy. Here's a transplant, and this is the intraoperative C-arm shot. We see a nice congruency again. There is not much fixation needed. We only had 2 K-wires and a lag screw. And here's the postoperative situation, running her up and down as a stair, very happy with a good range of motion of her knee. That's her X-ray before on the left side. That's her X-ray after with a good integration. And even on the CT scan, it's very hard to identify the transition between the allograft and the natural bone, showing that this is a nice osteointegration. The MRIs also look pretty good with a nice shape. Here we see still some signals at the level of the osteotomy. And what's most important is pain and functionality. And there is no better test for functionalities than running up a staircase, and even more jumping on a trampoline with other people, like we see her with her grandchildren. And you see the Lysholm score and Knee Society score significantly improved, and pain scores are down to 0. Actually, very rarely that she has some mild pain. And quite interesting, 12 months after transplant, we did an implant removal and scoped her. And we also did a chimerism analysis, and we found out that 32% of her donor cartilage cells were already exchanged with her own cells. And actually, the lateral plateau cartilage and meniscus was the nicest part of her entire knee. It looked much better than the medial compartment. And look, this soft and nice indentation with a palpating hook, indicating a very healthy and strong and natural cartilage, a very natural cartilage behavior. So this 3D prints template assisted navigation help us also for precise bone cutting. And we have developed a shape copy technique in order to perfectly hit the geometry. And this is something which helps us in our last case I will share with you. This is Catherine. Catherine has a elbow problem, and she had a neglected radial head dislocation, and had, in order to overcome this radial head dislocation, she had an extending corrective osteotomy in order to bring her radial head back into congruency, but this operation failed. So she had a chronic, she came out with a chronic anterior radial head dislocation. As we see here, radial head is dislocated anteriorly. And not only that, the radial head is also deformed, and the radial condyle also is deformed, as we see here in the AP view. This is not the natural radial condyle. So this results in instability. This results in significant deformity, limited range of motion, and most important, it results in significant amount of pain. 6 to 8 visual analog scale. She needs to take painkillers regularly, and here we see a defect on the CT scan. So what can we do? How can we help Catherine in her with her elbow? And I thought this might be something where we cannot reconstruct local cartilage, local deformed cartilage. This is something where we need to transplant healthy structure, but transplanting an elbow joint is not an easy task. And we only aimed for transplanting only the structures which were deformed. So our plan was to get a partial elbow transplant, which includes the radial head, which includes also the ulnar joint facet as an osteochondral block, together with the annular ligament and the lateral collateral ligament attached with an attached radial epicondyle bone flip in order to have a good ingrowth. And here a schematic drawing, we have this ulnar joint, ulnar joint facet osteochondral bone block. Here we have the annular ligament, we have attached the lateral collateral ligament and a chip of radial epicondyle on the distal side. On the radial side, we planned a V-shaped osteochondral graft, which we planned with a shape transfer. Here's a further step of the ulnar correction osteotomy, again with the help of 3D analysis and a 3D print template assisted navigation. On the red is the healthy side, is the shape of the ulna of the healthy side, and gray is the injured side with the deformity, and blue is the bone, how it would be superimposed according to the contralateral side. So we have a 30-degree hyperextension deformity if we follow the proximal main fragment. This would be the proximal main fragment in a correct correct configuration. And I bring you to the operating room. Here's the radial head. Look how deformed it is. There is no good function to expect. Here's a graft, very nice functionality with the ligament and the ulnar bone chip. But the key step is the radial head perfused? And here we do a test osteotomy and find, oh, very nice. We get some blood flow from the tip of the radial head. So we do make the grafts very thin. We excavated them and do press fit onto it. We have transplanted already as a radial head. And now we do a first test, but everything, of course, is still very unstable. The stability comes with the annular ligament and the radial bone chip tightened to the radial epicondyle. Then we have a nice centration of centering of the radial head. Here again, the graft, a very nice anatomy. Radial, we see the ligament, radial ligament, and ulnar bone chip. We ream and we osteotomize the radial head, and we find this bleeding surface. We adapt the transplant for the epicondyle, for the radial condyle. Very thin bone grafts, which ensures that they have rapid ingrowth and good perfusion. If we make them too thick, they don't have good ingrowth and they die. And the key step is the tightening of the radial ligaments in order to get stability and congruency both on the same time. So we move forward, and here we see the post-operative situation. We have straightened out the ulnar again. We see we have this this gap, and which we filled with bone graft, but it looks like an ulnar again. We have the radial head with a nice congruency. We have a good centering. It's 3 months after surgery. It's a case from 2016. It's now 5 years out of surgery. And at 2-year follow-up, we see significant improved, not perfect, but improved range of motion, prosupination, improved significantly. Visual analog scale is significantly improved as well. It's not 0, but significantly better compared to 6 to 8, what she had before, and she is back to work in her grocery shop. So let me summarize. We have nowadays some joint preserving options, which include new ideas about using the proximal tibiofibular joint in a knee problem. We have developed this osteochondral bone shaping technique as a new technique in order to modify bone surfaces, articular surfaces. We have new options with 3D printed template assisted navigation, and a Floxat allograft transplantation is a special defect situation is a helpful option in rare selected cases. Thank you very much for your attention.
Thank you. Thank you, Dr. Krettek. This is Shetty here. It was fantastic. Hi, how are you? Nice seeing you. Nice seeing you again. And we are really enlightened by your 5 cases which we saw. It was fantastic, and you have really enlightened us what can be done to really reconstruct any joint, especially the last case which you showed the dislocation of the head of the radius anteriorly with the ulnar, and the correction which you undertook, and all the cases for that. Before we open the house for other questions, can I ask you one or two simple questions as to starting from the 3D printing, which you always undertake the mirror of the opposite side, or it can be done only on one side?
Yeah, I think it's helpful for when we see it on one side only. We realize there is some shortening of condyles, there is some rotation, and maybe some hyperextension. But when it goes to planning, we need to quantify it, and it's very difficult to quantify. Of course, we can have the mechanical axis, which defines one plane, but in the other instances, the contralateral side is a gift, and the gift should be used rather than thrown into the radiologist's bin.
How are we sure the other side is absolutely the same as this side? If there is
that's a good question. Of course, if you have a post-traumatic deformity, you cannot, or you can use it only in parts, but it's always, I found it always helpful.
No, regarding the reconstruction, what happens to the ligament stability? Ligament stability. You are corrected the bony part of it. Body. Then what happens to the ligament? How do you really assess the ligament? There will be, when there is a contraction, when there is a deformity of nearly more than 1 year or 2 years, there can be a contracture of the ligaments or laxity of the ligaments. And how do you really assess?
Yeah, my experience is when you have these post-traumatic deformities, usually it's the bone which breaks and not the ligaments. So once there are exceptions, but once the large majority has not ruptured ligaments as well, at least in the cases we see here. And once you correct the bony side, the ligament side is just fine. We have cases where we have significant posteromedial instability, so this needs to be included in the planning as well, and also can require additional surgical steps in order to achieve knee stability or joint stability. And I agree with you completely. Bone congruency alone won't help the patient. The knee or the joint needs to be congruent, needs to be stable as well.
Yeah, it is all your 3D printing, no doubt, enhances the surgical planning exposure, lessens the radiation exposure, placement of the pedicle screw, especially in spine and pelvic fractures, and neurovascular trauma is perhaps lessened. And less operating time, as you rightly said. But our only concern is the cost factor. It is all right for you. The cost factor as such, compared to a 3D reconstruction with the CT and with perhaps added MRI, how do you think this is the way to go for the future?
Yeah,
you are a great scientist. We have great respect for you.
Yeah, I try to be a scientist and not an economist. But we are a university, and our task is getting the level to another level and to improve patient care and create patient care for the future. So the cost factors are second, actually. And regarding the cost for the printing, all the planning was done in our department, and so the printing costs are not as high as one would imagine. This is all very common technology now. So you can find a company doing the 3D prints, you can do the planning, and I think this is very important. The planning should belong to the surgeon, and these software tools belong into the hands of the surgeon. It's now like our generation was happy to use IT, Outlook, Word, Office package, but the future generation needs to use 3D planning tools, like they do the writing on the computer.
I have I have two questions.
Yeah, thank you. Now, one in the lighter vein, we are a mango growing state here, and you have enlightened us with your mango cuttings, and thank you very much, Krettek. Yeah, it's open. Thank you.
I have two questions. Dr. Krettek, I really appreciate your the way you have done surgery for malunited fractures, where in India, really, we are not doing much about this malunited intra-articular fractures. See, I have one doubt. See, you have done the reconstruction of the articular surface, that too in for younger patients. After how long they come for total knee replacement? how long this, whatever the surgery you have done is going to last?
No, yeah, give me the crystal ball to look into the future, then I can answer the question. But these are cases which are now, the lady in the staircase here she is 6 years. He is 4 or 5 years now out of surgery. The girl is with the elbow is 4 years, 5 years as well. But I think if they survive the first year, they have a pretty good outlook to have a good prognosis, but nobody knows how long it lasts. But when you look at the runner, I'm pretty confident that we give them additional years, and when they are in the mid of her 60s or 70s, it's fine to have a prosthesis then.
So one more question. When you're doing the reconstruction of the articular surface, the approach, are you going to dislocate the tibia anteriorly and see the whole articular surface and do the surgery?
Yes, when we do the anterolateral approach, we have always the problem that we have no good access to the posterior parts of the lateral condyle. And that was also the problem in primary surgery of the first case. He actually saw only good in the anterior 50%, and the manipulation is hindered by the lateral collateral ligament. But when you do an extended posterolateral approach, you dissect the fibula and release the lateral collateral ligament. So you can open it very nicely, and you can judge your congruency very nicely, and you can manipulate accordingly much better and build up a natural surface. So I'm a big fan of extended posterolateral approach, which with the inclusion of the fibula and release of the lateral structure. And later on you refix it and that's fine. And the peroneal nerve is not a problem.
Thank you.
Dr. Christian, good morning.
Good morning.
This is Dr. Rajkumar from Bangalore. At the outset, I would like to congratulate you for your wonderful technique that actually has brought us to a new forefront of dealing with malunited fractures of the proximal tibia as well as the difficult situations in the elbow. Having said that, I have two questions for you. Most often than not, when the lateral condyle of the tibia is depressed more than 6 millimeters, it is the lateral meniscus also that gets entrapped as shown in your presentation. How do you address the soft tissue just in case the meniscus is torn? And is it always that you choose the proximal tibiofibular joint to reconstruct the articular surface of the lateral side? Number one. And most of your cases are on the lateral side. Suppose the same thing happens on the medial tibial condyle, how would you approach it?
Oh, this is a very good question. Thank you very much. Yeah, meniscus, I would, I must say, when I see lateral plateau fractures, I very rarely need to do meniscus repair. Second, I do not always use the proximal tibiofibular joint because I have not regularly these defects. I only do it when I have defects where I have no other solution. So this is some sort of an exit strategy. And third, your question regarding the medial compartment, situations there is much more difficult because it's more difficult to approach it. And the indentation fractures usually on the lateral side. the fracture pattern on the medial side is usually different with the oblique fracture configuration. There's the impression, deep impression, defection, depression fractures usually on the lateral side.
Is it that the lateral side of the tibial condyle is more forgiving than the medial side of the tibial condyle because of the thickness of the cartilage?
Yes, that's an observation. That's a very interesting comment. Yes, I believe it's more forgiving than the medial condyle, and it's much more forgiving. But still, there are destruction, like we saw in the lady with the allograft tibia plateau. If the destruction is exceeding a certain limit, it's not tolerating it. And she had a 6 months history of not tolerating it. In addition, she also had a non-union in addition to the deformity. This was not completely united. So the autograft, which we did as a first step, was also to address the non-union situation.
Thank you,
Doctor.
Professor
Thank you.
Krettek. For shortage of time, there are too many questions which we will keep them later. So we proceed with our next this thing, that is inauguration, and we invite Dr. Chandrasekhar, President of the Karnataka Orthopaedic Association, to take on the proceedings. After the inauguration, we will have a second talk from you, Professor Krettek.
Okay. Thank you.
Good morning, everybody. First of all, I welcome all our delegates, KYA members, national faculty, international faculty. This World Arthritis Day, we are celebrating on 17th of October. Greeting from Bengaluru Traumacourse. It gives me immense pleasure to render a welcome address to the gathering, which involves great international and national faculty. It is unfortunate that due to current pandemic situation, we are unable to conduct a physical meeting, even though because our cases have come down, we are mixing up both virtual and physical conference. We are able to accommodate a few 30 to 40 delegates for physical presence. We are glad this pandemic has taught a new way of connecting, educating ourselves. See, we never used to these webinars and online teaching earlier, but this pandemic really taught us we can teach and connect international faculty through net. We never thought of that connecting international faculty through net. We are able to reach out various speakers. In the last couple of years, we have learned a lot of things from them, because otherwise, if for a physical conference, they're supposed to travel all the way from the abroad and come here with so much expenditure and wasting of time. Today, webinar is planned to celebrate World Arthritis Day. World Arthritis Day is observed on usually 12th October for global awareness. This year theme is Don't Delay, Connect Day. We have also gathered a small crowd in Bengaluru and more like hybrid meeting. I told already, it is a hybrid meeting, physical as well as virtual. Today we have talks related to arthritis of various joints, most connected to trauma. So since our trauma course is connected to this, we are conducting this on the Aegis of both Bengaluru Orthopaedic Society and Karnataka Orthopaedic Society also. We have a galaxy of international national faculty. I think Dr. Krettek, Dr. Thomas, Elmar, Rajasekaran from Coimbatore, Guruva Reddy from Hyderabad, Adarsh from Andhra Pradesh, and Chaddha from Maharashtra. We just heard Elmar's talk on medical meniscus tear and tear instability. Dr. Elmar is from University Hospital of Münster, Germany. Dr. Krettek, another medical school, who is well known, already has given the talk, and he has really talked very well on the osteotomy on malunited intra-articular fracture. A very good orthopedic surgeon to treat a fresh fracture of an orthopedic intra-articular fracture is very difficult. That malunited intra-articular fracture, that knee joint, a weight-bearing joint, managing malunited intra-articular fracture is very difficult. Really has given a clear picture, and even then, whatever we heard, doing practically for an orthopedic surgeon is very difficult unless he undergoes a training properly. Dr. Thomas from the University of Clinic of Bonn, Germany will be going to talk about knee arthroplasty. Nationally, we have Dr. Rajasekaran, a well-known spine surgeon, Dr. Guruva Reddy, arthroplasty surgeon, Dr. Adarsh from Andhra Pradesh, from Chaddha, from Maharashtra. They are all going to give their talks in their field. Rajasekaran from Ganga Hospital is a well-known senior faculty, leading spine surgeon from our country. He is role model for most of our young orthopedic surgeons. He is going to talk related to spine surgery. The Guruva Reddy is a senior orthoplasty surgeon from Sunshine Hospital, Hyderabad. He will be accompanied by the Adarsh, Annapareddy, a young surgeon from same institute specializing in robotic replacement. He is going to talk about robotic replacement, which is a latest surgery in knee arthroplasty. Dr. Chaddha, a senior orthopedic surgeon who deals with only spine. He is all the way come from Mumbai. He is known for his expertise in management of failed back syndrome. I welcome all faculty, delegates, and our KY members for this program. Our panelists, Dr. Rajiv Naik, Dr. Shantaram Shetty, Dr. Rajendra, Ram Subba Reddy, Uday Kumar, Dr. Satish, Ajit Kumar, Madan Ballal, Subhash Shetty, Narendra, to run, and they will be moderator for various sessions. I wish all the faculty best wishes. Hope this program becomes successful. Thank you. Thank you very much.
Thank you, Dr. Chandrasekhar, for the inauguration. And we request Professor Krettek to follow up with his next talk. Sir, kindly share your screen, sir. And
can you see my screen?
not yet. Yeah, now yes. No,
okay.
not yet, sir. What is it?
It's working now? Sorry.
Sir, not yet.
Okay.
Working? Yeah, it's working, he says.
It's working?
Yeah, it's working.
Okay. So thank you very much again for giving me the opportunity to talk a bit about motorized implants, especially motorized nails. And when we look back where we have been in trauma care 50 years ago and where we are today, it's really amazing. And IT technology is playing an increasing role. Implants are changing from a passive to a more active role, to a role where we can control them better, where we can have them to do certain things while inside the body. And I'm very sure that this is just the beginning of something amazing, new developments. And we have the philosophy here in Hanover to use motorized nails not only for the modification of lengths, as we see here, several implants, ISKD, fit bone nail, and precise nail. We can use them for the modification of nail lengths, and this is impressive, and this is very helpful for our patients. But that's not the end. We can use, and we see these lengthening nails not only as lengthening devices, we see them as a universal engine inside the body. And it's up to the surgeon to use them as a modifier for certain tasks. And this can be lengths, but much more needed in trauma where we are dealing with defects is alignment and is segmental transport. And here is a little video of an of a lengthening nail, which is modified with only some details, and it shows that we can use lengthening nails in a way that they modified articular axis, the mechanical axis, for example, of tibia, like in an HTO. And within the framework of a study, we have done here cases where we did an incomplete HTO, and then we shift the proximal main fragment according to our needs. And this gives us a good opportunity to stop the valgization process when we see we are just at target, because in standard techniques, we are not always hitting our target point. So how we do this, here just an osteotomized bone. We have an implant which is lengthening. We have an incomplete osteotomy, come from the medial side, very standard technique, but it's not fixed with a plate, it's fixed with a nail, and the nail is motorized and can be controlled with an external magnet machine, which says the nail, tells the nail at what speed and at what rhythm it should be lengthened. Here, a clinical case on a patient with a left side symptomatic varus deformity, has meniscus pain and cartilage problems. So we are planning an HTO and a stabilization with a motorized nail. Here, the first long-standing film after surgery. We see the implant, we see the lengthening nails, we see the locking screws, and now we 5 days post-operatively, we start with the opening process. You see the HTO is opening compared to the post-operative situation, and after day 18 we stop, and we have a very sound callus healing and a very uneventful course of treatment. So lengthening nails not only can lengthen bones, they can modify certain things, and it's up to the surgeon and up to the scientist to develop techniques how we can use them. Another example, this is actually the first case with a plate-assisted segmental transport with a lengthening nails many years ago on the femur with a malignant tumor, plate-assisted for a G2 soft tissue sarcoma with an 8 centimeter resection. We had at that time 2 plates to control length and torsion, and the precise nail does the segmental transport. The transport segment is linked to the nail with a cable in order to transport, because the tip of the nail with the locking option is far too distal in order to use it for the transport. Here, the situation at the end of the transport, and here's a clinical case. X-ray at the beginning of the transport. Here's a cable which takes the segment distally here at docking, and here's the final healing of the patients. Plate-assisted segmental transport can be a very helpful tool. It's very simple. All components are available quite easily. And here a patient with an infected ankle joint, which required further debridements. So it ended up with a loss of the articular surface of the distal tibia. We have filled it with the antibiotic bead spacer, and here we do plate-assisted segmental transport. And the soft tissue situation was difficult, and there is such a short distal main fragment that we did the posterior plating with inclusion of the subtalar joint. How did we bring in that plate? How make we sure that the plate is in situ? We did a transcalcanear retrograde plate osteosynthesis. So we made a little hole in the calcaneus and inserted a plate through the calcaneus along the tibial bone up to the proximal end, and have now a stable situation where we can transport the transport segment against the talus. And here we see it during the transport gap is opening. We transport the segment towards the talus here at the end, at docking, and the docking site is healing. And now within the next couple of months, we are planning to release the subtalar joint, to release the RCD, the temporary joint fixation, because it's not needed anymore. The bone has healed, and we give him at least the subtalar joint. We all know that pantalar arthrodesis is not a very favorable situation, and we give him another joint. We free another joint in order to give him more functionalities. That's the plan. And here, plate-assisted bone segment transport versus bone transport nails. There are a couple of pros and cons, and the problem with the plate-assisted situation is that there is less forgiveness in the execution and very little chance of correcting once the transport has started. Here's the situation of the patient walking with his free flap and his fused ankle joint. Until shortly, there was no modular implant for internal segmental transport. Nowadays, we have segment transport nails, which are helpful, but they only can do segmental transport, and we were looking for a solution where we can do bone transport and also lengthening, because most of our segmental transport cases have shortening in their treatment course. So how can we do both? How can we use the advantage of a motorized nail in order to achieve segmental transport and lengthening as needed? And I show you, we developed a very simple tool which we call Magic Tube. It's just a simple tube which has a slot and locking hole options, and we use the power and the energy of a motorized nails in order to get these two jobs done. Here you see the magic tube is just slipped over the inner part, the extending part of the motorized nail. And when we have a locking screw here through the segmental segment, we can do transport. And if we continue after the segment transport hits the bone, like we see in the middle now, we have lengthening as well. So first, a simple case, it's a 70-year-old male with a 9-centimeter defect and chronic infection and fistula. So he needs significant debridement, and it ends up with a long defect of 9 centimeter. And still we have a little piece of distal tibia left. And I like to show you in the operating theater how we took care of the patient. We first remove the bone cement. Here's the magic tube on the right hand of the surgeon, and now the implant construct magic tube and lengthening nail are inserted antegradely, passing the large defect, which we see here open. We see the slot of the magic tube. The magic tube is sitting on the very short piece of distal tibia. And we do the classic procedure. We do the locking of the proximal main fragment. We define the osteotomy site 8 centimeter above the distal end of the proximal main fragment. We use the jiggly saw to do the minimal invasive osteotomy around the nail. Here we have completed. We checked the functionality of the transport. And now we are able to lock the transport fragment to both aspects. Here we define the magnet location, and with the manipulator we test the device if it's working if the transport is working. We check it with the image intensifier, and then we go back in some sort of compression mode. Here, again, the principle of the device, we can do the osteotomy. The osteotomized segment is fixed with a locking screw to the extending part of the motorized nail, which is in the yellow part of the magic tube. The magic tube has a slot, so the fragment can be shifted distally until it connects to the distal main fragment, and here the docking takes place. And here we stopped in the case where we just saw, but in case you would have shortening, you could continue transporting, and then you would lengthen the leg, like we see here, until you have the desired length. So we have the option of additional lengthening, and at the end, we let the osteotomy consolidate, and all done with just such a simple thing, a slotted tube with a couple of locking options. And here again, the intraoperative situation. Here is the big defect. Here is the distal. On the left side is distal, so we have the locking holes. We see that this locking hole is sitting on the bone rather than in the bone because it's so short. Here's the screw through the slotted cylinder and through the tip of the expanding nail. This is the X-ray situation and how the case works. And here's the post-operative films, pre-operative situations with the large 9 centimeter defect. Here's the beginning of the transport. Here is the osteotomy. And very, very short distal main fragment, slowly transport, and here's the docking situation, and finally the patient has nicely healed. And this is good for the tibia, but the method especially good for the femur, because an all internal transport can avoid knee stiffness. We all know that knee stiffness is a problem when we do external fixation, when we do Elizarov technique, but when we transfer this motorized technology to all internal, we can avoid knee stiffness. And the animation shows it nicely. We are now here in the lengthening mode. This is the only device so far which can do both segmental transport and lengthening. Osteotomy again, then we move the segment, the transport segment to the distal main fragment. If it's okay, that's fine. But if we need additional length, we can lengthening the construct, getting callus formation in the other parts. Here, such a clinical case, from Syria. He got a gunshot injury with a large 12 centimeter defect, and we have different phases of transport: osteotomy, motorized nail, and the distal part is the magic tube. And the magic tube gets transported here with the help of a cable and a plate which broke after some transport. So we changed to a cable and finally to a screw. We have the docking side here. Now we reach the docking. And when we do further activation of the motor, we reach additional lengthening, which is represented by the green line. The segmental transport is represented by the yellow line. The lengthening is represented by the green line. So we have an overall segmental transport of 94 millimeters and a lengthening of 28 millimeters, resulting in a total transport of 122 millimeters. And here's a big advantages. Look at the patient. He is now 2 weeks before end of the transport. He has almost free range of motion with only very few restrictions left. And this is because there is no tractopexia, there is no fixation of the iliotibial tract with the perforating wires from the Elizarov. This gives him 2 weeks before the end of the transport a very good range of motion. Here another case, and we have seen that this works very nicely. And then it would be nice to speed up with a treatment period if we could do not only transport on one segment, but also on 2 segments. Like here in this gentleman, he had a conflict with a train, and he came out with this large 18.5 centimeter defect of his mid tibia with adjacent tibia plateau fracture. So in the first treating hospitals, they recommended him amputation. And then he was brought by the relatives to my department, and we developed a limb salvage plan for him with debridement, vacuum sealing. We fixed his tibial plateau fracture and added a free flap with the help of the plastic surgeon. And now it comes to the reconstructive part. Is it all internal? Can it done with one nail only? And last but not least, how can we achieve a bifocal transport? And here I was stimulated like before by the fish and the mango. Here I was stimulated by the principle of a paternoster. Paternoster is a device where one side goes up, but the other side goes down with the help of only one energy source. So I was thinking maybe I can do 2 osteotomies, one proximal and one distal transport segments and connects them with the Dalmals cerclage to the proximal and distal transport segment, and have a wheel around the proximal locking screws where I can achieve these double the speeds with 2 millimeter per day, one distal, one proximal. We have an equal distribution of force and we have an equal distribution of transport, and this avoids runaway, which we know from other situations. Here, the schematic drawing of our construct. We have a large tibial defect, we have a proximal and a distal transport segment, and it's all connected with a magic tube. One end of the Dalmals cerclage is fixed to the distal transport segment. It goes around a little wheel and it's fixed to the proximal transport segment through the slot of the nail into the hole of the transport segment of the lengthening nail. So this is the view from one side, this is the view from the other side, and here a schematic animation showing the mechanism. We see in the inner part, we see the lengthening nail acting and pulling the two fragments towards each other. Here's the construction, very simple technology, just a tip piece, a magic tube piece, very simple technology, the planning for the positioning of the wire. And here's the situation, pre-op early transport, very difficult to fix the proximal main fragment in with the cables, and here the situation at the end of the transport with good callus regeneration and callus formation. So this is the end for a small demonstration of how we can use motorized implants to do the job we give them, not only the lengthening job, but also the gear. We create gears, and the gears do what the surgeon wants, and the task can be very, very different from only lengthening. So we can transport segments, we can transport two segments at the same time with one nail. We can control distraction, we can add compression force and speed. We can modify also the rhythm of transport. Magic tube is a very simple, modular, universal device. Transition as segmental transport, lengthening without further surgery. And especially for the femurs, this is very nice because it prevents knee stiffness. You have seen the use of a transcalcanear plate, which gives us the option of having stability, but later on we can free the subtalar joint, we can release the subtalar joint again, and bifocal segmental transport with the magic tube and paternoster concept in mega defects might be helpful in the future in order to save time. Thank you very much for your attention.
Thank you, Dr. Krettek. Before we go into
I have one question for you.
Yes, sir.
This is a very good invention from Germany. Now, this motorized nail, when it is going to come to India, any idea, and what is the cost of this nail? Because maybe looks like the way you presented looks like very encouraging for us to go ahead with in future for this kind of surgery. So any idea is when it is going to come to available to us?
Okay, I think when you, I'm not aware that you don't have it, and maybe you speak with the companies. It's one is Precise and the other one is Orthofix. And in terms of costs, they are costing around 10,000 euros. They're quite expensive. But on the other side, you have significant benefits, where, especially in the femur, when everything is all inside, avoiding knee stiffness, avoiding further surgeries, etc., etc. So this is quite promising. But as all new technology, it has its price.
So, Krettek, I have a question now. Can you incorporate smart implant into this? Smart implant which have come into vogue, where the personalized enables personalized medicine, optimize the bone growth measurement and detection of early dislocation, things like this. Especially you are a knee surgeon as well, arthroplasty. Can it be incorporated as smart implant?
Yeah, I think this is clearly the next step, that we have sensors in the implants, which gives us feedback about the strain, about the forces, and about the stiffness of the construct. So we get information about the status of bone healing and osteotomy healing. So there are a lot of options for the future, but in the current situations, it's not yet commercially available, but I'm very sure this will come.
Professor Krettek, thank you very much for your out-of-the-world presentation. We are very happy that you have been with us, and at every of our requests, you have agreed to be a faculty. And listening to you gives us a lot of complexes. We go back with an inferiority complex, honestly. So thank you once again, and we request your cooperation in future as well. Thanks, Professor Krettek.
Thank you. Thank you for having me. It was a great pleasure.
Thank you very much.
Thank you.
There'll be a group photo. Please come in front for the company just to help them. Come.
Yes.
Thank you.
Bye-bye. Thank you. I really appreciate it. All the best. Looking forward.
Thank you. We look forward to see you again. Thank you. God bless you. Thank you.
Thank you so much, sir. Thank you, sir.
Sorry for the brief interlude. We'll carry on with the program, and I think Dr. Thomas Randau is next with his talk on preoperative preparations for total knee arthroplasty. Dr. Thomas is able to share his screen, please. Welcome.
Dr. Thomas Randau is a revision arthroplasty specialist. He's the head of clinical research in arthroplasty and head of the orthopedic rheumatology and osteoimmunology from the University of Bonn, Germany. Yes, Dr. Thomas, you can proceed with your first talk. Yeah.
Well, thank you for the kind introduction, and it's an honor to be here as an international faculty on the International Traumacourse. And after this very complex cases from Professor Krettek, it's getting a little more basic now. And I want to talk with you about knee arthroplasty and preoperative preparations. So this is my conflict of interest. So the facts and numbers about knee arthroplasty in Germany. Currently, we are performing about 150,000 arthroplasties per year in the whole country. And the numbers are pretty stable over the last years. So we have reached some sort of saturation here, but the revision numbers are still going up. Currently, it's around 20,000 revisions per year. And we have many certified centers for arthroplasty. We have a very strict quality management system employed. And so there are around 600 certified centers. And we can claim that we are pretty experienced with arthroplasty, and we are here in rank number 5 worldwide in means of arthroplasties per capita. It's about 222 arthroplasties per 100,000 inhabitants. So we are performing quite a few of them. And still up to 20% of the patients that receive a primary arthroplasty are not fully satisfied with the procedure. So there's still room for improvement. So, of course, we work with a preoperative checklist, and there's many basic things on here that you need to have before you can start with a surgery. And I want to go into some of these and shed some light into this. So I always tell my residents that surgery is a little bit like a marriage. So you shouldn't make any haste, and you shouldn't do it on a first date and not on a first appointment. And you should pick your significant other with great care, because most likely you will spend a lot of time with each other, and most likely your significant other, your patient, will find you for the rest of your life if he's not happy with you. You should make very thorough preparations to have a successful procedure. And honesty always prevails in marriage as in surgery. So always set your expectations right, and always tell the other side what he or she has to expect from you. So in means of indication, in Germany, there's quite strict regulation and things you need to have before you can go into surgery with the patient. And you need to document these things in your patient file. The patient should be in pain for at least 3 to 6 months and be in continuous need of analgesics. You should have, of course, signs of osteoarthritis in the X-rays. You should suggest to the patient a conservative treatment approach first, and this should have failed before you go into surgery. And there needs to be significant loss in quality of life. And I tend to say that the patient should make the suggestion to go into surgery and not the surgeon. So you know that he is or she is ready for this. Also, you need to see that there are no strict contraindications to go on with your procedure. I'm very firm about preoperative planning, because there is so much variation in needs around the patient, and there are so many different cases that you can go. And even though I do perform a lot of surgeries every year, I still plan every single case, and I plan them all by myself. So there are simple arthroplasties where you can just put in the implant in your planning, and you see everything works out. And there's more complex cases where you have modular implants and you need to put them together in the right way. And my plannings are pretty precise. Normally I'm plus minus 1 size. And I benchmark myself on these all the times. And I tell my residents that they are not allowed to go into the OR without a proper planning that they did themselves. And you can anticipate a lot of problems that you will have in the OR if you do the planning before, and you save a lot of operation time if you do this properly. You do need to know your implants. You need to know the contraindications. Many manufacturers, for example, rule out allergies against metallic components. Many manufacturers rule out obesity. and you need to read your instructions to know what your implant has on contraindications. At least in Germany, you need to be instructed on the implant and on the instruments, and you need to have that documented. I'm not sure on the international affairs, but it's always a good idea to know all your tools well. And you need to decide in advance if you need a product specialist present in the OR or not, and if you need to have any special forms signed for that. Also, you should have all your implants available. We tend to have all implants available in double, so in case something goes wrong, we still have a spare in the room. And also you should have a plan B. So you need to know if your collateral ligaments are intact or not. You need to know if you have bony defects or not. And you should always have the next size implant in the hospital in case you need to upgrade from resurfacing to semi-constrained or from semi-constrained to total hinge or rotating hinge. So you should have a good portfolio of implants in your hospital ready. So let's take another look at your significant other, your patient. There has been many studies published on risk factors that the patient brings in. And so there is yellow flag and red flag criteria. You should have a look at the blood cell counts. You should have a look at the hemoglobin level. And you should have a look at the diabetic markers like the hemoglobin A1C. You should also see if he's screened from the dental department, if he has any loose or disrupted teeth. You should see if he's a tobacco user or not, if there are any wounds on the lower extremity, and you should judge very carefully if these patients are really suitable for surgery in your hands or not. We do screening for Staph aureus on all our patients to reduce the risk of them bringing in resistant germs into the hospital. And there's been evidence that you should also screen for sensible Staph aureus, not only resistant, but the screening is quite expensive. You need to bring the patient in a week or so before the surgery into the hospital, and you need to take the swabs. And it might be more cost efficient just to wash all your patients and treat all your patients and just don't screen them all. So there is different body washing solutions you can use. There's nasal ointment you can use to decolonize Staph aureus from the nose. And there's significant evidence that you can reduce your surgical site infections by decolonizing your patients from Staph aureus. So in means of diabetes, there's a lot of different literature being published on this, and to be honest, there's no real clear evidence. So this was a big review controlling patients with and without diabetes, and with well-controlled diabetes with a HbA1c below 7 and above 7. And if you look at the very right side of the slide where the p-values between the two groups are given, you see there's almost no significant differences between these groups. A few things like post-operative stiffness tend to be significant, but the overall complication is not really that much higher in patients that have a badly controlled diabetes. But what I find from my own patients is that the diabetic markers are also surrogate markers for poor compliance. Those patients that show up with poorly controlled diabetes also tend to not follow doctor's orders very well. And so you can take this as a surrogate parameter to see if your patient will follow your instructions or not. And also patients with the diabetes tend to have higher comorbidities, and I will go into that in a few slides again. Many hospitals try to employ urinary screening on all their patients, and there's also good meta-analysis data on that. So if you have patients with a symptomatic bacteremia, you should treat them before, because the odds ratio of complications is significantly higher. But if they are asymptomatic and only the test is positive, it doesn't really matter. You don't need to treat them, or it makes no difference if you treat them or not. And so we do not recommend screening of all the patients. We only do tests if they have symptomatic bacteremia and have pain while urinating, and then we do testing, and then we treat them and delay the surgery for a week or two. So on obesity, there's also a lot of data being published. This one is a big meta-analysis of 37 studies. And you can see the relative risk for any kind of revision raises with the BMI of the patient up to almost 5-fold with an extremely obese patient with a BMI more than 50. And the revision for septic reasons also raises a lot with the increasing BMI. You see also 5-fold for BMI greater than 50. So the problem with the obesity is, can it even be optimized or not? So you can decide not to operate these patients and send them away. And but the problem is you cannot really help them this way. So we are trying to optimize these patients together with a bariatric surgeon and put them in a program where they can lose weight in a very controlled and supported manner. But what we also see from the study that even if they lose weight, their relative risk for complications doesn't really decrease, at least not within the first 1 or 2 years, because their metabolic system is still in a diseased kind of way that it's still programmed on the obesity. So you probably need to wait much longer after weight loss before you do the surgery. But in most cases, this is not really practical because the patients have a loss of quality of life and they suffer and do quite a bit. So in the end, this is up to the surgeon if he takes the risk or not. And again, you need to be honest with your patients. I tell all my patients that they have an extremely elevated risk in the surgery, and we try to argue this together if we are willing to take it or not. So in the last years, the concept of pre-habilitation has been, there's been some raising evidence that this might be a good idea. So you actually start physical therapy and patient education on how to move and how to walk and how to train before you do the surgery. And actually you get better results post-operatively, especially in the early post-operative phase. You have better function and you have less pain if you do a pre-habilitation program. Also, the evidence suggests that these advantages are not that much present after 1 or 2 years after the surgery, but you get the patient a head start. So he comes out of surgery better than without. And especially if you're looking at length of stay and you try to optimize the time the patient stays in the hospital, then this can really help. We do patient blood management with all our patients. And if we look at the German collective of total knee arthroplasty, I'm sorry, this slide is in German, I couldn't translate the images. We have an average of 70-year-old patient, and you see about 15% of these patients come into the hospital already with a preoperative anemia. And so we try to optimize these patients. We can use erythropoietin or Ferinject, this is injectable iron, and we can reduce the length of stay and we can reduce the rate of transfusion quite a bit. And we also use routinely tranexamic acid in our patients when there is no contraindication. And this reduces the blood loss severely in the operating room. So this is really something you should take into account, especially if you're dealing with older patients. So we have a look at the medication that the patient brings before surgery. You should avoid therapeutic anticoagulants if possible. Aspirin may continue. There's no evidence that you have higher risk of bleeding, and the cardiac risk factors always outweigh the possible optimization here. With the oral anticoagulants, we are not bridging them preoperatively. If possible, we just pause them 48 hours before, and after the surgery, we start the patients on low-weight heparin. And we try to go back to the NOACs as soon as the wound is clean and dry. The post-operative NSAIDs have been used for years, for decades mainly, but there's rising evidence that these medication can delay the bony healing. So especially if you're working with uncemented implants, you may want to think about restricting NSAIDs to the necessary amount. And also you need to look into the renal insufficiency, especially in older patients. Many of them rise with the creatinine if you use the NSAIDs too much. We only use single shot antibiotics in the operating room. You need to be aware of your dosing intervals. So especially if you use antibiotics like vancomycin, they should be administered at least 1 hour before you cut into the patient, because they have a long time before they are actually in the blood flow. At least in Germany, there's a rising concern with the legal matters before you do the surgery. You need to encourage a second opinion in the patient, and I think this also comes into the honesty lasts longer. So if the patient asks, where else can I go, you should recommend a good colleague, so he gets another colleague to tell him what to do. You do need to try the conservative treatment and see if it's doing any good. And you should be very honest about expectations, risk, limitations, and success rates. I also tell my patients that there's a 15 to 20% ratio of patients not fully satisfied, and that we have the expectations right. I always tell them that it's possible to do intraoperative modifications as needed, especially in the choice of the implant. If the ligaments are not as stable as expected, that I can upgrade the implant. We have standardized and legally approved informed consent forms, so we're on the safe side of that, and we always give a copy of that to the patient for liability reason. Also, a rising concern is the off-label use of the implants. I told you before, allergies and obesity are a very common contraindication, and often you don't have any alternative, so you won't find an implant that is in label for certain groups of patients. So you can still use them, but you need to tell the patient that this is off-label use, and you should make a note about that in your patient file so you don't get any legal problems afterwards. So we are trying to calculate complications from our patients, and this is from one of our own studies with a large group of knee arthroplasty patients, where we looked at comorbidity score and different lab values, and we saw that especially the Charlson Comorbidity Index correlates with unexpected adverse events, and also with the admission to intensive care unit after the surgery, and also the preoperative hemoglobin level correlates with that. The lower it is, the more likely you are to have adverse events. C-reactive protein also, the higher it is, the more likely you have adverse events. So you can, to some degree, you can calculate, and you can try to put your resources into certain cases where you are most likely to need them. So from my take-home message, the primary knee arthroplasty is an elective procedure, and it can be optimized in some ways. You should look at your patient-related risk factors, and you need to see if you can minimize them. Always plan your implants, even if you consider yourself a very experienced surgeon. Always make a plan before you go into the OR, and have a plan B ready in case your primary plan is not working. And always be honest with your patients, communicate well with them, tell them what to expect, set the right expectations, so everybody will be happy after the surgery. And thank you very much. And these are the channels where you can reach me if you want to get in contact with me. And I'm happy to take your questions.
Thank you, Dr. Thomas. We have really looked into the basics of, as you have told earlier. I'm sure we'll all follow this regime as you explained here. And thank you for that wonderful talk. Any questions from the floor, please? Yeah. Can we proceed with the next talk? Can I invite Dr. Guruva Reddy?
Yeah, good morning. Can you hear me?
Yes, sir. So it's a great pleasure to see you and to even introduce you, because you're such a versatile character. We all love you so much. I'm sure you don't need an introduction, but anyway, Dr. Guruva Reddy is the Managing Director and Chief Joint Replacement Surgeon at Sunshine Bone and Joint Institute, Sunshine Hospitals, Hyderabad. Apart from that, he is the first man, probably, sir, am I right, to introduce this bilateral TCAR?
No, not the first man. Not at all.
Okay.
One of the earlier people, and I got the largest volume of bilateral simultaneous in India.
Okay.
Yeah.
And along with that, computer-aided navigation also you...
Yeah, that's right. Yeah.
You have a huge list of awards, Lifetime Achievement Award, felicitated by the Indo-German Orthopaedic Federation, Distinguished Doctor Award by British International Doctors Association, Then you have acted in also some movies I have.
Yeah, that will be, yes, definitely.
Yeah,
That is
and
me.
last of all, your hilarious speeches, sir. We always look forward to that. Thank you. This is Dr. Guruva Reddy to all of you, sir.
Thank you so much, sir, for that kind introduction. My friend Ajit is there on the screen. I can see that. And thanks for the organizing committee and chairman, Nair, sir, for giving me this opportunity. But I'm slightly confused with that arthroplasty meeting in a trauma society meeting. Hope that there are people who do arthroplasty also in this group. So I'm going to give my 10 commandments for an ideal total knee replacement today. That's basically, I got a high volume center where we do around 4,000 joints per annum, and we got 15 fellowships every year. So a lot of the fellows are given the task of performing the surgeries. So basically, to supervise them, I myself stipulated these 10 commandments so that the outcomes are standardized. So that's all end of the day. These 10 commandments are not given anywhere in the textbook. These are for a high volume center to maintain the standards and the outcomes in a very consistent way. But these will be useful and ideal for any arthroplasty surgeon, whether they are doing 100 per month or 1,000 per month, it doesn't matter. But these commandments should be met with. What is a commandment? A rule that has to be adhered to strictly, and it is mandatory at all costs. These are not guidelines, let me tell you. This is a commandment. That means it cannot be breached or it cannot be negotiated. Those are the important things I wanted to tell. Or these commandments are the endpoints to be achieved before we embark on definitive fixation of implants. So we have a fixed protocol in our hospital where, let us say, 6 operating theaters are running simultaneously with 6 surgeons putting the implants. Every surgeon has to fulfill these 10 commandments. They have to be ratified by one of the senior surgeons, and then only they can put the final implants. Time and again, before implantation, even one commandment is not met with, the senior surgeon will scrub up and see that the 10 commandments are met with. So what is the commandment 1? The neutral alignment in coronal plane in full extension. So that means basically in coronal plane, it should be neither varus nor valgus. It is neutral. Slight varus is okay and slight valgus is okay, but not too much. But absolutely neutral is the sort of thing. So this is a schematic diagram. Slight valgus is acceptable in some of the patients, and varus is definitely a definite no-no. And this is the commandment 1 in the video, and this is the way you see that, and it is absolutely center of the hip, knee, and ankle axis. And now commandment 2, alignment in sagittal plane in full extension. So here there should neither be a residual flexion deformity nor recurvatum. Again, this is very, very important because both are having a lot of morbidity. At least flexion deformity, you can extend it. But if you got a recurvatum on the table, that is going to be a disaster. The one problem which I should never dream of having on the table is a recurvatum knee at the end of the procedure. So be careful, youngsters, never ever a recurvatum on the table. So again, this is a schematic diagram. If you see on the top, that is a neutral, and that is a recurvatum, and that is a residual flexion deformity. Again, a visual or video presentation of the commandments 2. You can see that by seeing both planes, there is neither a recurvatum nor a flexion deformity. Now, commandment number 3, stability in full extension in both the planes. That means varus valgus stress test with the knee in full extension, the knee should feel rock solid. You can see that again, a video representation. Is the knee is now, trials are done. And now I'm giving you varus and valgus stress in full extension. So that should be rock solid. So that is commandment number 3. Again, no medial or lateral joint opening. And that is the ideal situation. And in the bottom scenes, you can see that if the lateral side joint is opening, that means medial side is tight. And the medial joint is opening means lateral side is tight. Now, commandment 4, midflexion stability. That means you should test the stability at 30, 60, and 90 degrees of flexion by applying varus and valgus stress test, and at the same time doing anterior and posterior draw test, and this will show the rotation instability. This is one of the less understood and less performed and less respected commandment in the total 10 commandments. But I would urge all the youngsters to know about midflexion instability and to know how to perform this. This is Larry Dorr showed us how to test the midflexion instability. You hold the heel of the leg in the palm of your hand, keep the right hand free. You're not doing anything. And now You can see that I'm rotating the ankle and at the same time flexing the knee and giving a bit of varus valgus. At the same time, rotation is stable. I'm not putting any pressure with the opposite side. If the knee pops up, that means the rotationally it's unstable, and that should be in 30, 60, and 90. All these three things are important. So this is how you perform the test for midflexion instability. Now, commandment 5, it's called femorotibial tracking. Whether both the femoral condyles are tracking uniformly on tibia during the movement of the knee in the sagittal plane. A very, very important point. You can see that here. Is this the video there? Yeah, okay, video there. Yeah. You can see that now I'm flexing the knee with the patella inverted. But in patella closed also you can see, but these were demonstration sake. See, the femur is uniformly tracking on the tibia until 90. So there is no lift off on either side. So that is a very, very important part of this one. This is commandment 5. You can see that both A and B are equal and equal medial and lateral joint tightness. A very, very important point in the 10 commandments. So if A is more than B, that means lateral tightness in flexion and extension and the vice versa. Commandment 6 and 7 are called polo tests, pull off and lift off tests. Both should be checked and both should be negative and both should be checked at 90 degrees flexion. And I'll show you. This is pull off positive. If you see on the top left diagram, when you do the 90 degrees, that means if you put the hands in your popliteal fossa and pull the tibia forwards, if the tibia comes forwards like this, that means the flexion space is very loose. And I will show you the video also here. So you can see that this is not positive. So pull off should be negative. That means the flexion space is optimum. Like that, lift off. Now, if you see the lift off on the left side, when you flex to 90 degrees, the whole tibial plate is lifting off. And this is called nutcracker or bone booking effect. So that means the flexion space is too tight. If you see here, I'll show you the video again. If you see the flexion, this tibial base plate should not lift. If it is lifting, that means that is called nutcracker effect. That means the flexion space is too tight, whether it's a tight PCL or a big osteophytes. Again, this is a definite no-no in the polo test. So it means 90 degrees, both polo tests should be negative. And commandment 8 is optimum femoral rollback. Again, this is a very important point, which is again less understood. Again, this was explained to by Larry Dorr. When you flex the knee to 90 degrees, the midpoint of the posterior condyles of the femur, the midpoint of the tibia should be on the same line. If let us say this way it is called excessive femoral rollback. And if you see some retrieval symptoms, the posterior 1/3 of the tibial plastic is worn out. The reason is because of this. But how do you measure it on the table? If you can see the middle 1/3 of the upper part of the tibial plastic or poly, that means there is already femur rollback is more than optimum. Only you can see anterior 1/3, not more than that. That is optimum rollback. And let me see in the video here whether I can appreciate that. You can see that that is the one. So if it is seeing more than anterior 1/3 or central 1/3 of the plastic, that means you got an excessive rollback, which is not right for you at all. So very, very important point. Now commandment 8, again, you can see that when you flex that, when you put a scale, you should, the scale should touch the anterior part of the plastic, or you can see here only anterior 1/3 of the plastic is seen. So that is the optimum rollback. That is commandment 8. Now you can see here, I'm telling another video to show it. If you put a scale at the anterior part of the tibia, it should touch the anterior part of the femur. There should not be any gap there. So that's what it is. That is commandment 8. And now let us go to the commandment 9. This is a very, very important commandment. Rectangular and equal extension and flexion gaps. The spacer should move from flexion gap to extension gap unaided and unprompted. Very important part. If you can achieve this, I'll show you the video. That means your flexion extension balancing is good. And I'll tell you, this knee will last for 20 years. Take it from me. Whether it is a Zimmer, Biomed, DePuy, Smith & Nephew, it doesn't matter. Whether it is a cruciate retaining, cruciate sacrificing, doesn't matter. Whether you replace the patella or not, doesn't matter. This single commandment, if the spacer can move from flexion gap to extension gap unaided and unprompted, your knee is wonderful. Of course, this is a stability, everybody knows about that. And these are the 4x4 matrix for medial balancing in varus knees. I just want to show you this video. This is the one which you can see that. I'll show you on the table also. The gap should be, the spacer should move from flexion to extension unaided and unprompted. You should not push it with the hand or anything like that. Now let's see here what's happening. See, that is a flexion gap and the spacer beautifully sitting there. And see, the extension it is moving there. I'm not touching the spacer at all. So that is the way you should get the spacer. You see, even extension flexion, no prompting, no putting another hand and pushing it and pulling it. If you can achieve this, this one single step is very, very important or cardinal. If you get this one, your knee is going to last for 20 years. Commandment 10, patellar tracking without the thumb. Everybody knows about this. There is no rocket science about this. So again, a very important thing, whether you replace the patella or not, immaterial. I have not touched the patella in my last 10 to 15,000 knees. The more important is tracking. If you don't do the tracking properly, that patella will give you the problems. So the last commandment or 11th commandment is watertight closure of arthrotomy, because this is very important, and this will be just a stitch abscess can go into a complete full-blown infection if you don't have the watertight closure of the quadriceps. A watertight closure, both in extension and flexion, will prevent many stitch abscess from going into disastrous zones. So don't underestimate this and don't give it to the junior most of your team members. So be there, supervise, so that they get a good tight closure of the quadriceps in the final commandment. So summary, never neglect any commandment. Each one has a significance. They let you know where you have gone wrong and last chance to correct yourself before you do implantation with the cement. So my friends, if one follows all these 10 commandments, it is bound to good, and the replacement and the outcomes will be excellent. Thank you so much for giving me this opportunity.
Thank you, Dr. Guruva. Fabulous as usual. Any questions from the floor?
Direct 10 commandments from the Bible.
About this pull-off and lift-off, just about the pull-off maybe. Do you do that with the patella put back in place or with the patella everted?
Patella should be there. Patella should be as anterior.
Yeah, that's what I thought. Yeah.
And then you got to put the hands in popliteal position and pull it up. Yeah.
Okay, thank you. I think Dr. Rajiv Nayak has a question.
Yes.
Guruva, good morning. It was a beautiful talk.
Thank you, sir. Thank you.
I just wanted to know, supposing you fix up the tibia and at the end of the surgery, patient starts walking in varus and you fix the tibial plate in varus. How do you know that?
On the table, sir?
On the table, how do you align the tibial plate to which corner of the tibia?
No, sir. Listen, in the varus valgus cut, obviously the mechanical alignment and the tibial cut should be perpendicular to the tibia.
Correct.
And I always keep saying that when you put the jigs and all that stuff, they should align with the hip, knee, ankle axis. Of course, now
no, but why do so many?
We'll have the next session. I think Dr. Reddy and Dr. Chandrasekhar are moderating. Okay, if they're not there, we'll get started. Dr. Adarsh is Dr. Reddy's son, and I think he's trying his best to outdo his dad. He's gone one step ahead and is into robotics. So can we have Dr. Adarsh Annapareddy sharing the screen?
Yeah.
Thanks. Welcome.
Yeah. Good afternoon, sir. Well, thank you so much for inviting me today. I'm Dr. Adarsh Annapareddy from Sunshine Hospitals. I'm sorry. I'm just going to close this one. Yeah. So I would like to thank the Bengaluru Traumacourse as well as the Karnataka Orthopaedic Association, all my seniors, for inviting me today. So today I'm going to be speaking on robotics and arthroplasty. So when we speak about robots, these are the things that come to our mind. There's so many movies, and we have the good guys, the bad guys, you have the Rajasekaran, and our mind automatically goes there. But this is not what the robot actually look like. Most popular robot, I think, has been there for the longest time is the Da Vinci robot for gastrosurgery. This is what it looks like. But today I'll be speaking about specifically our joint replacement robot. We have the Stryker 4th generation robot, the Mako robot it's called. And I'll be speaking about this in, specific and robotics in general. So does it do everything? That's what the question a lot of patients ask us. No, it only assists us. At least this robot, which we are talking about, the Mako robot, it only assists us to make sure that we are not straying outside our predetermined boundaries. We're not cutting more bone than we had planned beforehand. We're not getting any soft tissue injury when we're doing our case. This is an example of the partial knee replacement, the burring, and it has haptic boundaries, and it makes sure that we are not staying outside our predetermined boundaries. As I said before, the surgery is done by us, not by the robot. It's only going to assist us. So it's actually not robotics, but it's robot assisted arthroplasty. So just to summarize, there's a classification of robots for arthroplasty. We have, depending on the movement, there's a boundary control type, semi-autonomous and autonomous. The boundary control, there is a human interaction and the robot deactivates beyond a certain boundary, but it is actually free to move anywhere. The example of that is the Smith & Nephew Navio robot. And then the semi-autonomous is where there's still a human interaction is there, but it's constrained within a boundary and it's fixed to a robot. So the arm is actually fixed to a robot. And that is basically our Mako robot, which I'm talking about, the Stryker Mako. And then there is the autonomous robot, where there's no human interaction at all. And it's constrained within a boundary like the previous two. And this is also fixed to a robot, but there's no human interaction. Like the Merrill or the Max's Cubis robot is completely autonomous. So just a brief glimpse of the other robots. This is the Smith & Nephew Navio. There's a small handpiece, and you can see that it burrs. You can see that it is burring away the bone over here. And then you have the Merrill Cubis robot. The cutting tool. This is a completely autonomous one. You see the surgeon is standing on the side, and you have the robot completely doing its sculpting on the side. So there's no actual human interaction over here. Okay, but our robot is the Mako. So this is the Stryker, is a semi-autonomous. If you can see, there's a screen over here. The robotic saw, the saw is attached to the robotic arm, but the surgery is still being done by us, if you can notice here. So we are looking at the screen, we're making sure that we cut what is told to be cut. It is auto-aligned and it prevents us from straying outside the boundary, but still we have our own tactile feel of the surgeon. So this is not a semi-autonomous. I mean, this is not an autonomous, this is semi-autonomous surgery. So the Mako robot, the Stryker Mako robot, is the only one which can do all three replacements. There's a total knee, the partial knee, and the total hip replacement. But what's the need? There's wonderful results of knee and hip arthroplasty over the years. But what is the real need for this robotic arthroplasty? So there are three core features. Let's go one by one. Let's talk about total knee replacement first. There are three core features for total knee replacement. One is the enhanced planning. Second is dynamic joint balancing. And third is the robotic arm assisted bone preparation. So we categorize these into A, B, C. It helps us to achieve accurate sizing. So accuracy is increased. Perfect gap balancing. So balancing has become like spot on, very objective. And then 100% precise cuts. So once we have determined our plan, it's going to guide us to make sure that we stick to our plan. Our cuts are exactly how we are measured. Even that 1 millimeter or 2 millimeters of human error is eradicated now. So this is enhanced 3D planning. A CT scan is made, and all these films are put together and they're segmented, and then they're combined together to form a 3D model of that particular patient's anatomy. So each case has its own 3D model of that particular patient, and then we do our planning according to that patient's anatomy. So it's completely personalized according to that. So you can flex the implant, you can size your implant. This is all done even before going into the surgery. The next is the dynamic joint balancing. As you can see here, the gaps on the lateral and the medial side, they're balanced perfectly well, depending on exactly what we want. Okay. And then finally, bone preparation. Once you've fed the robot what plan we want to give it, what amount of cut we need to do, it's not going to allow us to stay outside that. We have to remain within this haptic boundary. We don't cut anything more than we need to. And the soft tissues and the ligaments are all protected thanks to this. So now let's move on to the partial knee. This is like sculpting. The partial knee replacement is a technically demanding and slick surgery, and robotics plus partial knee is probably the future, because we have to have sub-millimeter and sub-degree accuracy in terms of partial knee replacement. And by using this robot, we can do the burring, and then we can prevent overstuffing on the opposite, overstuffing on the medial compartment, and prevention of lateral compartment arthritis. This can all be done by proper, precise planning of the gaps and precise burring away of the arthritic bone. And as I mentioned, the medial, lateral, as well as patellofemoral arthritis can be treated with this robot. Then this is just a video of us performing this during the surgery. See, we're burring away, and you can see the accuracy over here. We make sure that we don't stray outside the haptic boundaries. We just remove what bone we need to. Then the total hip in robotic surgery, in total hip replacement, the main challenges are the placement and positioning of the cup, inclination and inversion of the cup, and then of course limb length. All these things can be taken care of by the robot. If you see a manual surgery, if you're going to ream too much, or if you're going to impact too much, you're going to have the risk always of breaching through the medial quadrilateral plate. But here in robotic surgery, it tells you exactly how much of bone you're supposed to ream out, and we don't have that problem anymore. So as I said earlier, inclination and inversion of the cup, limb length discrepancy, all these things can be taken care of and helps to avoid dislocation as well. So the robot helps to address all these things accurately: the cup size, the femur size, the cup's height and depth, the center of rotation, the cup anteversion, inclination, the offset, the horizontal offset, the limb length discrepancy, and the bone stock. Everything is taken care of in one go by the robot. This is a video of how we do a single ream in the operation theater. You can see the green part is the bone that we need to ream out. And you can see we don't have to do serial reaming to check which is the correct fit of the cup, because it's already predetermined, and we just ream out whatever green is being shown over here. And that's it. Once that's done, we do a direct impaction of the final cup. We don't even have to go for a trial. Okay, just as a brief example, this is a right hip arthritis. It tells us beforehand by giving us a nice 3D model that this is 3 millimeters shorter than the opposite side. Immediately we do our planning. We've decided that 44 mm cup with the 127 degrees stem, size 2 with a neutral head is going to give us an equal limb length. So all this pre-planning is done. We don't even have to check it initially. We just do all this pre-operatively. Then we have a nice depiction of how the cup is going to sit. We can determine at 40 degrees of inclination and inversion, depending on if you want to increase it, you can. The transverse view gives us the right anterior posterior fit, and the sagittal and coronal views give us the right superior inferior fit as well. Restoration of the strip, center of rotation can also be done. If you want to medialize the cup or not, we can decide over here. The green dot is the cup that we have placed, and the pink is the native cup. If we determine that medialization by 2 mm is giving us a better limb length and a better offset, then we can do that as well. Then finally, the femoral component sizing, it will tell us two size 2 and 127 neck. There are two types, 127 or 132. And depending on whether we need to increase or reduce our length, we can change our head length as well. This even gives us a pre-operative visualization of the post-operative X-ray. And most of the time we find out that the X-rays are spot on. Just a small video of how this is done. The robotic arm comes in, and then the predetermined green part, as I showed you earlier, we have to just ream away. So we don't have to do sequential reaming anymore. And with robotics, we ream the acetabular once, and the final prosthesis is also directly impacted without having to go for the trials. Okay, you can see over here. And it even shows us how much more medial we need to go, how much posterior, how much superior. We just ream away the green part of the bone. And in one go, you're done. Your acetabular cup is completely ready for implantation. There it is. That's done. And then, of course, the proper impaction is also important. It even tells us how many more bangs we have to do to get the right cup fit, so that you make sure that you're not going to shatter the quadrilateral plate. If you notice here in the bottom right-hand corner, this is a real time, and this is the real-time depiction of it on the computer. And banging, it says I'm 5 proud, and then later, now it's come down to 6, and now it's come down to 2. So it tells us how many more times you're supposed to hit to finally impact the cup. At the end of the day, it gives us a 3D representation of the surgical plan and the end result. And as I said, the X-rays, the cup version and inclination is always spot on compared to the pre-op visualization. What about the procedure time? It looks like it's going to take a lot of time because we have to do a registration of the points, we have to put in the arrays. But now we have found because of the reaming time and the cup impaction time has reduced greatly. Our time has actually not even become neutral, it haven't even become faster. So summary of the benefits in TCAR: accurate sizing, perfect gap balancing, 100% precise cuts, a partial knee replacement prevents overstuffing, and total hip replacement, cup placement, and avoids dislocations. Consistency and reproducibility every single time is what we have found in our patients. Now, if you ask what's the difference between robotics and navigation, I'll just briefly explain the advantages of robotics over navigation. First, of course, we have a 3D CT scan here. So it's an image-based robot. So there's accuracy of the bone registration and the landmarks. Here we can understand the pathology and the location of the osteophytes, bone defects, cysts, quality of the bone, and occult fractures, all before we even go into the case. Then there's the pre-op planning, which you can do again before entering. You can do accurate sizing of the femur as well as the tibia, the positioning, shape matching of the femur. We even restore the posterior condylar offset. Sagittal planning and patient-specific alignment can all be done beforehand. Of course, after that, the part where the navigation doesn't really help you is the well-defined haptic boundary. And there's lots of data from lakhs of CT scans from the robotic around the world. The bony landmarks, robotics, you have, it's already the CT scan is given. So we just have to match these two landmarks in the femur and just show the rotation of the center of the hip. But in navigation, surgeon has to physically locate all the landmarks, and it's hence prone to error, which has been shown in literature as well. Bone registration in the robotics system already has a CT scan. So 40 points on both the bones is enough. It's a very, very high accuracy of less than 0.5 millimeters. In navigation, you have to actually paint the whole bone, and still it is prone to some sort of error. This paper by Sebastian Lustig shows that these three components, femoral posterior offset, tibial sizing, and femoral undersizing, there's a lot of deviation. If you see the green, which is very standard, is the robotic. The brown is navigation, and the blue is mechanical partial knee replacement. See how much of deviation is in these two. But in the robotics, it's very, very consistent. Then, of course, there's joint balancing, robotic versus navigation. Dynamic joint balancing can be done in the robotics. You can just put 2 degrees of tibia vara, 1 degree of varus in the femur, 1 degree external rotation of the femur, and you see how these gaps have been balanced out nicely. But in the robot, the cutting jigs need to be placed manually for all the cuts. It's time consuming, and it completely depends on the surgeon's dexterity. It cannot be reproducible every single time. So why is robotic superior to navigation? The final part, which is completely set apart from navigation, is a robotic arm assisted bone preparation. Here is where we're a cut above the navigation. As you can see, as I mentioned earlier, it auto aligns to the cut which we have pre-planned. And then we can go make sure we do our cut without staying outside of the boundaries. There's sub-millimeter cut precision. So if you just want to summarize that, navigation is only a planning tool like a map, a physical map, but a robot is like a GPS. It's going to tell you where to go, what is the speed, what is the weather, what is the traffic. It's going to tell you everything, and it helps you reach the target, and you can reach the target certainly without any doubts. This is only going to guide you, and you don't know whether you're going to end up there correctly or not. Once again, not all robotic systems are the same. Literature of one cannot be extrapolated to the other. I'm talking strictly about the Stryker Mako. There are other robots like the Rosa, the Navio, and the Cubis. And this is just a summary of the advantages. I'm not going to go into this right now. So if yes to robotics, then why Mako? There's so much of good data here. This is the only CT-based system. It recreates a 3D image of the patient's anatomy. It has an intelligent tool holder without any cutting jigs. It's the only system for all three primary applications. That's the partial knee, total knee, and the total hip. It has the haptic technology combined with the 3D data. And there's actually now this is more than 1,000 systems around the world. But what does it mean for the patients? At the end of the day, the patient's satisfaction is more important than anything else. So less pain in the 90-day post-op period is what has been found, robotic versus manual. 92% patient satisfaction at 2 years. And that's again more than the conventional, sorry. Everything is less over here, less bone and soft tissue damage, less need for analgesics, less time to discharge, less post-operative pain. Again, the accuracy and in the femoral component and the tibial component is much more compared to manual partial knee. And we have also summarized our advantages in this particular slide. You can just take a screenshot of this. Our journey with Mako was first we launched our Sunshine Orthopaedics department. It was inaugurated by PV Sindhu. She used the robot for the first time on the sawbone. And right now we are standing at 1,205 social surgeries in spite of 2 lockdowns. And majority are total knees. We have done, now we're increasing our numbers in partial and hips as well. So what about our outcomes? That's what matters. This is a Mako unicorn. It's the very second day after surgery. She's walking, not only walking absolutely normally, but also able to sit and squat and speak to us without any pain and without any problem at all. And this gentleman, this is 1 week after bilateral partial knee replacement, going for a walk in his garden. Day of surgery itself, this gentleman is able to do his straight leg raising. This is probably because we are doing very, very little amount of soft tissue release. And this is probably, we're not changing the malio-interior of the knee joint. Gross deformities can also be taken care of by the robot. Perfectly nice, straight joints with perfect balancing. Valgus deformities have also been corrected by us. This is a severe valgus deformity, which we managed to get nice and straight just by using the robot and doing the balancing. This is a bilateral total hip replacement for a 37-year-old woman. This is 1 month post-op. And this is our first batch of robotic patients that we had done. So why are we getting better results? It's not that the robot is some God's gift or something suddenly come from out of space and helping us. Basically, the reason is we are maintaining the internal homeostasis of the knee, titration of the bone cuts. So we are in functional alignment. So that leads to less amount of ligament release and indirectly less amount of pain. The haptic control, there's less inadvertent soft tissue injury, and there's less time with the knee subluxated. We don't need to subluxate the tibia until the tibial preparation now. Even while doing the tibial cut, it's all done without subluxating the knee. Our study, we're doing a study where we're doing a double-blinded randomized control trial comparing patient satisfaction, one side robotic and one side conventional, to see which one has more comfort. And right now we're more than 80 cases, around 95 cases we have recruited. And we're going to see how the 1 to 2 year follow-ups are doing. The future of robotics, especially Mako, the hip is going to show, the upgraded software is going to give us more information about impingement and spinopelvic abnormalities. And they're going to come up with the shoulder replacement as well in the near future. Thank you so much for the opportunity.
Thank you, Dr. Adarsh, for your lucid presentation.
Thank you, sir.
There are some questions which we would like to ask.
Adarsh,
Yes, sir.
are you doing all your surgeries robotic assisted or conventional? First, that is the question. Second,
Yes, sir. Go ahead.
second question is, if at all we are going only with the robotics, are we losing our pre-operative and per-operative skills?
It's a very good question, sir.
Want to be
So, we never expected to be doing so many numbers. We thought that we'll have maybe 5 to 10% patients opting for the surgery. But we were pleasantly surprised to see, but once we give the option to the patient, they're willing to shell out a little bit of extra money to do it. So right now we have 2 branches. In the Gachibowli branch, the high-tech city where it's closer to the IT crowd, we're doing almost 85% of robotic surgeries and maybe 15-20% are manual. But in the other branch, we're still doing a good chunk, 70-75% as manual. So one thing is we still need the surgical skill even if we're using the robot. It's not that the robot can come and any young person who has no experience can use it. You still need to be able to have that feel. You still need to know how to balance the joint. But it's a completely different skill set than we need for manual. But again, as you said, we should keep in touch. Just like driving an automatic car, should always drive a manual car once in a while. Otherwise, you're going to forget how to put your gears. So we are still doing 70% of manual surgeries in the other branch. So we are not losing the touch with that.
So conventionally, when you are doing, you are shown that there is a little difference when it is done with the robotics, robotic help. Why that happened? Whether we are losing our touch or it is technical error?
No, sir. So it's not a technical error, but as I mentioned earlier, there are few things that we are doing little differently in the robot. As I mentioned, initially we were thinking only of mechanical alignment in the conventional cases, but in robots now we are accepting functional alignment. We put the joint in maybe 1 to 2 degrees of varus. By doing that, amount of soft tissue release, amount of MCL release is reduced a lot. So we're not actually, we're doing much less amount of soft tissue release. And on top of that, we're not subluxating the joint. So probably these things are leading to less amount of pain post-operatively. That's what we are hypothesizing.
Yeah. Can I add a minute, sir, with your permission?
Yeah, please.
Yeah, because basically after your answer to your question, after the robotics have come into picture in our institute for the last 18 months, in fact, the way we are doing the manuals also changed because our perception has become much more clear because we are not afraid of cutting the tibia into 5 degrees varus manually also to get a functional alignment rather than be slave to the mechanical alignment. So in other words, our understanding has become much more in getting this functional alignment without disturbing much of the soft tissue release. with more aplomb and with more clarity, thanks to the robotics.
There any more questions?
Yeah, can I just ask Dr. Guruva?
Yes, sir.
Yes, yes.
Dr. Guruva,
Yeah,
in your own inimicable way, can I ask a question?
yeah, please.
Aren't you a little, what do you say, uncomfortable being driven by the lady at home and by a machine in the hospital?
I know, Ajit, what's coming. I'm used to that. Only thing is the robot, I call it as a man. Yeah, but in sense, as Adarsh has already very much summarized that, I will tell you that robotics are not the panacea, number one. But number two, it is a very good technology which is going to give a lot of things. Because I realize that whatever this uncomfortable 20% of the knees might be because of our slavery to mechanical alignment. So probably the future will hold some more answers for us. So that's what it is.
Sir, if chair permits, I can ask some questions.
Yes,
This is
Dr.
Dr. Rajkumar from St. John's, Bangalore. Thank you, doctors, for your lucid presentations, both father and son. One thing that I would like to ask you is, what is your tolerance for doing unicondylar knee for a varus knee?
That
All
Adarsh
varus
will answer,
knees,
sir, because I don't do
unicondylar.
partials. He is the man.
Yes, yes, that's what I wanted to ask, sir. And then second question would be, how do you manage pain, and what is the cause for pain post TKR, whether it is robotic assisted or whether it is a natural way of doing your conventional TKR?
I think I'll answer the first question, sir. Thank you for the question. So we do TKRs, I mean, partial knee replacements in varus even up to like 10 degrees, and even maybe like up to around 15 degrees, because now we have objective data showing that, okay, this is 10 to 15 degrees, but whether it's correctable or not. If it's a correctable varus deformity, that means that the MCL has not been contracted. We can recreate the native knee. But again, we are not a slave to complete neutral alignment. We can leave the knee. In fact, papers are showing that if you undercorrect the knee a little bit in partial knee replacements, maybe bring it down to like 5 to 7 degrees. If it's like up to 15 degrees pre-op, we can leave it around 5 to 7 degrees post-op, depending on the pre-op angle. So if you're only around 6-7 degrees pre-op, then you can think of bringing to neutral alignment. So we are okay as long as it's a completely correctable varus deformity.
You think osteotomy can give the same results as your unicondylar, or you think unicondylar knee replacement is superior to osteotomy?
I don't think it's superior. We don't have much experience with the high tibial osteotomy, but the indications are slightly different. High tibial osteotomy, usually if there's not enough bone-on-bone arthritis in the X-ray, if it's reduced joint space, but without actual bone-on-bone, I would probably think that a high tibial osteotomy, I don't do unis for those kind of patients. I only do a uni if you can see complete bone-on-bone arthritis on the medial compartment. That's the only time when I actually advise a unicondylar. I don't think it's a mutually exclusive club.
Were there situations in your practice wherein you have done unis and the patients have not done well? And what are those kind of patients that you want us not to do?
No, sir. I think it's all about the proper indication selection. We were like, when I was training on this with the Oxford group and then later on with the MACO, everybody was stressing on the fact that you have to choose the right indicated patients. So we have managed to do that. So we have had quite good results with the unicondylar. Maybe 1 or 2 obese patients had a bit more pain. I had one single tibial condyle fracture with a very obese lady, osteoporotic lady. From then I've reduced my cutoff, BMI cutoff. So I'm doing a little bit less obese patients. I'm accepting now. But no other contraindications if you have proper bone-on-bone arthritis with a correctable varus deformity.
Okay. To the second question, how do you manage pain post TKR or post unicondylar?
I think I'll hand this part over to Dr. Guruva because he spoke about the 10 commandments.
Yes, yes.
I think the advantage of father and son in the same group. The pain control, we got a fixed multimodal attack. Starts with the preemptive analgesia. We will give Celecoxib 400 milligrams tablets, pregabalin. And now, in fact, we are contemplating of adding a steroid also preoperatively, and diabetic control. And prehabilitation is also one of the very important aspects for us. We have, let's say, preoperative knee school where we educate the patient about the pain control. And then post-op, per-operatively, we have we don't use any drill. And then post-operatively, we put them on paracetamol drips, and occasionally we use them patches, and that's what. And robotic knee replacements in the last 1,200 knees, the consistent clinical indicators for us is the post-operative pain is significantly less. There is no doubt about that. At least first 2 days. By the time the patient gets discharged, because now we have, let us say, in our Secunderabad branch, every day we do around 20 joints. Out of 20, around 10 robotics and 10 manual. All of them lie down in the same surgical ICU, one to next. And you can just by walking down the aisle, you will know who is the robotic knee and who is the manual knee by looking at their face. I'm telling that much confidently, the pain control in the post-op, robotic.
So considering the present scenario that you are exposed to, both father and son, what is your message to the youngsters? To go your way or to go your son's way?
No, sir. It's not my way or his way, sir. It is Rajasekaran is I'm in the audience. I'm sure he would agree. There is definitely a role for technology. As in Rajasekaran's famous sentences, you should not be the first one to embrace it, and you are not the last one to disgrace it. So you got to be somewhere in the middle, which we have done it. And we feel that we hit the sweet spot, because the evolution of the technology, somebody has to be pioneers, somebody has to follow it, but somebody cannot be skeptic throughout the lifetime. Robotics has definitely got a role. And I'll tell you, sir, in the next 10 years, mark my words, with artificial intelligence and big data coming, a day will come where my son can sit in the operating theater and with a gross horrendous deformities, robotic will tell, look, my friend, go there, release up to here, stop. Go there, take this osteopathic, stop. Cut this tibia 5 degrees, stop. Cut the femur 3 degrees, stop. Now you got the knee joint fantastic in place. That algorithms will be in place 100% because the artificial intelligence and big data is already coming up in a big way in knee replacements. That is the future. There is no doubt about that. But it is not that all the youngsters should embark on robotic just for the sake of marketing. No, full stop. It will not happen at all. At the same time, they cannot just lie down there and see the robotics take over the arthroplasty. It will come in 5 years. It will be like a Siam.
Thank you, sir. Thank you very much for this wonderful interaction with us. God bless you all. Bye.
Thank you, sir.
Thank you, Dr. Guruva Reddy and Dr. Adarsh for your clear, concise concepts. We proceed to the next talk. We request Dr. Thomas Randau to give his talk on interactive discussion in knee revision arthroplasty. Dr. Thomas.
Thank you very much.
Yeah, we can see your slide.
Okay, perfect. So this is hopefully a little more advanced. And so I would like to get in contact with you and with all the audience and the live stream. So I hope the technique works. I have here for you a QR code that you can scan with your mobile device, and it should take you to the online TED of our university and should allow you to participate in our little discussion group here. And hopefully you will see the first question. Okay, I see a few coming in. I have the QR code on all the following slides as well. So if you missed it on the first one, you can still log in.
Yeah, we're just scanning the QR code, Dr. Thomas. We are just getting it open.
Okay.
Yeah, I think it is open now. It says give us a few seconds. We are just opening it in the audience.
Perfect. So also for those people watching the live stream, it should also work for you as well, as long as you're watching it live.
Those who are seeing it online, they can use their mobile and scan the code.
Exactly.
I think this will take a few seconds, sir. We're just getting it there. think it just opened University of Bonn. Is that the one? Welcome to the interactive case presentation. Great to have you here. Have you used the online TED before? Did you get that?
Yeah, very good.
Some of them are just opening it. They're just getting it there.
Okay, I see a few votes coming in. So
Yeah.
I would say we just proceed, and we will have some questions coming in, and I will show you how it looks on my side. So I have the website, and I see
Has it opened?
Coming in.
Huh?
So I will close the vote on the first question because I think we are advanced in time and we need to continue.
Okay.
And so I see how you voted.
Have we used the, okay.
So about half of you have and half of you have not.
Yeah.
And so we will just continue with the presentation and see how it goes. So I have the first case for you. This is a female patient. She had her first hemiarthroplasty in the knee in 2007. She was never happy with that. She was changed to a full arthroplasty in 2010. She had some instability of the knee and an early loosening of the implant, and she was changed to a rotating hinge in 2015. She's a very adipose lady. She has a BMI of 48. She has arterial hypertension. She has a COPD. She has obstructive sleep apnea, and she smokes about 10 to 15 cigarettes a day. And she's in constant pain. She takes metabizole and NSAIDs permanently. She is limited in her extensor strength, and she's walking on crutches as she is presenting in our hospital. And these are her X-rays. You see rotating hinge arthroplasty, cemented stems. You see somebody move the tuberositas and try to fix it with screws. And so now this is our first case. And so the question is, what is your routine in these cases? So would you say she's too big and too sick to operate on, and she definitely needs to be sent somewhere else and not my hospital? Or do you say, I do some lab stats and see how her CRP and ESR and white blood cell count is, and that will do for my further diagnostics? Or do you also perform a bone scan, a scintigraphy, and a CT scan for some of these three? Or do you also necessarily perform a joint aspiration for cell count and microbiology? Or do you think you must do an open or arthroscopic sampling? So you should see on your smart devices the question for you to vote on. If you missed the QR code, you can still scan it on the upper right hand of the slide. I see some votes getting in. It's all anonymous. I don't see who is answering what, so feel free to hit whatever you think might be correct. The more people participate, the more fun it will be.
Yeah.
I hope this is working from the technical side for you.
So have we got the answer for this? We can't go back.
So, okay. 40% stop at the bone scan and scintigraphy. 40% also want to do the joint aspiration, and another 20% say you must do open sampling or arthroscopic sampling. So here's what we do. The lab stats in this case showed a CRP of 10 milligrams per liter and no raised white cell blood count, and ESR was normal. The scintigraphy says signs of loosening, femoral and tibial side. The CT shows that the tuberositas is not healed, and there are signs of loosening of the implant, but there's no malalignment. We always do a joint aspiration in all patients that present with a painful arthroplasty. For us, it's mandatory to do aspiration, cell count, and microbiology. We also do molecular biology and PCR on all our aspirates now. And for open sampling, I'm not really a great fan of that. There's mixed evidence if it's good or not. And so it's not mandatory to do this. but we keep it for those cases where we're not sure and we don't get a clear result from the aspiration. So in her case, the aspirate stays sterile. She has 700 cells per microliter and less than 50% of neutrophils. So all in all, no typical sign of infection except for the raised CRP. So this is the X-rays, just to remind you. And so now the next question is, we go in, we take her into the operating room, and in the operating room, the arthroplasty seems to be some kind of loosened, so it's not falling out of the knee, but you can remove it very easily. The PMMA is not loose as usual, takes a lot of chiseling to remove. There is slimy synovial-like interface membrane, slims everywhere. It doesn't look very good. It has this glassy, slimy touch to it, and the tuberositas, as expected, is not healed at all. So how do you proceed in the operating room? Do you perform a cemented one-stage exchange, cement in cement, so you just leave the old PMMA in there and put a new cemented stem in? Or do you remove all the PMMA, will take you about 1 hour, and then use a new cemented or uncemented total knee arthroplasty? Or are you uncomfortable with the synovial-like interface membranes and stay on the safe side, explant, debride, take samples and do a temporary PMMA spacer? Or do you explant debride and say, okay, with this tuberositas extension strength deficit, you will be safer with the arthrodesis? Just go back to the X-rays for you once more. So you have those as well. So I'm looking forward on your answers. Let's start the countdown. Your last chance to vote, please. So half of you decided on explant, debride, samples, and PMMA, and the other half decided on either cement in cement or remove the cement and but one stage exchange. So as usual in revision arthroplasty, there's no really right and wrong, but I can tell you what I did. I like safety, so I decided to go with a PMMA spacer. I use titanium rods and I coat them with a PMMA containing vancomycin and gentamicin. And I link these rods in the joint space to make a very stable construct. And I fill the joint space with a PMMA. And then I started her on antibiotics. In this case, I used clindamycin because she had a reaction to cephalosporins in the past. And the microbiology samples stayed negative in long-term culture for 14 days. And our pathologist said it's a type 2 and type 4 synovial-like interface membrane. So that's mixed type, maybe infection, and maybe just wear particles. So you can anticipate my next question. So what would you do? 14 days without growth in the microbiology and mixed results in the pathology. So do you continue your antibiotics for 6 weeks and plan an arthrodesis, or do you continue your antibiotics for 6 weeks and plan on a re-arthroplasty, or do you want to do the arthrodesis right now or the arthroplasty right now, or do you go drastic and say, okay, this has no gain and you amputate, or would you like to refer the patient somewhere else and go have lunch? Okay, I start the countdown. Please vote if you haven't done so already. Okay. So half of you decided on continuing the antibiotics for 6 weeks and plan an arthroplasty, and the rest wants to do arthrodesis either after 6 weeks or right away. So if we put all the facts together, we don't really have any sure signs of infection except for the pathologist who's not really sure with the tissue samples. So this is the only hint we had. But I do trust my feeling intraoperatively as well. And if I had the feeling that there was infection when I removed the implant, I tend to go for the long interval as well. So in this case, we decided on safety first, and we decided on a long interval. And since we had some time, we decided to create a custom sleeve for the tibial side to address the problem with the non-union of the tuberositas and make a stable tibial implant. So we made patient-matched implant for the tibia. And in total, we had a reoperation after 10 weeks, and we put in a condylar replacement implant on the femoral side, and we put in the custom tibia and made it a uncemented stem on the tibial side and a cemented stem on the femoral side. And all in all, this was the final result. She was initially very happy, but she comes back after 10 months, acute swelling and pain. Now the joint aspirate is positive, is 5,000 cells per microliter and 20% neutrophils, which is not typical for infection, but still too many cells. The CRP is raised again, the white blood cell count is normal, and we suspected a reinfection. We did a DARE, the implant was stable. We started her on antibiotics again. The microbiology was again negative and didn't show any pathogens. And currently she has a mediocre outcome. Her extensor deficit is still there, but she can walk using her crutches. She's almost pain-free. But in the end, the outcome is not perfect. So I showed you this case because even after a month of treatment, we're still not really sure if she ever had an infection or not, because we never had any pathogens growing in the samples, and we had mixed results from all these different diagnostics we did. And so I want to ask you, what is your most trusted diagnostics in cases of these revision arthroplasties? How do you diagnose infection? Is it your cell count and the neutrophil, the cutoff at 3,000 cells per microliter as the MSIS suggested? Or would you rather use the leukocyte esterase because it's so cheap and effective and you can just use your sticks? Or are you a fan of alpha-defensin and use the Sonova Sure? Do you say microbiology is the gold standard? Or would you go with E, always the full picture and all of the above? Start the countdown. So we have the votes coming in. Okay, so most of you voted all of the above, and I agree with that. That's why I highlighted it in green here. So you should always try to use as many options as you have. And so if you don't take a temperature, you can find a fever, and you should always consider infection as a likely cause of the problems the patient is having and rule it out. The cell count and the neutrophils are difficult with a low-grade infection. You do have pathogens that will not raise your total cell number, especially Cutibacteria and some of the coagulous negative staphylococci will not cause a high number of neutrophils. The leukocyte esterase test is actually just a surrogate for the above, and if it's possible to count your cells, it's better to use that. The Sonova Sure is quite expensive, and the sensitivity is not as high as some companies suggest, but the specificity is very good, but you can't fully rely on a negative result. Infection might still be present. And in microbiology, as I showed you in the case I presented, up to 30% of the cultures can be negative. There are certain pathogens you cannot really detect, especially if you're dealing with anaerobic culture. It's hard to do, and the pathogens will die on the way to the lab, and small colony variants will escape the microbiologist, and you need a very long culture, so 14 days of culture should be mandatory. So I would have another case if we still have the time. Is it okay if I present another one? Okay, so this is a male patient. He came to our hospital first in 2014. He also had a medial hemiarthroplasty in 2010. He had an infection in his two-stage exchange in 2012. Then he fell on the knee. He had a loosening and another exchange in 2013, then an early infection, and then a reimplantation of a cemented rotating hinge in 2014, and a reinfection in 2014. And this is the clinical image that he comes with in 2014 to our hospital. So he's quite sick. He has heart insufficiency, renal insufficiency, diabetes, atrial fibrillation. He's on warfarin therapy, currently paused, and on fractional heparin. He is cardially sick. He has a BMI of 30 and also sleep apnea. And this is the last antibiogram that he brings from the germs he had, so still treatable from the microbiology point of view. And so the question to you is, what are your options in this case? So you would do a one-stage exchange with a plastic surgeon and try to cover the soft tissues. You would remove the arthroplasty that is in place, put in a spacer, and wait for two-stage arthroplasty, arthrodesis. Or would you try to debride and retain the implant and cover the soft tissues and put in a drain because you can't cure the infection? Or would you do no surgery at all, use antibiotic suppression and a wound management, or would you go with amputation in this case? I'm sorry I didn't include the X-rays, actually, because he was referred from an external hospital. I couldn't find them anymore of the initial presentation, but I will have X-rays later on. So I start the countdown on this one. Okay, so very, very mixed results also on your side. Almost every option is presented. Only D, nobody's choosing, no surgery, antibiotic suppression. So, well, we are surgeons, so of course we want to go into surgery with them. And we decided on the two-stage approach. So this is our first spacer that we put in, and it didn't work, it failed, it broke again. And we did several approaches using wires, using rods. And in the end, we managed to stabilize this, but it took us quite a few tries. And he had, with the soft tissues, he had problems all the time. The wound was draining all the time. So it took us about 2 months and 12 surgeries to get to this result. The soft tissues are covered, but the skin is not. And there's a stable spacer in there. So we decided to use arthrodesis, and this is the arthrodesic nail we put in. This is uncemented on the tibial side, cemented on the femoral side, long interval, and this is the soft tissues afterwards. And we decided that the capsule is closed and there is muscular tissue everywhere, so we used a vac to cover this, and then we did a mesh graft on the skin. And so this is the final result that we had after more than a dozen surgeries on this leg. So what do you think? Do you think this is a good idea? We can use VAC on arthroplasty to condition the wound and to make the skin graft in the end? Or do you think we should have used the flap already when we explanted and put the spacer in? Or should we have used the flap at the reimplantation stage? Should we have shortened the leg severely to allow for soft tissue and wound closure without any flaps and without the VAC therapy? Or do you stick with amputation and say we should have amputated this in the first place? Okay, I start the countdown. Okay, so quite a few of you agree that our result is acceptable and that we did well and the VAC was good to put on there. And 20% say we should have amputated in the first place, and 20% say we should have used the local flap at the reimplantation. So I will show you what happened with this case. At the reimplantation, from the microbiology point, we had a candida. Excuse me. So we now have a fungal infection of the newly put in implant, and the patient refuses further surgery after more than a dozen surgeries in our hospital. We start him on IV antimycotics for 4 weeks and oral antimycotics for 12 weeks. The soft tissue further healed, but after a few weeks, a fistula formed at the medial tibia. The patient was able to ambulate and to walk with a stick. But in the follow-up X-rays, you see what happens. The implant is not stable. The tibial side goes into the bone, and during the months, it starts going into the ankle joint and into the lower ankle joint. And so there's no stability. And we talked to the patient again and again and told him this is not going to work and he can't walk on this anymore and we need to reoperate. But he refused any surgery. And in the end, we suggested amputation because we couldn't imagine how to save the leg, and he refused surgery. And so this is the state that he ended in. So last question for this is, what do you think? We never should have taken the case in the first place. There was no real chance of success. Or do you say, well, we saved the leg, so we take it as a success for some years? Or would you say now the amputation is inevitable and you should have done it in the first place because we just caused false hope, years of pain and some immense expenses? Or do you have a good idea how to solve this case now? And I can send them over to you. Far trip, I know. So I'll start the countdown. Excellent. Well, thank you for your kind words. But in retrospect, you see, this is an older case of mine, and it's quite a few years ago that I treated him. And I picked this and showed this to you to show you the complexity and also our learning curve. So in retrospect, I think we didn't do too well. We should have used the flap before, and we shouldn't have relied on the vacuum therapy to close the wound, because I'm pretty sure this is what caused the fungal infection to go into there, because it's not really a closed system and not really as sterile as you might think it is. And so in retrospect, I think if you had used the flap, either at explantation or at the reimplantation, we might have been more successful on this. And even more in retrospect, I think if I would see him today, I would probably advise earlier to amputation, because my experience is that when patients are well educated and well informed on the possibilities they have after amputation, then they can agree with this treatment as well, and it would have been much faster for him, and he would probably be able to walk with the exoprothesis and wouldn't have had more than a dozen surgeries and quite a lot of trouble. And so I'm looking forward for those of you who said you can still save him and solve the case. And so with this, my presentation is finished. I'm looking forward for your suggestions and your questions. And if you want to stay in touch with me, please use any of the channels here shown. Thank you very much.
Thank you, Dr. Thomas, for an excellent interactive session. And you have used the latest technology using the QR code, which we have learned now. And we will use this technique to have more of our interactive sessions. If there are any questions from the audience, I think all the answers are there in the most of the questions which we have seen. So if there are no more questions, thank you very much, Dr. Randy. Huh? There is a small question from the audience, Dr.
Yes,
Thomas. They would like to know, how old are you?
How old I am? I am 40 years old.
that is one of the questions asked by the audience.
I am 40 years old.
Oh, Dr. Thomas is 40 years old. Okay, huh?
We should say 40
the audience replies that they envy your age. Okay.
I think Thomas must say that he is 40 years young.
Yes, Dr. Rajasekaran, thank you. 40 years gap. Yes. Thank you, Dr. Thomas, for a wonderful interactive session. It was really wonderful. Thank you.
Thank you very much for having me. Thank you. And
we go on to the next session, and that is the spine. And we invite the moderators for the spine session. Dr. Subodh Shetty is here, and please come, Dr. Subodh. Dr. Narendra Sidulingaya.
So we are into our last session today. It's on spine, and we are lucky to have Professor Rajasekaran and Dr. Ram Chaddha here with us. In fact, Dr. Ram Chaddha is come here in our venue, and we hope Professor Rajasekaran was also here with us. Yeah. So just we have very good topics on vertebroplasty, which would be covered by Professor Rajasekaran. Just as a small introduction, I would invite Professor Rajasekaran, Chief of Ganga Medical Center and Hospitals Private Limited. He is just to brief about this never-ending thirst for research. Just to mention, he has more than 500 publications in international journals and more than 1,000 national presentations as well. So today we are very happy to have you, and your presentation would help us to know more about vertebroplasty, which is your first topic. I invite you, sir, for the talk.
So thank you very much. I should actually start off with thanking all of you and the organizers, and Raju especially, for allowing me to be with all of you here, although by technology. So my topic is on vertebroplasty, and Rajiv asked me to actually concentrate more on the technique of vertebroplasty. Now, this is going to be important, but as we know that the world is continuously aging, and there are more than 700,000 vertebral fractures, osteoporotic fractures every year. And although more than 70% of them heal very well, at least 30% ends up in painful pseudoarthrosis. And for these people, if you are able to do a cement injection by a minimally invasive technique, the pain relief that they get is dramatic. And it's a very, very useful armamentarium to have if you're going to actually practice geriatric spine surgery. Now, it is not only used in the fractures, but also it's very good in isolated metastatic lesions and myeloma especially. And also in painful vertebral fractures associated with osteonecrosis, and in vertebral hemangioma. It's one of the very important and easily used techniques. Now, you have to be careful about the contraindications because it's an easy procedure, and there is always the idea, a temptation to do more and more. So if you have to be sure that there is a pseudoarthrosis, and if there is fractures with associated neurological injury, then most probably that means that there is a possibility of a cement leak behind. And when there is a neurological problem, you always do an open surgery with decompression and stabilization, and not just do a vertebroplasty alone. Now, spinal canal stenosis, and of course, if there is any suspicion of infection or coagulopathy, you do not do it. Now, patient selection is the key, and this has to be both clinical and radiological. Most important is to remember that the pain usually is not exactly over the site of the fracture, but it is in the lower back and there is severe loin pain. And what gives them pain is the change in posture. I mean, once they are lying down or sitting or standing, it's not bad. But changing from lying down to sitting and from sitting to standing is very, very painful. And in radiographic evaluation, you carefully look for the pseudoarthrosis as you see over here. If you have a clear pseudoarthrosis with a gap like this, there is no issue. These are the patients who give very, very good results. And then if you also must, wherever there is a doubt, you always employ a stress view of flexion and extension, and you can always find that the kyphosis of that wedged vertebra changes. And if you can demonstrate that, along with this, what we call as the alligator sign. So when you take a lateral view in an extension view, you will find that the pseudoarthrosis becomes wider, and the two end plates actually become opening up, just like the jaws of an alligator, and this is called the alligator sign. Now, if you can demonstrate this, these patients have excellent results. Very often when you look at radiology, it's very confusing because there are multiple fractures over there. And you need to use the T1, T2, and also the stir images so that you have to be sure that it is benign compression, and you have to differentiate it between the acute and the chronic. And also you have to be sure that it's not a pathological fracture before you will take up these patients for. Now, as we told, I mean, with neurological compromise and if there is an infection, then you don't do it. One another question that is frequently asked is, in the same sitting, how many vertebra can be injected? Now, mostly you do one, sometimes two, but rarely three. And we do not do more than three as a rule because it can be deleterious on the cardiopulmonary system due to cement, fat, or marrow embolism. Now, the technique is very important. You can do it in general anesthesia, but in high morbidity patients, then you can also do it under a paraspinal block and also under mild sedation. What is very important is that you should be able to get a good CM, AP, and lateral images. And if you're not able to get that, you should be very careful. If you're using transpedicular approach or a parapedicular approach, now radiologists frequently use a parapedicular approach, but we surgeons use a transpedicular approach. The positioning is very important. And what is most important is after you position the patient, you apply a gentle pressure over the spinous process of the cranial vertebra. And then you will see that actually the spine completely opens up. Here you can see that between before and after, you can see that the end plate has opened up and the pseudoarthrosis is much clearly seen over here. And this makes your entire process simple. Now, Rajiv asked me to concentrate on the technique. And so this was a video which I just made recently for one of the big conferences. And so this is a 7 minutes video. I will just put it on. And you can see that the technique is very well explained. So the entire success of the vertebroplasty procedure depends on two things. One is to pass the needle into the pseudoarthrosis mass without violation of the medial wall of the pedicle. And secondly, to accurately place the tip of the needle inside the pseudoarthro. Oh, I'm sorry for this, yeah. So the entire success of the vertebroplasty process mass. Now, this is done by a few steps, and you have to use the AP and the lateral view sequentially so that you get an accurate placement. The first principle is you always start with the AP view. You make sure that the tip of the needle when you start is always on the lateral margin of the pedicle. So at this stage, when you look at the lateral view, you will find that the tip of the needle is just
at the dorsal margin of the pedicle, as you see over here. Now, this is the view in the AP view and the lateral that you should get when you start the procedure. You then proceed to pass the needle through the pedicle with a gentle tap or by just gentle movements of your hand if the bone is very osteoporotic. And in the AP view again, when you have reached to the middle of the pedicle, as you see, you then must verify in the lateral view. And at this stage, on the lateral view, you should see that the needle has already come to the junction of the pedicle and the body, as you see over here. So there is a clear distance on the AP view, but in the lateral view, you have crossed the pedicle. And then as you proceed a little further, you will find that the tip of the needle comes to the medial margin in the AP view. At the time, in the lateral view, you should find that the needle has clearly crossed the pedicle and entered the body. So this way, you are 100% sure that there is no violation of the medial wall of the pedicle. So this is point number one. Second is that you will have to place the tip of the needle exactly into the pseudoarthrosis mass. And so you can see that the pseudoarthrosis mass on the lateral view may be either at the superior margin, which is very common, or it may involve the whole of the middle of the body, or very, very rarely on the inferior margin. So depending upon this will be the start of your needle on the AP view. So if you see here, if this is at the superior margin, then the point that you would start is at the lower end. So which means that on the lateral view, your pedicle will start here, and then you will have a good trajectory to go up over here. If you have a big lesion occupying the whole of the body, then that is in the middle, and then your starting point will be in the center of the pedicle over here. And then you will find that from here, it is quite easy to pass the needle trajectory over here. Whereas in the very rare instances where the pseudoarthrosis mass is in the inferior side, then your starting point must be at the superior part of the pedicle, and then your trajectory will be easily to pass over here. So the starting point is always on the lateral margin of the pedicle, and it depends upon what is the level of the lesion in the vertebral body. If it is in the middle, then you start in the middle, and if the lesion is in the inferior part of the body, then you start at the superior part of the pedicle. Now, if you follow these basic rules, then your placement of the needle will be very safe and also accurate. Once the patient is positioned and draped, a gentle pressure can be applied on the site of the fracture. This will help to open up the wedged vertebra adequately. You can see here that there is a good opening of the vertebra subsequent to the pressure, and the pseudoarthrosis lesion is more clearly visible. Next is the placement of the needle, and it is important that the starting point must also be planned always with a good AP view. The CR must be so positioned that the end-on view of the pedicle is very clearly seen. A forceps can be utilized to mark the extent of the pedicle, and a stab incision is made so that the needle can have an entry point on the lateral margin of the pedicle. The entire success and safety of the procedure is on the accurate placement of the needle through the pedicle and into the pseudoarthrosis mass. As explained before, you can see that the tip of the needle has been placed at the lateral margin of the pedicle, and then by gently tapping, the needle is progressed through the pedicle. When the lateral view is seen, two important features must be noted. Firstly, the tip of the needle must have crossed the pedicle before the needle has crossed the medial margin of the pedicle in the AP view. And secondly, the direction of the needle must be so positioned that the needle tip will be accurately reaching the surarthrosis. This moment, the position of the needle tip is in the surarthrosis can be confirmed. We can see here that the position of the needle tip is in the surarthrosis. And this can be confirmed by also introducing a thin stylet through the Jamshid needle. And it will be seen to pass and drop into the surarthrosis space. Once this is confirmed, the procedure is repeated on the right side. A forceps tip is used to identify the lateral margin of the pedicle, which will be the entry point for the needle.
Raju, tell me. Raju, tell me, you asked me to stop?
He has to join that. He will be there. Only we got disconnected. No, but then he has to. Otherwise, he would have progressed thinking that we have seen. It will go on, sir. Let me see. Raju, am I audible? Should I go on or stop or?
Raja, this is Ram here. You're getting reconnected.
Should I wait?
We are back, sir.
You have to go back, Raja.
Raja sir, you are completely audible. Please continue.
Okay. Can I start now?
Yeah.
But maybe 1 minute of rewinding, sir. Yeah.
Okay. And it will be seen to pass and drop into the surarthrosis space. Once this is confirmed, the procedure is repeated on the right side. A forceps tip is used to identify the lateral margin of the pedicle, which will be the end point for the needle. Again, by gentle taps.
Professor Rajasekaran, sir,
Yeah. Pedicle.
you may have to rewind it with maybe a 1 minute or 2 minutes.
Cross the medial margin.
Because we lost 2-3 minutes here.
Yeah, but I stopped it, sir.
Okay, okay.
The trajectory
Because the time what we are seeing here is a little ahead of what you stopped at.
To the surarthrosis space. The thin stylet.
You may have to rewind it from, we just saw the positioning when you started, then the power went off.
Oh, you want me to rewind or it's okay? I think.
Yeah, rewind for about 2 minutes.
The accurate position of the needles can also be confirmed by injecting saline into one of the needles and confirming that it is flowing out through the other needle. This procedure not only confirms the position of the needles, but also allows washing out of the surarthrosis and cleaning it for cement injection. Once this is done, the saline inside the vertebra is sucked out from both the needles, and this will result in a pneumogram of the pseudoarthrosis, making the pseudoarthrosis be seen very clearly on the lateral view. At this stage, the cement is prepared by mixing the polymer and the monomer, and while it is in the liquid stage, it is filled in 2 cc syringes, taking care that there is no air bubble within the cement. Although only 1 to 3 cc of cement can be injected usually into any one vertebral segment, it is usual to fill 5 syringes just to keep things ready in case it is necessary. The cement should not be injected too early when it is in the liquid stage, as it will tend to flow out of the defects in the vertebral wall and extrude out either on the circumference or more dangerously through any fractures on the posterior wall of the body. The chances for pulmonary complications due to monomer infiltration into the vasculature are also very high when the cement is too liquid and injected at this stage. Placing the syringes under the surgical light will help to fasten the setting of the cement due to the warmth of the light. When the cement is found to be of correct consistency, it is then injected gently under fluoroscopy, initially to make sure that the cement filling is in the correct space and without any extrusion. The needle opposite is kept open without a trocar so that it acts as a vent. The quantity of cement to be injected is determined by the sensory feedback on the pressure required for injection, and also critically viewing the lateral view, which shows the completeness of the filling of the defect. A few images on the lateral view should be taken successfully during the injection to make sure that there is no extravasation of the cement into the canal. At this stage, an AP view is obtained to see the filling of the cement. Here it is seen that there is less cement filling on the right side, and so the cement is now injected on the right needle with lateral fluoroscopic guidance. It should be emphasized again that any cement injection should be done only with the lateral image control, because prevention of extravasation of the cement into the canal is more important than extravasation on the lateral side. The trocar is introduced into the needles on both sides so that the cement tract is obliterated and both the needles are removed. The AP and the lateral view will show the status of the cement filling, and also here we can confirm the absence of any extravasation. The pin tracks are closed with a single stitch, and a small dressing can be done, which completes the procedure. Here we can see the post-operative pictures, which show an excellent filling of the cement in both the AP and lateral views. The patient went on to have a very good result.
So as I mentioned before, what is the most important thing is the placement of the needle. And if that is well done, making sure that there is no breach of the medial wall of the pedicle, then it is very good. Pulmonary embolism and also cement extravasation into the foramen, or worse, into the spinal canal and getting a spinal cord injury is very, very rare, but certainly a possibility. And that is why at any moment of injection of the cement, a lateral view fluoroscopy is definitely required. We all know that, as you can see in these two figures, that, the post-operative protocol is that this patient can be moved immediately a few hours after bed rest, and many of them can be discharged on the same day. Now, this is the post-operative X-ray, but this is one of the patients whom we saw from a different hospital. You can see that there has been huge extravasations of the cement. Now, this is most probably because the patient has had a vertebroplasty very early, immediately after the fractures, but probably there was intense pain which had forced the surgeon to do that, or injecting the cement too early and too fast, and also with too much force. And these can be quite dangerous because these extravasated cement can enter into the venous channels and you can have a cement embolism. So the most important thing is not to inject the cement too early. Make sure that you have a good sensory feedback and you know that you are not pressurizing it too much. Be very, very careful when you are using cement at levels T7 and above. And wherever you are doubtful, always use kyphoplasty and you will have a very good result. So thank you very much for this opportunity. And I see that Ram is going to follow me with the decision making in lumbar degenerative disease. And recently I had the pleasure and privilege of proposing Ram for the position of the president of the IOA in the forthcoming elections. That was because I have been always cajoling Ram to contest for the last few years, and this year he reluctantly agreed. But in the many positions I have seen Ram, where he was the secretary when I was the president in the Association of Spine Surgeons of India, and later as he followed to be the president and also holding executive committee positions in the Asia Pacific Spine Society, the Bombay Orthopaedic Society, Bombay Spine Society. There is not one single position where he has not brought very important advances and put his complete might behind the society. So I do hope that all of you will support him in this candidature as I would. And Ram, let me wish you all the best for the elections before I hand over the mic to you.
Thank you, sir, for an excellent talk and making vertebroplasty very, making it with your schematic, diagrammatic representation and explanation. I'm sure a lot of us and a lot of orthopedics surgeons will start vertebroplasty in a very efficient way. So now I would like the audience to invite some of their questions, please. So Professor Raju Naik would like to know, when do you time your vertebroplasty after the fracture?
Yeah, so generally, because 70 to 80% of them heal very well by themselves. I have very rarely done a vertebroplasty before 3 weeks after the fracture. And my comfortable time is actually 6 weeks. By 6 weeks, a lot of fibrous tissue has formed at the margins of the vertebral bone. And so they offer you a natural tissue resistance for cement leakage. And if the patient has a lot of pain, still by 6 weeks, these are the patients who really need it and who are very happy after you have done it. So the complication rates are very low. Patient complaints is very high. Patient actually asks for the procedure and that satisfaction rate is very high. Between 4 and 6 weeks is the time I do it.
Okay, sir. So one question from my side. You just mentioned about painful hemangioma. How do you identify a painful hemangioma in terms of clinically and radiologically?
It is not an asymptomatic hemangioma which we find in about 12% of all the MRIs that you take. I'm talking about the hemangioma of the bone, hemangioma of the entire vertebral body, and also which is causing a lot of pain. And there is an extra dural component which is starting to irritate the foramen and also compromise the spinal cord. Now, previously, we always used to do an entire vertebrectomy for them. But now we know that in patients in whom there is no cord compromise and where the epidural component is not too huge, these hemangiomas can be very well arrested by doing a vertebroplasty. The cement entirely fills up the hemangiomatous space of these hemangiomas, and many of them can escape a surgery. It is not for those small hemangiomas which you see in the body. It's for the entire vertebral body which has become hemangioma.
But do you do it in any differently, sir, from when you compare it with the compression fractures?
No, you have to be a little bit more careful, and you need to make sure that you have got good sized needles on either side with venting possible. And then also you probably need to inject the cement slightly a little more early than what you would use it for vertebral body fracture. And you need to do it very carefully, looking at the AP and the lateral views. And the results are excellent. You'll find that the cement entirely fills up the hemangiomatous space. And these patients escape surgery. Otherwise, you need to do a vertebrectomy for them.
And the pain relief is immediately.
Yeah, very good.
Okay. Any other questions?
Sir, I have one small question. Would you prefer vertebroplasty if there is a multiple level hemangioma involved the vertebrae?
No, the hemangioma that I am talking about is not multiple levels. It is these single vertebral body large hemangiomas.
I know, sir, but what if it is involved multiple level? What would be your decision, sir?
Multiple level hemangiomas which we see are usually intraosseous. They are occupying about 20% or 15% of the vertebral body. These don't require treatment at all.
If there's no question, shall we move on to the next session?
Yeah. So Rajiv and all of you, many thanks to me, and I will let Ram take over the stage. Thank you very much.
Thank you, sir, for your presence and making our vertebroplasty procedure look so easy. And thank you for your talk, sir.
Thank you very much. Thank you.
Thank you. I would like to now invite Professor Ram Chaddha, and Professor Rajasekaran has made our job easy in introducing Dr. Ram Chaddha because he's given a good introduction about Dr. Ram. As a past president of Association of Spine Surgeons of India, he's done a very excellent job, and he has pioneered in minimally invasive spine surgery, particularly thoracoscopic spine surgeries, which he started way back in 90s. So we are proud of you, sir. Your presence here has made us even more happier. So I invite you for your talk on the decision-making of lumbar degenerative disc disease. Thank you.
Respected Chairperson, sir, and my dear friends, at the outset, I must thank each one of you from Bengaluru for having given me the opportunity to come here and share some academic experience that I've gathered over the past 3 decades. I stand here speaking about probably the commonest disease or commonest presentation that any orthopedic surgeon gets in his busy outpatient, which is somebody with a low back pain. And I am here to share some myths, some realities, which have made us think differently. Degenerative disc disease. Today I am close to 58 years of age, and obviously my lower back does not look the same as it did when I was 28. However, is it something that's an aging process, or is it a pathology by itself? This is an enigma that remains unsolved. This is an MRI of a 22-year-old. Yes, none of the discs look really very healthy except probably the L3-4. The ones above that seem to have small nodes and make us suspect a seronegative spondyloarthropathy. The ones below are dark, degenerate. And we believe that this man could either be obese or a weightlifter or has abused his lower back. May I share with you that none of the above were true. He was a young executive and he had none of the above that we suspected. This is a 60-year-old where we expect things to be far worse, but he appears to be much better preserved. Hence, we today are not too sure that we can predict chronology based on what we see on MR imaging, as I was shocked when I saw this image of a very dear friend, cancer surgeon's brother, whom I treated about a decade and a half back. He is a 26-year-old businessman when I have actually been treating him for almost 4 to 5 years non-surgically. And I recently heard an ailment called juvenile degenerative disc disease, and that's what I had christened him to be, where I found the lower 3 discs appearing so very different from the ones above. And there is some genetic basis to this, which probably we are not aware of. But this young man managed to pull, till push came to shove. He continued with his golf, he continued with his marathon running, but back pain was getting worse. And what was now unfortunate, that despite my having forced him to give up smoking 6 years earlier, he was a claudicant, he had paresthesia, left lower limb was getting a bit weaker, affecting his activities of daily living. And he shared with me at the age of 26 that, Ram, I'm getting married probably next month or maybe a couple of months later. And I am not very sure because I am now feeling that there is some dysuria, delayed as far as I'm having some problem with my urination, and taking me aside said that he's not too sure about his sexual function as well. Now, these were things where the red flag came in and I said, let's have a look at you all over again. These were his plain x-rays, not very helpful. Flexion extension, no gross mobility, but you actually look at it more intently, you see that there is a calcification of the annulus at the L4-5 level, not as visible at 3-4 and 5S1. What next? Well, my guess was as good as yours. I didn't know what to do. I did a sagittal MRI, and I'm talking 15 years back. I did a SAG MRI, T1, T2 weighted images. I did axials, and I didn't know what to do next because all the 3 levels that I scanned on axial images deserved surgery. All 3 of them could explain the left-sided pain, and probably all 3 were contributing to a lesser or greater extent. I did a whole spine imaging. Is it limited only to the lower back? It was limited to the lower back. The upper part was pristine, clean, and he was younger than I was. What did we do next? Well, we did his electrophysiology to reconfirm that what I was thinking was correct. We even did what is called as a discography at that time. We went ahead and gave diagnostic root blocks, which told us that yes, all 3 were having some component. We ruled out everything else. All the HLA-B27s, anti-CCPs, RAs, all negative. Built up his vitamin D3, B12. Had my rheumatologist on board. They all said, no, this guy needs surgery. We don't have a name to the disease, but he needs surgery. Well, I had batted him for almost 6 years and was not keen on surgery. But then I did the 3 most important things when you do and which you need to do before you embark on any such procedure. The first is counseling. The second is counseling. And the third is counseling. You have to discuss everything threadbare. Even if this surgery may take you 2 hours, 3 hours, you actually have to spend composite 2 to 3 days time, maybe over a couple of weeks, to explain everything to this young man. And if you then embark on surgery, unlike what is happening today, we should first ask the question, why are we doing the operation? After that, we decide, how are we doing the operation? And finally, we embark on what are we going to use during the operation? Today, we started working in the opposite direction. We decide we're going to use this implant. We then decide how we are doing it by minimal access. And we very often forget why the hell were we doing the operation at all. Hence, start with why. The why is he needed decompression. Would the decompression be only a fenestration discectomy, a laminotomy, an interlaminar discectomy, or a complete laminectomy? Well, this young man was different. He was like Sachin Tendulkar. He was an exception to all rules. I didn't know what I'm going to do, but yes, I was struggling. We had these new kids on the block, the new Watts on the block, the new, as I said, the purpose, the process, and the product, the new products on the block. We had Dinesis.
which was the primary part of the surgery. I did a complete left-sided nerve root clearance and foraminal reviews at all the levels. I did a T-left at the lowest level. So I took care of the L5 and S1 nerve roots, the two major offenders completely. I did a decompression at the 4-5, but I did not do an interbody there. I just did a flexible rod there, and I did just a over the top micro decompression at 3-4, which is basically decompressed all the three levels, fused just the lower one, and got away with a flexible rod above, and then a final non-invasive sort of a non-instrumented level. Having said that, we have actually followed him up now for 15 years. I have X-rays almost till the time that he was about 40 years of age. He's happily married. He's doing everything. He's running the hospital, which has been made by his elder brother. And he's extremely happy with the way that he has progressed. But as I said, he's still 40 and we don't know the future, because a lot of these flexible rods, which you have above the solid rods, don't really remain flexible forever. They do become fusion devices over a period of time. So this is the non-fusion device that I looked at. We also had at that time, and I'm talking of 15 years back, 2008, the Charité had come in, which came in for a short period of time, the disc replacement prosthesis, and then got withdrawn because of access issues. So I had that option. I also had the option of the interspinous pressure, the D-arm, which I have not used by choice, or the Wallace ring, or many other interspinous bracers which came and went despite getting US FDA approval. What did I do? Well, I thought, should I fuse all the three levels? I did not. I did what I did, which is in front of you, a hybrid. This is that isobar TTL where I had a solid here and a flexible here. So I have gone solid across 5S1, flexible across 4-5, having decompressed all the levels. This is exactly what I said, 3-4 micro decompressed, 4-5 decompressed and soft stabilized, and 5S1 a T-lift transforaminal lumbar interbody fusion. That's the immediate post-op. You can see the skin staples there. And that's 7 years post-op. I've seen him very recently, not as a patient, but just visiting some other patient in the hospital. And he was perfectly fine and grateful for what we've done. Where does this bring me to? This brings me to a situation where I'm talking of invasion in the lower back. If it's done, it should follow the principle of miracle. We have to treat the man and not the scan. Very often there are clinico-radiological mismatches. Go with the man, don't go with the scan. Howsoever dangerous the scan is looking, if the man is safe, man is better, hold on, because the scan will follow. Please remember that the scan will follow if the man is recovering. If you do invade the body, it should be minimal invasiveness, risks and cost having a long-lasting effect. As I've said earlier, and I'm repeating this, and I say it every time when I take a talk on microlumbar decompression, is you may take 20 minutes to perform the microlumbar decompression, but you must take 2 hours to counsel the patient and the family prior to doing any microlumbar decompression. I feel it is probably the most important part of the surgery. Coming to now the overview. 80% of us will have low back pain. These are the 3 major components that will hit us in our lifetime. It will be either a lumbar disc herniation or a lumbar canal stenosis, 2 of which you've heard, and a third, which I have christened, and you can use it if you want to, called lumbar canal stenosis plus. Lumbar discs, we all know what a degenerated disc is. It looks bad radiologically, but if it's clinico-radiologically bad, it's only then that you will address it. That's my patient who I showed you. You could guess the age today because it's 26. But if I were to show this to you earlier, you would have said 45, 50, 65, 70. This is what we go through from the top, from a dysfunctional phase all the way down to an unstable phase and going to stabilization. This was actually originally described by Kirkcaldy Willis. And we've learned that disc degeneration is going through a stage of stability to micro instability to macro instability to auto stabilization. I repeat, stability to micro instability to macro instability to auto stabilization. And if you can hand hold the patient through the micro and macro instability, a lot of them will settle without a surgery. Having said that, what actually happens and brings the patient to us? There's a tear in the annulus, there's a mechanical component and a chemical component. There's something that pops out, which is the proteoglycan from the nucleus pulposus, comes and hits the nerve, causes a leg pain or a radiculopathy. Well, when we see this MRI to the left, we start imagining that as an intraoperative picture. Yes, if you were to operate, you would get that as an intraoperative picture. And you could
very proudly show it to your patient post-operatively and feel good about it. So would the patient, so would you, so would the hospital. However, if you are looking at a 45-year-old, chronic back pain, 4 days of severe right more than left leg pain, neurologically L5 grade 4 on 5. A lot of spine surgeons are very happy saying left EHL is slightly weaker. When you say that, it means you're buying the operation and you're selling it as well. And that's the time when you have to decide whether you're conserving or operating. Well, if it is your own relative, then it's grade 5/5. And if it's your patient, it becomes grade 4/5. So please remember that if it's yourself, it's 3/5, but you will never tell anybody that it's 3/5. So look at it that way, that we have to be very, very clear. 4/5 EHL, you can live the rest of your life. No problem. Even 3/5 EHL, you can live the rest of your life. There is no physical disability. So please put yourself in that position. I am making a case as to why this patient with this huge disc need not be operated. I'm sticking my neck out. You guys might say, 30 saal bahut paisa kama liya, abhi nahi karne ka. No, it's not the case. Please understand, there is enough literature and evidence to say the same. Natural history, and there are various studies which say that we have almost 75 to 100% resorption of discs like the ones that I showed you in 49%. That means almost half of them will completely disappear. 39, that is almost 40% will recover or resorb to 3/4, which is 50 to 75%, and only 12% will remain 0 to 50%. And please understand, a nerve root is under pressure by a huge disc. Even if it gets slightly shrunk, the nerve root gets decompressed. Please understand that the MRI may look the same, but the patient is very comfortable. That's why I say, treat the man, not the scan will follow. Some more things to know. If the disc is more degenerated, the chances of it regressing are higher. The younger kids don't regress as quickly, the elderly people do. The greater the size of the herniated fragment, the greater the size of it disappearing. The non-contained discs shrink, the contained discs may not shrink. Young disc bulges do not regress. Again, posterocentral, they disappear or they don't even cause symptoms. Posterolateral may shrink. It's that foraminal disc in a constitutionally narrow canal, like the one that I showed you, that young man. Those are the ones that trouble the most. And those are the ones where you have to look at making that nerve root free. Please understand. Does radiological regression sort of correspond to clinical symptoms? I'm trying to say that, and that's exactly mentioned here. It takes much longer for radiology to follow the clinical resumption. This is comparing surgical with non-surgical. Like the disc that I showed you, that fragment which was taken out. In 1 month after you've popped that disc out, taken it out, the surgical guys will be far happier. Can you see that? At 1 year, they'll be getting closer. At 4 years, they're very close. And at 10 years, they all are almost the same. So if you can patiently hold on to the patient, and the patient and you both don't give up, you can probably actually treat most disc herniations without cauda equina syndrome non-surgically. Please understand, this has a good prognosis. Most of them will recover in the first 3 to 6 weeks. Sensory fibers are most susceptible and they will be the last to recover. Even your surgery does not cause sensory recovery, so don't ever promise it to them. Resolution is not affected by surgery. This was mentioned in 1983 and still stands true today. What are the things where you have to be happy that this patient has only this? If a patient has a severe SLR on one side, but the SLR on the other side, cross SLR is free, this patient has a higher chance of recovery without surgery. If his spinal movement in extension gives him a sense of relief and does not reproduce the pain, there's a higher chance of recovery. If there's a large sequestration, yeah, it's very easy to sell the operation, but these guys will recover. If he gets more than 50% relief in the first 6 weeks, he has a higher chance of recovery. If he's an otherwise healthy, fit guy, non-smoker, he will have a higher chance of recovery. If there is an improvement in neurology, let's say a grade 2/5 became a 3/5 or 4/5 MRC within the first 12 weeks, he will recover.
If he's motivated, he's not coming under workman compensation, doesn't have a baggage that he's carrying, something from home. A lot of these daughter-in-law, mother-in-law issues, if they're not there, these people recover very fast. What are the poor outcomes? Positive cross SLR. Be very, very careful. Left-sided disc, right lower limb causing left-sided radicular symptoms. Again, these people have a constitutionally narrow canal and there's something more than is meeting your eye. Leg pain also produced on extension. Again, canal is narrow, canal is occupied by disc in a gross way. Subligamentous, as I'm trying to tell you, a disc which is not really extruded out but is stuck and is not coming out. No recovery at the end of 6 weeks or less than 50% recovery. Progressive deficit or a cauda equina. And as I said, psychological issues. These guys are bad candidates for surgery. Don't operate on them. Send them to your worst enemy. Am I clear? Don't touch them. Just send them away. Say, I'm not good enough for you. What's the role of bed rest? Now, this is a question which everybody asks. Sir, there is enough review to say there is no place for bed rest beyond the first 1 to 3 days to give pain relief. Please do not give them bed rest. Cochrane review on traction in low back pain. Ladies and gentlemen, there is no place for traction anymore. The only place that traction is given is where a patient is medically insured and needs to be admitted for the insurance claim. Okay, this is very clear. I'm not mixing words. Traction does not work. What is new? Well, chemonuclear lysis, which was done by chymopapine and the age group who are now 55 plus would sort of say that is no more done, but it's coming back because now a safer modality is being used. Ethanol gel is being injected. Artemin is a new drug which is being used for the same. Tenazumab, similar to denosumab, it's a monoclonal antibody, is now being considered to take care of the chemical part of the disc herniation. PRP, it's being used everywhere, so they're also thinking of using it here. Stem cells is being used everywhere, so they're thinking of using it here. And of course, something called back school. Now, back school is a big topic by itself, but this is proper education and exercise as far as your activities of daily living are concerned, need to be supervised by a physiotherapist, a psychologist, and a spine surgeon together, is what is the way to go for the future. In summary, most disc herniations will spontaneously go away. Large discs are the easiest to treat. Majority of patients will improve spontaneously in 1 to 3 months. The only indications for surgery are cauda equina, profound deficit like a foot drop acutely developing, unrelenting pain, and patient specific. There is a patient who is in too much of pain, agony, and you're seeing that there is a match and he's just not settling down. You've given him pregabalin, you've given him duloxetine, you've even tried steroids. I don't, but people do. Not settling down, and you think there's a complete match and you feel this particular patient needs surgery, only there do you go in. Don't convince yourself, let him buy the operation. Don't sell it to him. What sort of patients do we see? Well, we have all sorts of patients coming, the young, the elderly. Is a 3 Tesla mandatory for an MRI? If available, yes, but a 1.5 Tesla for the low back is as good. So please remember that. Don't necessarily always insist on a 3 Tesla MRI. Various people do various things. All of them do the same thing. They decompress the nerve root. How do they do it? Well, people put in laser light amplification by stimulated emission of radiation, automated percutaneous limbar discectomy, chemonuclear lysis, ozone. Any of you who do this, all the best. I don't, because if a patient is responding to this, he would respond as much to my talking and taking some rest. If you still wish to do it, go ahead, enjoy yourself. In-clinic daycare surgery is where we are today. A lot of people do come in the morning, go home the same evening or the next day, depending on what their insurance claim allows. And what do? We do a microlumbar discectomy. It's an open surgery. However you may use it. You may use a McCullough retractor. You may use a Destandu tube. You may use a metric system, whatever you want to use. There's a small incision. Either it is paraspinal or midline slightly to one side. You go in and do the operation, identify the nerve root, as I've said, pick up the disc and take it home. Remember that in microlumbar decompression, it's a nerve root surgery. It's not a discectomy surgery. I repeat, it's a nerve root surgery. It's not a discectomy surgery. Your surgery initially should begin with doing a complete foraminotomy. For the last 25 years, I do my foraminotomy first, and then I pick up the disc. And I request each one of you do the same, because there are times when you picked up the disc and there's so much of an epidural bleeding that you do not end up doing a proper foraminotomy. So before you pick up that very, very beautiful, juicy disc, which you're putting your hand on and come out, do your foraminotomy. The bigger the disc you're picking up, the bigger the epidural veins that are going to come out. So do your complete foraminectomy. See that nerve root the way you wanted to see it completely. Then get your disc out. But the moment you take your disc out, then you're in a hurry to leave. You forget the foraminectomy, recurrence rates, post-operative, so-called iatrogenic stenosis, nerve root adhesions, all happen because you've not done that. Fragments like this will come out. Today, we do only a bumpectomy or a fragmentectomy. We don't go into the disc and scrape it out like I was also taught that you must take it out like you're taking a coconut out. You know, take it completely out. No more done. Please don't do it. You're giving a discitis, aseptic or septic to the patient, and you're asking for another surgery, which will be fusion sooner or later. However, there are some people who have back pain and leg pain the same. 5 on 10, 5 on 10. You've counseled them that I'll take care, do a micro decompression. Nahi, doctor sahab, back ache bhi bahut zyada hai, wo bhi theek karna hai. In that case, what do you do? Well, I used to do this surgery. Now this device is not available. I used to do the same microlumbar incision, but I used to do a standalone instrumented fusion where I used to put in 2 5mm tubes and go and jack it up and put bone graft. Where it worked very well. This is no more available. So I can't put in this standalone jack, which used to go in. It used to be called B-Twin. It was a discotheque company from Israel, which got bought over by Kaifon. Kaifon got bought over by Medtronic, and they crushed the whole thing. Okay, it's no more available. One of the best implants ever made, which go in and jack it up. It was a lordotic cage. It used to come as a 5mm tube. You could put it as 7.5 by 9. When I say 7.5 by 9, it's 7.5 millimeters posterior height, 9 millimeters anterior height, 9.5, 11, 11.5, 13, 13.5, 15, 15.5, 17. These were the options available. Not available anymore. Go in, jack it up. Use local bone graft from your foraminectomy and from your mesial facetectomy and a little bit of the spinous process here and there. Pack it in, add additional bone substitute if you want, and you got excellent results. And I was very happy. No more available. Sorry about it. However, in the elderly, we need to do much more of decompression. Hence, in that case, we do a standard procedure. Again, I'm taking you 20 years back when I used to use mesh cages. Roll them in from one side, push them on the other side. These are Jurgen-Harms cages, and we put 4 screws, 2 rods, put it in. We used to do a lot of interbody and posterolateral. We did 360-degree fusions. Gave it up over a period of time because I don't need to add posterolateral if I'm doing a good interbody. So hear me out again. If you're doing a good interbody, you don't have to add posterolateral. If you're not doing an interbody, you have to do a copious posterolateral fusion. When you're doing this in the elderly, if you're not doing interbody, then of course, go far lateral, put a large amount of posterolateral fusion. Moving to lumbar canal stenosis. Only decision in lumbar canal stenosis, it's more signs than symptoms. When do you operate? You operate when the patient is having Cauda equina syndrome. Till that time, just push them. They will go up and down, up and down, up and down. When they have Cauda equina, what do you look? You look at the central part of the canal, totally obliterated, and you look at the lateral part of the canal. Why do you do that? Because you have to decide what are you doing in the operation. When you're doing this in the operation, you have to decompress central, lateral, and far lateral. If you're doing far lateral as well, they need stabilization. Simple answer. If you're not doing anything beyond central and lateral, you don't need to stabilize. If you're doing far lateral, you need to stabilize the patient, provided he's fit, quality of bone is good enough. Otherwise, he stays in bed with a belt and prays to God that he doesn't get an instability. If he does get an instability, what happens? He goes into the next category, which I call lumbar canal stenosis plus. Degenerative listhesis, degenerative scoliosis, more than 20 degrees needs interbody, less than 20 degrees may not need interbody, and a redo surgery. Why do I show this? Well, I show this because a lot of us are in our youth, when we keep seeing our patients repeatedly, we start seeing instability after a period of time. Keep looking at that, you think that things are moving. In the elderly, things don't move. Please stop imagining instabilities in the elderly. Leave them with a decom, they will all do well. Very few of them need instrumentation. Those who do are those grossly mobile degenerative listhesis where you could go in, put in 4 screws, 2 rods. And I used to again use a lot of these interbody spacers, which were expandable at that time. Here is where I come. Can you see that? I put huge amount of posterolateral fusion. At 3 months, dikhta hi nahi hai posterolateral. At 6 months, it disappears. And at 1 year, it's no more there. Where the hell did it go? If I had not put the interbody, you would see it. Because I had put the interbody and the interbody fused, my posterolateral was never challenged and hence disappears. So please remember there, it's like nailing versus plating. The two don't work together. One of the principles will work. So where it's a good interbody, don't waste your time doing posterolateral. And if you're doing a good posterolateral, don't waste your time doing interbody. They don't work together. Having said that, less than 20 degrees of a degen scolio, just do a decomp and do posterolateral. It will fuse as you've seen here. But if it's more than that, there's a lateral listhesis, there's a prolisthesis, that's the only time. Vacuum signs seen at all levels. Here, you would need to put in interbodies. Again, as I said, my favorite implant always there. I used to go in, jack them up, correct the scoli with that implant, eccentrically place my implants, larger on one side, smaller on the other, and get away. Revision surgeries, again, 90% of redo surgeries of the spine, if they are microlumbar, will only need a microlumbar. And I'm repeating, it will only need a microlumbar. However, 10% of them will need instrumentation. In those few, you could get away with doing an instrumented fusion. Most first recurrences need only a re-decomp. They don't need an instrumented stabilization. Having said that, if you have created your own listhesis, this is my closest friend, cardiologist's mother-in-law. The same cardiologist put stents into my mother. So I put cages into his mother. I had no choice. But I did on day one, when he was treating my mother non-surgically without the invasion, I did a decomp. And then within 3 years, he put 5 stents into my mother, and his mother-in-law had an instability. So then I said, listen, you've put in so much of titanium, I got to put some titanium. So I went in and put this titanium in that lady, and that's where she is. She ended up with a nitrogenic instability I had created, and 4 years, 5 years down the line, went and did this. Story didn't end here. She then went for an adjacent segment and an adjacent segment. Fortunately, my mother has stopped with 5 stents, but his mother-in-law is still following up with me. So as an orthopedic surgeon, this is an investment. And be careful. Okay, especially if your own friends are there, be very, very careful. He's looking for put the 6th stent in my mother, but I'm holding on. Okay. So finally, what have we learned? Symptoms should be more than signs. Only then let the patient buy the operation. If the signs are more than symptoms, then counsel them for the surgery. So only when they're getting quad equina foot drop, only then would you advise them surgery. Elderly osteoporotics, delay the surgery. Give them denosumab, give them teriparatide, give them time, build up their bone stock. Complex LCS, which I said, all these redos, colis, listhesis, buy time, don't be in a hurry. Instrumentation, in special situations, you might need fenestrated screws with cement. You might need to augment it with BMP. Have I used it? Yes, I have. Have I had good results? Reserved, comments reserved. BMP, it goes into the perineural area, can cause a lot of problems. Screws, wires, you have to at times combine sublaminar wires, hooks and screws all put together. Technology and technique, yes. Have I used the robot? Yes. Does it help? It does help. Too expensive for the present? Yes, too expensive. Minimally invasive, works well. Tertiary centers, yes, you always do these elderly patients in ICU setups. Don't do it in small nursing homes. Future, fusion versus non-fusion. I think non-fusion will take over sooner or later. Minimally invasive versus open, minimally invasive has taken over. Instrumented versus non-instrumented, it all depends on what sort of a patient. Your own patient, your own family, uninstrumented, anybody else, you tend to do instrumented. So give it a thought. It's market driven, it's trade driven. Be a little careful. Gene therapy versus biologics versus metal. We are right now on metals. We are trading onto biologics. We have not yet reached gene therapy as far as low back is concerned. Final message: tread cautiously into spine surgery. Things are changing as we talk, and what I state today may be state of the art. It will be history tomorrow, and probably obsolete the day after. What we talk of 17th October 2021. Do what works best in your hands rather than be market driven or techno savvy. Always remember, begin with the purpose, then comes the process, and finally the product. If that is what you want to do, I don't know why that was done, but I saw this patient at the end of 3 months. I still don't know how it was done. So be extremely careful. You should know why you're doing the operation. Then you decide how you do it, and finally what you use for it. So be very, very careful. I'm still not sure why and what was done there and what he's working around with. God bless. I have followed this Dunning-Kruger effect all my life, and I'm reading it out. There are a lot of young men at the rear. Please understand, good results come from experience. Experience comes from bad results. This is a talk which I gave in 1994, which got me multiple awards, but it also got a lot of brickbats. Because in that I mentioned something which one of our colleagues mentioned today, when he said that he was comparing surgery to marriage. Am I correct? That's one of this gentlemen. And my topic, the first line was good results come from experience. Experience comes from bad results. And the next thing was surgery is like marriage. Everything looks good the first year. And I had a lot of trouble. Not in my marriage, that also happened, but in that academy, it was terrible. Anyway, the more you know, the less confident you are likely to be, because experts know just how much they don't know. They tend to underestimate their ability, but it's easy to be overconfident when you have only a simple idea of how things are. Try not to mistake the cautiousness of experts as a lack of understanding, not to give too much credence to lay people who appear confident but have only superficial knowledge. Bertrand Russell, and I quote, "The whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people are so full of doubts." So be doubtful, be vulnerable. You can only perform when you're scared. You cannot perform when you're overconfident. Whether it is Sachin Tendulkar, whether it is Virat Kohli, when they walk in, the fear of getting out on the first ball has to be there. It's that how we'll perform with spine surgery. Well, trauma, we've always enjoyed it. It's a battle we play with, but spine surgery, very, very careful. I would be erring in my duties if I don't invite all of you to be a part of IOCON 2021, which is happening at Goa, 21st to 25th of December. Be there. Large number of postgraduates have already registered. I have 2,524 registrations till yesterday. It's become 2,564 this morning. Almost 690 PGs, which is a large number. And about 700 people for the CME, 900 people for the banquet. So please come. 2166 abstracts we've got, of which we are hoping to get about 1,500 on board. So let's see how it works. We are very hopeful that you will all be there and participate in what's going to be the first major physical meeting. Your 2,500 have registered. We'll go between 4,500 to 5,000. And Goa is a nice place to be at the end of the year around Christmas. So please be there. Thank you very much for a patient hearing.
Thank you, sir. I think before we start with the question and answer session, I think we enjoyed your talk. And
Both, I think it's both. It's both. It's not just one.
Does the body have a mechanism of opening space for the nerve?
Will it radiologically improve is your question, sir? Clinically they improve.
Practically,
Yeah.
the bone gives way for the nerve. That is how many problems are solved.
Sir, I totally agree with you, and I have used this, and again, don't quote me. The relationship between the canal and the nerve is a relationship between a husband and a wife. Things may not look good, but they do auto-settle in a large number of cases. And if you give them time long enough, you don't have to indulge in a legal separation.
When do you really do your epidurals or nerve root blocks, sir?
When do I do my epidurals and nerve root blocks? May I first put my disclaimer? I don't do my own epidurals and my nerve root blocks. I have a pain specialist who does it much better than I do, so I don't do it. I don't do epidurals anymore. They are always selective nerve root blocks. And I do them usually if I have a patient who is very symptomatic and is either not wanting surgery or is not fit for surgery. These are two different people. There is an elderly person who is agreeable to surgery but is medically unfit. That's the one who goes for a nerve root block. Or there is one who is actually cut out for surgery but is not willing. Doctor Saab, no, I don't want an operation. Give me pain relief. These are the two sets of people who go in a treatment naive patient. Post-operative failed backs, a lot of them do go for nerve root blocks, but these are all time-bound, temporary, partial relieving modalities. If there is a post-operative diagnostic anatomic aberration which needs to be corrected, failed back, then only surgery will help that patient. But if it is perineural adhesions, scars, no surgery is going to help. That's where the pain specialist comes in. Are you getting that difference?
In the case of lumbar canal stenosis,
yes,
it's not about failed back.
Yes,
pure lumbar
treatment naive patient, not operated.
Degenerated lumbar canal stenosis. In that case, you need to offer them nerve root blocks first. Don't even talk about surgery.
I don't give them nerve root blocks. I don't give them nerve root blocks, sir.
But if they're not fit for surgery.
Sir, just a moment, sir. Lumbar canal stenosis is more of symptoms and less of signs. Am I correct? It's more of claudication than single nerve roots involvement. Am I correct? Now, if it's claudication, it's postural. It's related to the neurogenic. We're not talking vascular. We're talking neurogenic claudication. That is related to the fact that anything which is lordotic is causing symptoms. Kyphogenicity reduces the symptoms. I'm talking of simple primary LCS. I mean, I'm talking of secondary LCS, but elderly. Their nerve root blocks is just, then your epidurals come in, which was the old way. It's buying time and they're not really giving us any sort of relief. And I don't like to have my operative bed filled with steroid if I'm going in sooner or later. Avoidable. That time is gone, sir. That period when people are giving these caudal epidurals and just blind epidurals, palliative. So those have gone down now, sir. We are very specific right now. If you're giving a nerve root block, you're giving a selective nerve root block. Yeah, there may be 2 roots you want to block. Fine. There may be 3 roots on one side, like that young man, which is a rare case. 3 roots which were tested, diagnostic plus selective. That's different. But that epidural daldo, no. I don't think there is much space today for that, sir. Unless, as I said, patient unfit, not willing. Those 2, you will give everything.
So one of my classmates, anesthetist, probably she couldn't be her anesthetist, I don't know. But Dr. Lakshmi, she was a pain management in Bombay.
Lakshmi Vas is one of the top pain management ladies.
She's my classmate. I invited her to speak in one of our last conferences which I conducted.
Yeah.
I mean, we studied together long time. She keeps calling me.
Very good.
She's
very good speaker. Very, very talented.
You
very
know,
she's very good. So Lakshmi
she does dry needling. Some specialties is dry needling for pain. I don't know what that really dry needling. She keeps telling about this dry needling, dry needling. So many patients went from here.
That's only for the muscles, I guess.
I don't know.
Sir,
she's an anesthetist, I'm sure.
Sir, I know. She's in other Hindu colony, sir. She has a center there. Just walking distance. Sir, with due respects, what I'm not aware of and what I don't do, I don't comment on. And if somebody takes the treatment, I have nothing. They feel better. So go ahead, sir. Go ahead, sir. Whenever somebody comes and tells me that I'm taking a lot of needling, I just tell them that I would not mind it, but then I have more luxurious ways of contacting HIV. Oh, sir, I would rather enjoy and have HIV rather than get needled and have HIV. Come on, sir. God bless. Anyway, I'll share with you a short presentation. Please excuse, this has been made on a 16:9 Mac, and it's being now converted to a 4:3 Microsoft Office on Windows. So we'll have to sort of creak our necks a little bit, but don't mind. Okay. What are the aims and objectives of treating or looking at failed back surgery syndrome? Well, it's the primordial deterrent for a spine surgeon in the process of achieving its holy grail. The analysis of surgical results in the form of an audit spanning over almost 3 decades, and the lessons that I've learned and the mistakes I've made. I hope and pray that none of you ever see such patients. I have seen both. This is a gentleman who could hang his clothes to dry at the rear because he had implants which were coming out. And this is a gentleman who was operated in the same hospital where I work. And there are 1, 2, 3, 4, 5, 6, 7 screws which were put in. And guess how many of them are in the pedicle? It's like the score that we lost a few years back in hockey. It is 7-0. So none of them were in the pedicle and everything collapsed. So unfortunately, we see such patients. I learned from trauma surgeons. Professor Lard was my teacher, and he always told me that if life gives you lemons, you have to make lemonade. And that's precisely what happened to me. I was already a trauma and pelviacetabular surgeon, and he sent me off to Chennai just because a 7,500 paid kid was getting 25,000 and a free car and a lovely home to live in. And I became a spine surgeon. So that's what life did to me. These are 4 of my colleagues whom I grew up with, whom are my role models and mentors. Few of them you would know. I introduced him. This is Dr. Narayan. He's a big man in AO today. He's from Muscat. He's sitting there in Muscat and is ruling the AO International. Dr. Surya Narayan is a joint replacement surgeon from Chennai. And Shekhar Kumta is probably one of the most gifted microvascular surgeons in Hong Kong. And we are at a 1-year gap, and we were all students of that man who's showing us a finger there. I was the youngest of the 4, and I learned a lot from these guys. And I'm really grateful to them for what I have done today, including the failed backs. Well, we have a group of orthopedic spine surgeons, neurospine surgeons, and fellows who work together as a team. And we analyzed what I did in the last 30 years of my career. And we picked up only 228 cases, but that's the literature that we had, the notes that we had. And I studied them. Well, we found that there were 3 types of patients. Now, this is again, it's no classification. This is something that's coming from within. There were implant-related failed back surgery syndromes. There was surgery-related failed back surgery syndrome, and there was non-specific failed back surgery syndrome. 90, where an implant was erroneously placed. 72, where surgery was done, there was nothing wrong with the implant, or there was no implant. And 66, where your guess and my guess, we don't know why the hell they were unhappy. That's the most difficult sort of people to treat. And remember, you should have fewest of those. Well, most of the surgeries were done by us, but a few came to us and were referred to us and were added to this because we then followed them up thereafter. 1.5 years is the minimum time span that we had for these surgeries, and 25 years is the maximum that we have. And I have a lot of them who are that old as well. Well, they were symptomatic. They were uncomfortable, and they were willing for a reintervention. That's the criteria. They should all be needing another surgery or needing something to be done. Then they come under this FBSS or failed back surgery syndrome category. Aside, this is the only part of medicine in the world which is called failed back surgery syndrome. There's no failed arthroscopic surgery syndrome. There's no failed trauma surgery syndrome. There's no failed arthroplasty surgery syndrome. For some reason, they have sort of put us in a terrible situation where we have been made to make unhappy people less unhappy. Maximum I can do is make an unhappy patient less unhappy. I can never make him as happy as you trauma guys and joint replacement guys. And especially the sports guys who even get people gold medals at Olympics. We can't do that. Any which way, let's look at the first 90 patients. They had malpositioned implants, screws, cages, spacers, etc. They had residual recurrent symptoms or fresh neurology. Well, I'll share a few. Has anybody seen this? Well, this came to me and I am very proud that I can't find another one, but I don't know who did it, why he did it, but this man came to me with a neurology and he came about 2-3 years after this was done. I appreciate that the cage stayed where it did for 2 to 3 years before it decided to move. Why did it move? I don't know. But it moved and he got neurology. What did I do? Well, simple. We had to just remove this cage. This is a man who came from overseas. He had this screw which was going into the root and he had agonizing pain and had lived with it for again a year and a half. He came across the border from our friendly neighbors and all I had to do was just change the screw. So a lot of these are implant related things which could have been avoided on day one. So we remove them, reposition them. Then there are some where everything looks good on day one. As I said, it's like marriage. Fantastic. Bahut acha lag raha hai. 6 weeks down the line, the wife turns away. So the cage has looked into a different direction. And now there is neurology. This is my own patient. I have done this surgery. I went in at the end of 6 weeks when this man came for a follow-up. And I went in. What I share with you is very interesting at this stage. At this stage, I went in, I got that spacer out. I put in my number 4 Penfield retractor, which goes in. And I could feel hard bone in the interbody space. That means this was probably subclinical infection, plus the fact that the bone was healing. And I just cleaned it up and I came out. And this man progressed to heal further. May I also say that this man also is a spiritual guru. So I have no, I don't know if there's something more than meets the eye. These guys can control their blood pressure. They can even throw bone, I believe. But then he healed without any major issue and had good interbody fusion just by picking out that cage at the end of, because what I needed to do was pick out that cage, make a fresh trough and put this cage again. That was my plan. But when I took it out, I had bone through and through and feeling pretty solid, firm. Decided to do no more and he got away with that. That's the cage that I took out. So this is something where you either remove or you reposition. Now there are patients who have adverse effects during the operation. Now, please remember there are 2 words. There's something called an adverse event and there's something called a complication. Every adverse event does not turn out to be a complication. Every complication post-op need not have an intraoperative adverse event. A dural rent during surgery is an adverse event, need not be a complication. A post-operative sepsis may be a complication, but there may be no intraoperative event that you can attribute it to. Having said that, incidental durotomy, you've removed the pars and made the stable patient unstable, post-op surgical site SSI, discitis, interbody adjacent segment disease, delayed or non-union, any one of your interbody or posterolaterals didn't work. Let's look at this. Well, this was a patient operated back and front, partly in Oman, partly in Mumbai, part of the surgery done in Oman, part of the surgery done in Dubai, in India, came to me 6 months after the 2 surgeries. And this was his MRI. He had this huge collection at the rear. I was not sure whether I'm dealing with pus or whether I'm dealing with the CSF. To me, it looked like pus, although he was very cold. So I thought it may be tuberculosis because that part of the world also has a lot of tuberculosis. I opened up, there was a lot of pus there. And I cleaned it all up. Fortunately, since it was about 6 months plus, I just removed the metal from the rear and I didn't touch the anterior and he went on to heal. All the neurology, the pain, the weakness that he had developed was because of the posterior neural compression and there was nothing anterior. So at the end of the day, if you know what your purpose is, which is decompressing the rear, you can then just do what you want and get away with it because the anterior construct by itself was reasonably strong. He was a fractured spine who had been operated this way. So that's where we are. Having said that, this is the implant which came out and I left him just with the anterior implant and that's a post-operative MRI which showed a complete clearance. He went on to improve and he became a walker from a non-walker. I didn't take the credit. It's just that it happened. He should have got it with the surgeries but had sepsis. Well, this is the patient who taught me the most and it will teach you guys a lot. This is, I'm calling it L45 listhesis. Today, what would I do? Well, he's about 70 years of age when he came to me, no, 65 years of age when he came to me. He's a very, very well-to-do person. He's no more today, but he's very well-to-do. He's a big shot in the city of Mumbai. And he comes to me and he tells me, I've got instability. I've been told you need instrumented fusion. I was going to fly to Chennai or to Germany. Can you do it? I said, yes, of course I can do it. Younger person, more egoistic. I said, yeah, I'll do it. So what do I do? At that time, what I did, what I made you today is a little different. I went in and I did what I showed you earlier. flexible rod. This is another type of flexible rod. These are knurled rods which can move, and a solid fusion with correction of the listhesis. My ego felt great. I have corrected this listhesis. I've done a great job. He's already 65, 70, he was stable. I should have just decomped and stabilized him in situ. But no, I did this. Felt great. I've used flexible rod. It was something great. It was 2001, 2002. This was from a company called Globus at that time. They had that knurled rod which I used to use. And I was great. He did well for 7-8 years. He came back, and can that be? Can you take that out? Can that thing be taken out? Okay, then it's okay. He came back later with, yeah, great. He came back with an adjacent segment disease adjacent to the flexible rod. Why the hell did I put the flexible rod? So that he doesn't get adjacent segment disease. And he got an adjacent segment disease adjacent to the flexible rod. I said, doesn't work. Technology is useless. Removed it, put a solid rod. So now I've gone 4, 5 is what we are calling it down, 3 and 2. Felt great. He felt good for another 2 years. Now we are now gone from 2010 to about 2012. Comes back in 2012. This is called proximal junctional kyphosis. There's a backing out of the implant. He's growing older. He's 72 plus. I've treated his wife. She's already on teriparatide. They can afford the best. They're on 40. Good, great. He said, Doctor, mujhe bhi wo injection de do. I said, no, sir. You're you're a tough man. You don't need teriparatide. I had not used teriparatide in men at that time. So I said, no, sir, you're good. But this is now cutting out. And then he got that disc there, and he got this early cauda equina. I said, no, you will need another operation. We went ahead. What did we do next? So we are now stuck at L1. No, this is the wrong level to stop. You can't stop at thoracolumbar junction. You have to go up to D10. Great. I learned it. I went up to D10. So this is now surgery number 4. We've gone up to D10. Felt great. He was good. We felt good. Implant company felt the best. We are going up. Okay. Globus is doing well. Okay. We've gone all the way up to D10. He lives another 6 months. At the end of 6 months, he comes back and says, I'm again feeling weak. I'm falling off my feet. There's a disc which has popped out there. I had not heard of D9, 10 discs popping out so easily, but this guy popped it out. You can see that there is a lucency there. I thought infection hoga. I went in again, cleaned it up, went up now, this time up to where? D4. Why? Because you never stop on the thoracic kyphosis. Okay, we read all that. D4. I said, great. I said, now sir, abhi iske baad kuch nahi hoega. You'll be perfectly fine. Doctor साहब आप ही का ऑपरेशन करते हो और तो सब बोलते हैं उनके पास वापस चले जाओ. Fine, that will happen. When you have such patients, nobody else is going to touch him. जाओ उनके पास वापस जाओ. So he comes back to me. Again, we have him walking, and then we start having, he sends us, by that time, WhatsApp videos start coming in. He sends us how the physiotherapist became walk, and we feel good about it. He's also feeling good about it. He's now becoming about 76, 77 years old. And he's saying now, he starts getting some cardiac problem. He says, nahi, main cardiac karaun. Maine kaha, nahi, kara lo. Cardiologist says, no, with so much of metal, we are not doing anything to you. Stay where you are. God knows what they're up to. Anyway, he starts walking. I said, sir, abhi mera kaam khatam ho gaya. Abhi aap, by which time he's convinced that he needs teriparatide. So we start him on teriparatide. We've done his BMD. Spine obviously will give us something which is wrong. We do the hip and the forearm and the wrist. And they say, no, start teriparatide. He's very happy. He's feeling good. Start feeling younger. Wait for a little more time. And at D3-4, he develops a pathological fracture or a collapse, osteoporotic fracture at D4 with a retropulsion. And now there's a D3-4 thoracic myelopathy. I said, now I'm in big trouble. There's no place left. But then orthopedic surgeon will not stop when he can see there is cord compression at 3-4, screw is backing out. Nice. Never say die. Orthopedic surgeon never say die. I went up to D1. This time I said, sir, this time not only putting screw, I'm also putting wires. So I put screws, D1 to D1, D2, D3, went across 3-4, put in wires, sublaminar wires, also tied them to the transverse processes, everything. And then my colleagues, my partners who were in this exercise together, 2 of them, one is senior to me, one is a couple of years junior to me. He says, Ram, agar wapas aayenge to kya karenge? I said, abhi cervical spine mein jayenge upar tak. But then probably God was kind. His cardiac ailment came up again. And I had to send a small letter that may his soul rest in peace. But it happened about 6-8 months after we did this. I don't know what I would have done after this. Had he popped at C71 and he would have had an injury. But I learned a lot. Hence, when Dr. Rajiv asked me, why do you not suggest too much of surgery in lumbar canal stenosis? Why are you getting less aggressive than you were? Well, I am a little bit learning from my own mistakes. And I believe that the later we start, the lesser we do. Probably we keep them longer, happier.
Sir, but how you made him trust you so much?
I said something thrice. Counseling, counseling, counseling. I take a lot of time. I take a lot of time. I take a lot of time with my patients. And as I said, I am grateful. Sir, kahin nahi jata, sir. वो नहीं जाता, sir.
Nobody would accept it by
They don't, sir. They don't. In our city, we are very good. No, I would not remove. Sir, he has instability there. He has a myelopathy. I have to decomp and stabilize. I have to decomp. I've given him teriparatide. I've now improved his BMD. But now, if you had gone to cervical spine, as I said, this is once in a lifetime. It doesn't happen again. But I don't know what I would have done had he gone beyond that. Where? In the same thing, I would have kept doing the same thing. But primary surgery, I'll be less invasive, sir. Primary surgery, I would be less invasive. I would not try to get corrections. I would not believe that correcting that is as important. And I would have probably addressed the bone density issues earlier. I would have done a lot of things slightly differently. But as I said, but every time you get a neurological deficit, you have to respond, sir. You can't just let it go, sir. These are all neurologies. And finally, we come to that last group, which I said is the most difficult to treat, where the patient is an unhappy patient. He or she has no mechanical correctable cause on imaging. And usually the patient is out of focus, and it is the patient's relative who's very much in focus, who's very unhappy, and who's looking at you, penetrating through you, looking past you, and you're in big trouble. This is where you need communication skills. All these have to be managed without pharmacological treatment. You need advice and counseling. They need mental health consultations. You have to give it yourself. You can't send them to a psychologist or a psychiatrist. You're in big trouble if you do that. You need highly skilled consultations. And remember that you have to get them at your level. Remember that you and they have to be at the same level, neither above you nor below you. They have to be besides you. Listen to them, respect their views, open communication about all treatment choices, discuss all management options, allow patients to ask questions, ensure that they understand, be aware of their language, accept all their cultural influences, and compensate all their communications skills. If you follow these 9 rules, you can operate on the same patient 6 times, as I showed you. Well, what have I done in my revisions? Well, I've corrected them as I showed you in the type 1, category 1. I've added additional soft tissue surgeries in the other where there is, let's say, a smaller procedure to be done. And in the last, I have used pain specialists, physiatrists. I may do a little limited decompression, but may have to sort of talk to them and hold their hands forever. Well, most of these patients who have an obvious cause will go home in 4 days. Those who don't have an obvious cause will stay a little longer. And those who have no cause, despite what you do, will stay for the longest with you, inpatient and outpatient. As I said, where there's an obvious cause, second surgery will give you good results. Where there's no obvious cause, they'll give you only 56% results, whatever you may do. I have learned that type 1 gives me the best results, type 3 gives me the worst results. And we have to evaluate a risk-benefit ratio, discuss it with the patient every time, counsel with a clear intent. Please remember that revision surgery is like life. It's not just about reinventing the wheel. It needs to be a set of wheels which need to run in perfect harmony, even if the wheels are not circular. You have to think out of the box. And you must understand what Samuel Beckett said. Ever tried, ever failed, no matter. Try again, fail better. Before every surgery, I say this prayer, and so must you. God grant me the serenity. It was originally quoted by Reinhold Niebuhr. God grant me the serenity to accept the things that I cannot change, courage to change the things that I can, and wisdom to know the difference. Please remember that. Say it before you operate every time. As surgeons, we can only change the anatomy and hope that the change in anatomy improves the physiology. Thank you all for a very patient hearing. We don't live in a perfect world. We have to accept our imperfections and hope and pray that things will settle down. Thank you very much. God bless you all.
Thank you, Professor Chaddha. I think you have given us a very holistic approach on this matter of lumbar degenerative disease and failed back syndrome. Any questions from the audience?
I must confess here, Ram is a wonderful gentleman. My son had a L1, L2 fracture. That was on a Sunday morning. And, Rajiv was beside me and almost total, except for a little movement in the grade 2. So I called up Ram in Bombay. My son is like this on a Sunday morning. Can you come over? Promptly, within no time, he took the flight. He said, shift your son to the OT, I'm coming. It was almost 14 years back. And today we recall, he's fully improved. So I want to thank him personally in front of this audience that he has done this. Thank you, Ram. Thanks a lot.
I can only say that I was destined to be there and his son was destined to improve. And it's just that I happen to be the instrument and not the person who did it. So we should all remember that we are all instruments of a much larger force. We are not doing anything else.
Next.
Yes.
Would now like to invite Dr. Ketan Kulkarni from MQ Pharma for a designated strategy for management of osteoarthritis. Thank you.
Very good afternoon, everyone. I know it's 4 o'clock, but I wish to thank all of you for audio. Thank you, all of you. I'm Dr. Ketan Kulkarni from the medical services team at MQ Pharmaceuticals Limited. And it's a great pleasure of mine to stand in front of stalwarts in orthopedics to give you a small talk on S-Etodolac, design strategy for the management of osteoarthritis. Okay. So osteoarthritis, it is a degenerative disorder. It is characterized by cartilage degradation, subcortical damage, and bone remodeling. And it is one of the most common disease affecting the weight-bearing joints such as the knee and the hip. Approximately 85% of the population is burdened by osteoarthritis worldwide. And it is one of the 4th leading cause of years lived with disability globally. One of the key options for management of osteoarthritis includes the NSAIDs, which represent a key strategy in the management of osteoarthritis, which is a non-pharmacologic treatment. And NSAIDs have dominated the treatment of osteoarthritis since the past century, with 50% of NSAID prescriptions being written for osteoarthritis. And expected benefits of NSAIDs include reducing stiffness and inflammation and improving mobility. One of the NSAID, what I'm going to focus upon is Etodolac. And Etodolac studies have shown that this is the study where Etodolac was compared with diclofenac, and it showed very fewer incidents of adverse events, and very fewer percentage of patients, they required antacids as compared to the diclofenac arm. So it was as effective as diclofenac, but it was superior to diclofenac in terms of safety, such as the GI symptoms. This was another study where it was compared with naproxen, and the study concluded that Etodolac is not associated with statistically increased risk of myocardial infarction as compared with naproxen. However, naproxen had a higher incidence of GI bleeding and perforations. So the two major events of NSAIDs, such as GI side effects as well as the cardiotoxicity, are minimized with Etodolac, and therefore it should be preferred for patients who have got increased risk of NSAID related GI and cardiovascular complications. I'm sharing with you the data on Etodolac initially. So this was an analysis which compared 10 double-blind placebo-controlled groups to see the effect of Etodolac on renal function. So this was an analysis of around 1,382 patients, and 228 patients were in the age group of 65 years and older. So the analysis said that no patient was withdrawn from the treatment due to an abnormal renal function because of Etodolac administration. There were no incidences in the definite renal function abnormalities in patients who received Etodolac. And long-term treatment with Etodolac in patients with arthritis does not appear to produce clinically significant changes in the renal function. Okay. Now, why I'm talking about this? This is because there is a concept which is called as chirality. So just to give an example of chirality, our two hands, they are identical. They are identical to each other. Both have 5 fingers. If I place my right hand on the left hand, which is shown in the screen, you can see they are not exactly fitting on each other because the thumb is coming in the middle. So these objects in our day-to-day life, these are what are called as the chiral objects. Okay. Or I'll give another example. This is a pair of bottles. And if you place the left bottle on the right bottle, they exactly fit on each other. So these kinds of objects are what are called as the achiral objects. Okay, so the concept of chirality was introduced by 1848 by the well-known microbiologist Dr. Louis Pasteur, and he discovered the phenomenon of molecular chirality based on his study of tartarate crystals. So chirality is a fundamentally important chemical phenomenon with essential implications in biology. The word chirality comes from the word chir, that is hand, and it has got vital implications in biology and medicine. So chirality can affect the pharmacokinetics and pharmacodynamics of the drug, and therefore it is essential to study the chiral aspects of these compounds. Okay, so how chirality is related to drug action. So this can be exemplified by a simple example that our left leg will not go into the right shoe and our right leg will not go into the left shoe. So it has to exactly match. So how is chirality related to drug action? Just a simple example. So this is a drug, okay, and it has got say 2 enantiomers. One is the S enantiomer and one is the R enantiomer. These are examples. So if you see the S enantiomer, it perfectly fits into the binding sites of the receptor. So this is the tight binding which happens when a chirally bound drug interacts with the receptor in a 3-dimensional format. While if you see, this is another R enantiomer, and if you see the binding which happens is very weak because you can see this group which is shown in circle is not fitting in this trapezium. So that is a weak binding of these drugs. Therefore, it will give a weak binding. Okay. So when we isolate single enantiomers, what will be the benefits? So it will lead to lesser complications because racemate is a compound which is made up of 2 enantiomers, and we separate out the active one. There will be lesser complications. It will have a selective pharmacokinetic profile. It will reduce the probability of drug interactions because you keep only the one active one. It will prevent the drug interactions. It will have a better kinetic profile because we are giving a single one. And another important action is that as we are giving only the single isomer, it will give a half dosage, and therefore it will give a lot of benefits. So coming back to Etodolac, Etodolac is a racemate made up of 2 compounds in one. That is, one is the S Etodolac and one is the R Etodolac. So studies have shown that the S Etodolac shows almost all the pharmacological activity, while R Etodolac shows little. Okay, so in Etodolac, the S Etodolac is the active NSAID, while the R Etodolac is not an NSAID because it is not blocking the prostaglandins. So studies have shown that S Etodolac has greater concentrations in the synovial fluid as compared to the R Etodolac, which is twice as high as the R Etodolac component. And if you compare the two in terms of the pharmacological action, S-etodolac has been shown to have 2 to 2.6 times greater potency in racemic etodolac in reducing the inflammation. R-etodolac is inactive. It is twice as potent as racemate in terms of inhibition of prostaglandin release. And the second advantage is that etodolac is rapidly cleared from the plasma, while R-etodolac requires more time for clearance. So overall, if you see, it is an active isomer, and R-etodolac has no therapeutic significance, and we have already seen it has got twice the concentration in the synovial fluid as compared to the R-etodolac. Okay, so study has been done on etodolac, which is a multicentric randomized comparative study. So this was a study in Indian patients. Around 101 patients were compared. So one arm received the S-etodolac 300 milligrams, while the other arm received etodolac extended release 600 milligrams. So in terms of the WOMAC pain score reduction, there is a 65% reduction in pain score, around 71% reduction in stiffness, and 60% improvement in physical function. So the efficacy was documented. And in this study also, there were less amount of adverse events with the S-etodolac component as compared with the etodolac component. Also, in 2019, there was a consensus statement of all the different specialties. This was an executive summary which was published in JAPI. And of the orthopedic segment, they said that S-etodolac demonstrated 2.6 times higher potency and bioequivalence at half the dose when compared to the racemic mixture. So key highlights of S-etodolac, that it is an active component of etodolac. It has been shown to have the potency which is higher than that of racemate. It has got a higher concentrations in the synovial fluid. It gives the effect at half the dosage as compared to the racemate. As there is a half the dosage, it leads to lesser metabolic load. And study and efficacy, safety and efficacy has been evaluated in treatment of osteoarthritis. So this was a short and presentation of S-etodolac. I like to thank all the organizers for today's event. Thank you very much.
Thank you very much, sir, for your nice presentation. We will go for the next, that's a word of thanks. I would like to thank the organizing committee of Bengaluru Traumacourse 2021 hybrid, which was hybrid, with a very good evening to all. I would like to thank the delegates and the participants, both online and offline, for participating in Bengaluru Traumacourse 2021, and all the distinguished dignitaries assembled here. And the foremost, I would like to thank our international faculty, Dr. Krettek, Dr. Thomas Randau, Dr. Elmar Herbst, and for their nice talks on the topic and sharing their wisdom. I would like to thank our national faculties also, led by Dr. Rajasekaran, Dr. Guruva Reddy, Dr. Adarsh, and Dr. Chaddha, who was physically present to give his lecture. And I would also like to thank the organizers of Bengaluru Traumacourse, led by its president, KOA, Dr. H.S. Chandrasekhar, and organizing secretary, Dr. Satish Revagar, and the scientific committee led by Dr. Rajanaik, Dr. Uday Kumar, Dr. Ajit Kumar. And I would like to thank the other office based like Dr. Rajendra and Dr. Ram Subbareddy. And also I would like to thank Dr. Nikhil Kulkarni for giving his good talk on behalf of MQ. And also I am with a special thanks to MQ, Zenex, and led by its ever my good old friend Dr. Satish for sponsoring this event. And once again, thank for all of you for your august presence. Thank you.
Finally, from MQ side, I wish to thank all of you for attending today's event. So thank you all of you for joining right from the morning, and now it is a full house. So MQ is glad to join hands with the entire orthopedic fraternity to emphasize the importance of active lifestyle among the public and stakeholders to beat arthritis. Through this initiative, which is called as Keep on Walking, which you can see on the screen. So Keep on Walking is designed to create awareness among the osteoarthritis patients to live an active, healthy lifestyle and to reduce pain of osteoarthritis and improve the overall health. So requesting all of you to join hands and encourage us to make this initiative a success and ensure that your osteoarthritis patient keep on walking with smile. So with this, I'd like to thank all of you for joining in for today's meeting, even the national faculty who are live here and also the international faculty and all across India, and wish you a great evening ahead. Thank you very much.